this literature is evolving more in the, sorry, I got this message in here. This literature is evolving more in other patients as well, but definitely there is a body of literature that is now coming out in patients with kidney disease. I'm still not fully on board yet because I do think to do it well and to do it correctly, you have to have a huge amount of experience to put it all together. And as it evolves, as we get more and more data, I think that it is something we will definitely be using, especially as we see a lot more of these handheld devices being, available and relatively, I'm not saying that it's not expensive, but relatively inexpensive. So to be able to have that point of care, I always think that ultrasound is an adjunct to physical examination. So whatever you do in your physical examination, what your assessment is, the ultrasound should be another measure. And some of us do believe that it is, and it has really become part of the physical examination. But the data for patients with kidney disease is not as strong right now, but there are some people who are trying to put that data together. So I think it's useful. We have explored and are looking at trying to see if we can, there is again, no data on this as well, but this is something we are thinking of doing as a QI project, a quality improvement project, is to do it in the dialysis unit and see if that can help us with the amount of ultrafiltration, in addition to, obviously, most of us are using clinical parameters like blood pressure and pulse rate to dictate how much fluid we take off and dry weight for dialysis. Now in dialysis access, ultrasound again can be used at the point of care for dialysis access evaluation and cannulation. So if you have a patient that you're not sure if the patient is ready for dialysis, or if there's some issues, or if there's some difficulty cannulation, or if the patient has had a new access placed and it's been a few weeks and you want to assess if the access is ready and it's mature, then you can obviously use the point of care ultrasound at that point as well. So definitely a lot more uses than we are using it for now currently, but that is expanding and evolving.
Thank you, ma'am, for the session. Ma'am, I have a query that are there any techniques to ease native kidney imaging for obese patients?
So definitely a good question. It's very hard when the patient is obese. I listed some of the maneuvers that I use personally. So if the patient is, now keep in mind that when you're trying to look at the kidneys, you're going through the ribs. A lot of the people who are obese, they have, more of, if you turn them to their side, or if you actually have them raise their arm, because a lot of the fat is abdominal, you can actually displace it quite a bit. So if someone is morbidly obese, I just would say that the images, if I find that the images are inadequate, I'll usually in the report put in a little disclaimer that the images were inadequate and we recommend additional imaging based on what we find. But when the patient, if the patient is mobile, so again, in the ICU, it's a little bit harder because you can't move your patients back and forth. But in the ambulatory setting, it is much easier to move your patients. And because you're coming in through the anterior or even the mid for the right side, and on the left side, you're mid to posterior, and the fat in obese patients tends to be, more frontal, you can move them to the side, you can have them lift their arm above their heart, and you can try to displace that so you can get better images. But if you have too much of rib crowding and it's not very visible, I think you should very clearly state that in your report as well, that you were able to get only suboptimal images. So if there's any clinical concern, that does need to be evaluated by a different modality.
Thank you, ma'am.
One question I have for you. In CKD patients, most often we say that the kidney is echogenic.
I'm sorry, I can't hear you.
Regarding echogenicity of the kidney matter. So sometimes in clinical scenario, this is, hello, good morning, ma'am.
Yeah, I can hear you now.
Echogenicity of the kidney. Regarding echogenicity of the kidney, sometimes patients creatively ache, but we see that the echogenicity is being mentioned normal, CMD is normal. So we do ask our radiologists to cross check, but they say no, we are sure that it looks normal. So how do we go about it?
So I think you have to keep in mind that the ultrasound is an adjunct to physical examination. So if you are thinking it's an addition to whatever you're using in your thing. So if you think that the patient's labs are correct, echogenicity is not specific for chronic kidney disease. So there are patients with chronic kidney disease where I read the ultrasounds, I do the ultrasound, and I say that the kidney structurally looks normal. That doesn't necessarily, so again, there is a correlation, and most of the time a chronic kidney disease patient does have echogenic kidneys, but that's not necessary and it's not specific either. So there is some literature as well as some data. We just are writing a core curriculum on ultrasound for AJKD, and we have quoted some of that literature in there where the echogenicity is not specific. So if I see there are patients with AKI sometimes with acute kidney disease where you see the kidney and it looks really echogenic, and if it's large and echogenic, you sometimes think that might be ATN, but if it's small and echogenic and it really is what you see, but how you correlate it clinically. That's why right from the beginning, what I always say is that a nephrologist, understanding the ultrasound does make us a better nephrologist, but the ultrasound is not, it doesn't stand on its own. It's really an adjunct to everything else that you do.
What is the percentage, ma'am, where we get different echogenicity even though it is normal? What is the percentage of that finding?
Oh, what is the percentage of people who have normal? I don't know the answer to that, but that's a good question. I'll look it up, and if I find it, I'll email some of the WIN people.
Thank you.
Madam, have you looked into the entity of fatty kidney by sonography?
I'm sorry, I can't hear. Would you come to the mic, please?
Have you looked into the entity of fatty kidney by sonography? Fatty kidney.
Fatty kidney, ma'am. Fatty kidney via ultrasound.
By ultrasound? I mean, no, I don't think that you can really, like you're talking about like a fatty liver, sort of. I would just change the echogenicity. I've never labeled a kidney as a fatty kidney.
Regarding renal dialysis, there are patients who cannot lie down. If we do sitting biopsy for those cases, there is a difficulty in holding the probe. So, is there any other method other than sitting? Is there any lateral development posture we can do biopsies? First question. Second is there any like we do shear wave elastography for liver fibrosis, where we, in case of cirrhosis, is there any method where we can remove the like fibrosis content in this person?
I'm sorry, I'm going to stop you right there because I just texted them. I cannot hear the question unless someone is on the mic.
So one thing is that he's asking that in case, is there any lateral decubitus method that we can use for taking kidney biopsies in case the patient is not able to lie down supine? And the second question is like how we check liver for fibroscan. Is there any way we can check kidney fibroscan to see for the shear wave elasticity of the kidney?
So for the first question, definitely. So I think you're talking about doing a kidney biopsy, perhaps in a pregnant patient or someone who's in the ICU. So again, there are two different ways to do the kidney biopsies. And obviously, way back when I trained in India, we did, and I'm talking very long time ago, but we used to do blind kidney biopsies where we would just go in with the Wim Silverman needle and watch it, until it started moving with respirations. That was 25 years ago. We would do that. And that's definitely one way to do it. I think we did it very successfully without many complications. But with the use of ultrasound, there are a couple of different ways that you can do a kidney biopsy. And so one way to do the kidney biopsy is if the patient is actually lying prone, and you can use the ultrasound to mark the kidney. So what you do is you find a perpendicular distance. So you're going perpendicular to the floor and you mark it in the longitudinal as well as the transverse. And once you have that cross section, you can go straight down because you've already marked the kidney and you've marked where it stands with inspiration or expiration. So that's what I call a quasi real-time guidance. For the real-time guidance, that's when you would use it when you are not able to have the patient in a prone position. So if the patient is in the supine, you really want to be able to watch, but keep in mind that you can't really see the whole part of the kidney, as the whole part of the needle as it goes through. So you do have to be very careful when you do that. And of course, you would do that. Again, I always sort of teach that is that the kidney biopsy is not it's not essential. It's never an emergency. So in the right setting, and there are a few situations where you do have to do a kidney biopsy in a patient that is either intubated or the patient may be pregnant. That's the two scenarios that come right to mind, where you would actually do it under real-time guidance. So you would have the probe and you would be watching, and it's actually the artifact from the needle that as it moves through the tissues. That's a very critical point to remember, that you're not actually visualizing the entire needle, you're visualizing it, the reverberation through the tissues, and you can do the kidney biopsy in a lateral position as well. And what was the second question?
Like how we have FibroScan for liver, do we have something similar for the kidney, like to see for the shear wave analysis?
Yeah, so I think you do more like a functional, like a MAG3 scan, if you really want to see that, because again, what you're looking at the kidney with the ultrasound or other imaging techniques is more a structural thing. So when you really want to get to the point of where you're doing a functional scan, then that would be something completely different. But the ultrasound is good enough to give you answers to a lot of your clinical questions. And again, keep in mind, the ultrasound is not a panacea, right? It's a addition to everything else that you do.
Thank you, Dr. Vandana.
Thank you for having me. Any more questions?
Thank you, ma'am. If there are any more questions, I think we can mail you and then we can
Okay.
answer. Thank you so much, ma'am.
Thank you very much for the invitation and good luck with the rest of the conference.
Thank you,
Thank
ma'am. Thanks to the chairperson for the wonderful insight on focus. Moving on to our next session, the topic is what is known about CKD of unknown origin. And I would like to invite on stage the chairpersons, Dr. Gomti, Professor and Head of Department, Government Medical College, Alapi, Dr. Anupama, Consultant Nephrologist, Shivamogga, Dr. Indumati, Consultant Nephrologist, Savita Medical College, Chennai, Dr. Shakuntala Modi, Consultant Nephrologist and Transplant Physician, NU Hospital, Bangalore. And now request our chairpersons to introduce the speaker. Good morning, everybody. The chronic kidney disease of uncertain etiology, or CKDU, is a disease which has troubled us, which has more questions than answers over the last 2 decades since it has been reported first. And to tell us what is known about CKDU already, we have Dr. Indu Ramchandra Rao. She is Associate Professor in the Department of Nephrology in Kasturba Medical College, Manipal. And a lot of hypotheses around the etiology of CKDU, and it will be interesting to know what is the current status of the etiology.
Good morning, everybody, and thank you for giving me this opportunity to speak before you all today. So today I'll be talking about CKDU. So as you all know, there's really not much that we know for certain about this disease. So what I'll discuss today is what is widely accepted about this disease, what are some areas of controversy and uncertainty, and also I'll try to discuss a few recent developments that have occurred in this area. So the slides are not moving. Can just somebody Yeah, all right. So this is what I'll be discussing today. So what is CKDU? Who does it affect? Is it a single disease or a group of different diseases with some shared characteristics? What could the possible causes be? Can it be attributed to a single cause or is it multifactorial? And finally, what can we do about it? So CKDU, I think, can be best defined as a diagnosis of exclusion that refers to CKD without an identifiable risk factor or etiology, such as diabetes, hypertension, glomerulonephritis, and so on. So as you can see on this slide, there are several terms by which this disease has been referred to by. So for example, in Sri Lanka, the commonly used term is CNAC, or chronic interstitial nephritis in agricultural communities. This is of course based on the population that it affects. It's also sometimes been referred to as nephropathy or kidney disease of unknown cause in agricultural laborers. Other terms are chronic kidney disease of non-traditional causes and CKD of multifactorial origin. This last one again assumes that there is no single cause to it and that it is multifactorial. So the ISN has adopted the term CKD of unknown cause, or CKDU, because this is the most agnostic terminology. So this is what I'll be using throughout my presentation. So this is a map showing the geographical distribution of CKDU hotspots across the globe. So the countries which have been marked with an asterisk like this one are emerging hotspots. So there's really not much evidence. We really don't know for sure whether these are indeed hotspots. So what I'll be focusing on today are the three most well-described endemic nephropathies for which we currently do not know the etiology. So that is Mesoamerican nephropathy, CKDU in Sri Lanka, and of course, CKDU in India. So coming to Mesoamerican nephropathy, the first report came out in 2002 when Trabonino et al. Found that almost 2/3 of patients who were recently initiated on dialysis in El Salvador had no known risk factors. Almost all of them are male and involved in some sort of agricultural work. And subsequently, similar reports started emerging from other areas along the Pacific coast of Latin America. You can see here marked in this light orange. So from regions such as Costa Rica, Nicaragua, Honduras, El Salvador, and Guatemala, with a prevalence varying between 10 to 42%. Just to give you an idea of the burden of CKD here in Chichigalpa, which is the epicenter of the Nicaraguan epidemic, 1 in 3 men had end-stage kidney disease. And so this region has earned the unfortunate moniker of La Isla de las Viudas, or the Island of Widows. Coming to Sri Lankan nephropathy, the worst affected region here is the North Central Province, or the NCP, that you can see here marked in this red color. But now this disease is spreading at an epidemic scale to adjacent areas as well. So now it involves almost a third of the small island country. An estimated 60,000 cases have been reported, with nearly 20,000 deaths occurring yearly. Coming finally to CKD in India, Uddaram nephropathy. So we've all heard of it. It's been in the news for the last few years. So unpublished reports indicate a prevalence of as high as 50% in this area. It was first reported in the 1990s, and by 2015, there were an estimated 34,000 cases, with approximately 4,500 reported deaths due to CKDU in this region. Very recently, another CKDU epidemic, CKDU hotspot has been identified in South India, in Tamil Nadu, in fact, and this has been termed as Tondaimandalam nephropathy. There are several other hotspots across India as well, but there's not really much data from these areas, so we really can't be sure whether these are indeed hotspots. So what do they all have in common? So for one, they all occur in tropical climates. So the region between the equator and the Tropic of Cancer, they commonly occur in rural settings. The affected population is generally male, belonging to agricultural communities. Hypertension is either mild or absent. There is little to no proteinuria, and typically the urine sediment would be bland. On ultrasound, one would find shrunken kidneys, and on biopsy, there would be evidence of chronic tubular interstitial nephritis. Some other commonly described findings are hyperuricemia, which has been described in almost as high as 75% of these patients, hypokalemia and hyponatremia. This disease is typically silent in the early stages, and so would present only when patients come to you with end-stage kidney disease. So there's so many similarities. So does this mean that we are dealing with a single entity? It's really too soon to say. Although there are several similarities, there are certain differences as well. For example, the Mesoamerican nephropathy, the most affected population are the sugarcane workers. although this disease has also been described in miners, construction workers, and brick makers. In Sri Lanka, it is the paddy farmers which are most affected, specifically those who are engaged in chena cultivation, which is a type of slash and burn agriculture. Uddanam is a region well known for its cashew and coconut plantations. The most affected population here are manual laborers or farmers. Coming to the male to female ratio, in Mesoamerican nephropathy, the affected population is predominantly male. The ratio is somewhere around 3:1. Whereas in the Asian variants, the gender distribution is somewhat more balanced. The male to female ratio is about 1.3:1 or 1.5:1 in that range. So it's still more common in males, but it's a bit more balanced than the Mesoamerican variant. An acute form of Mesoamerican nephropathy has been described. This acute form is not as well described in the South Asian variants. There is some evidence from Sri Lanka, but there's no evidence whatsoever from India. So in this acute presentation, patients would present to you with acute kidney injury, fever, nausea, vomiting, backache, muscle pains, leukocytosis, and leukocyturia. And when biopsy, there would be evidence of acute tubular interstitial nephritis. And there is always a background of chronic inflammation in these patients, which suggests that this is an ongoing dynamic disease process. Also very interesting is this study which showed certain extrarenal manifestations in patients with Mesoamerican nephropathy. For example, there were neurological manifestations such as abnormal tenant reflexes and sensory hearing loss. Certain vascular abnormalities were also noted on Doppler. What they described was tibial wall abnormalities on Doppler. Not really clear what exactly they meant by this. The paper is not very clear there. So there are also certain subtle findings on biopsy. For example, this systematic review, which studied 13 studies, found that CKDU in Sri Lanka had higher degrees of tubular interstitial inflammation than the Mesoamerican variant, and there was lower frequency of glomerulosclerosis and glomerulomegaly. So this figure shows the possible etiologies for CKDU. We'll go through them one by one. So let's start with heat stress. So this is the favored explanation for CKDU in Central America. So as I said before, sugarcane workers are particularly at high risk. This is because their work involves strenuous exertion. There are infrequent breaks and long work hours, sometimes averaging for more than 8 hours at a stretch. There is lack of shade and lack of access to potable water. So it's really a combination of high heat, heavy work, and insufficient labor protections. There is a practice of burning the sugarcane to facilitate cutting. This exposes the workers to additional heat from the recently burned cane, and that can actually worsen things. Moreover, experimental studies in mice have demonstrated that heat exposure and dehydration can cause chronic tubular interstitial nephritis. And lastly, CKDU is most common among those sugarcane cutters who are working at sea level, where the temperatures are higher, and is less common among sugarcane workers who work at higher elevations, where the temperatures are generally lower. So this figure demonstrates the possible mechanism of heat stress nephropathy. So when there is high heat, heavy exertion, reduced water intake, hypovolemia and hyperosmolality activates not just the RAS pathway, but also the polyol pathway, wherein glucose is converted to sorbitol and then fructose 1-phosphate. This reaction uses up ATP, so the resulting ATP depletion leads to elevated levels of uric acid, inflammation, and reactive oxygen species. And I said before, hyperuricemia has been demonstrated in these patients. Up to 75% of these patients may have hyperuricemia. In fact, uricosuriia has been reported as well. And this may explain the dysuria and graveluria that some patients complain of, something which has been described as chistata in Mesoamerican nephropathy. These workers also drink sugary drinks, and the fructose in these drinks may actually worsen this entire cycle. Moreover, these patients also may have some element of subclinical rhabdomyolysis, and this may cause repeated episodes of acute kidney injury, and this may finally lead on to chronic kidney disease. And indeed, this has been demonstrated in cross-shift studies. For example, this study, which included 189 workers who were studied before and after a shift, found that serum uric acid, creatinine, and BUN were actually increased at the end of a work shift. Another very interesting study by Kaufman et al. Included 326 patients who had a GFR of more than 60 at the beginning of the harvest season. By the end of it, almost 10% of them had developed acute kidney injury. And when these patients were followed up, even at a period of 1 year, 35% of these workers continued to have a GFR of less than 60. And indeed, we do know that global average temperatures have gone up since the past few years, since the 1880s, and almost 2/3 of this change has occurred after 1970. So around the same time that the first cases of CKDU started getting reported. And it's not just the average temperature either; it's also the extremes of temperature. So we do know that the frequency, duration, and the intensity of heat waves has been increasing. There are also certain arguments against heat stress. For example, since the 1990s, agricultural work has become increasingly mechanized, so the manual workload has drastically come down. Another thing is that CKDU has also been reported in females, and even in children, there are some biomarkers such as NCALH have been found to be elevated. So it's really not clear why heat stress should occur in this group of the population. Also, there are hotter regions across the world, but CKDU hasn't really been reported from those areas. Even in Sri Lanka, for example, it's the northern province which is hotter, but CKDU hasn't really been reported from there. It's the NCP which has been affected. And finally, the external manifestations that I described can't really be explained by heat stress. So could it be something else? What about pesticides? So this is the favored explanation for CKDU in South Asia. We all know that pesticides such as glyphosate, paraquat, and organochlorines are widely used. And an association between these pesticides and AKI has been suggested. And the emergence of CKDU in the 1990s also coincides with the increase in the use of these pesticides. So this very interesting study by Michael Holliday et al. Came out somewhere early last year. And what the authors did was compared patients with Mesoamerican nephropathy to those with CKD due to other causes, and found that exposure to any agrochemical increases the odds of having Mesoamerican nephropathy by almost 5 times. And if that chemical is specifically paraquat, the odds increases by almost by 12. And they also performed a very nice animal study wherein mice were given 10 to 15 weekly intraperitoneal injections of paraquat. And when these mice were autopsied, there was evidence of chronic tubular interstitial nephritis consistent with what was seen in Mesoamerican nephropathy. And another very interesting finding was that male mice tended to be affected faster and showed higher degrees of kidney damage compared to female mice. And a channel called as OCT2 was actually expressed at higher levels in male mice, and this channel called MATE1 was showed a lower expression. So OCT2 is an organic cation transporter which is responsible for the influx of paraquat, whereas MATE1 is responsible for the efflux. So when this channel is increased, what happens is the paraquat tends to accumulate in the proximal tubular cells. And the author said that this mechanism could explain why males are preferentially more affected compared to females. This biopsy study was by Bobat et al. Came out in 2019. It's a very interesting one. So this study actually found that in patients with diagnosed CKDU on light microscopy, the silver staining showed these silver positive granules in the proximal tubular cells. These granules were found to be lysosomes, and on electron microscopy, these lysosomes were found to be enlarged and dysmorphic and had these electron-dense aggregates that you can see here. And these findings were also seen in patients who had toxic nephropathies due to drugs such as lithium, cocaine, and so on. Similar lesions were also found in renal biopsy, renal transplant recipients. At the time of implantation, these lesions occurred in less than 10%. But at 12 months, these lesions occurred in almost 70% of these patients. So the authors postulated that this suggests that it's an acquired phenotype, and suggested that this may be because of CNI exposure based on some animal studies which showed that certain pesticides can exert a direct or indirect calcineurin inhibition. The authors postulated that it is very likely that a CKDU is a toxin-induced nephropathy, and that toxin may be a pesticide. So another study by Daniel C. et al. This came out this year, and they again found these dysmorphic lysosomes in 85% of patients in CKDU, but they also found these lesions in 47% of patients who had undergone biopsies for some other reason. So this shows that this finding is not really specific for CKDU, but it definitely occurs more commonly in these patients. So this, along with a host of other findings, can actually tell us something about the underlying pathomechanism of the disease. So this systematic review actually identified 21 cases, 21 different studies, and found that 4 of these had a strong study design, and all 4 of these had shown positive association between pesticide exposure and CKDU. Unfortunately, 3 of these 4 studies were conducted in areas which were not really endemic zones for CKDU. Moreover, each of the study showed a positive association with a different type of pesticide. Another exposure, such as heat stress, was not actually described. So coming to heavy metals next, we all know the nephrotoxic effects of heavy metals such as cadmium, lead, mercury, and arsenic. And we've all heard the story of Ita disease, wherein the Jinzu River in Japan, which you can see in this figure here, was actually contaminated by industrial effluents. And so the cadmium concentration in this river was very high. And when this water was used to irrigate rice fields, consumption of the rice led to the development of osteomalacia, bony pains, and CKD in these patients. So this was described sometime in the 1950s and is a well-known example of a regional nephropathy due to heavy metal. So, but the evidence for CKDU and heavy metals is really a bit conflicting. This study, for example, showed that the cadmium concentration in urine was significantly higher in CKDU patients. In fact, the authors also found that certain food items such as rice and lotus stem were also showed higher levels of cadmium and lead. This other study, though, studied 18 different metals in urine and also in the drinking water, and did not show any evidence of higher levels. So heavy metals apart, other suspected environmental nephrotoxins include silica and strontium. In fact, there is some data from India which shows that strontium and silica levels in water were significantly higher. Apart from silica exposure through water, another possible mechanism of exposure is inhalation. And this animal study found that silica nanoparticles which were released during burning of sugarcane could lead to chronic tubule indecision nephritis in rats. And another similar study studied the effects of these silica nanoparticles on a human proximal convoluted tubule cell line, and found that these nanoparticles inhibited mitochondrial function and reduced ATP generation. So coming next to groundwater contamination. So this study from Sri Lanka found that communities who consume water from natural springs had a lower prevalence of CKDU compared to those communities where the source of water was shallow wells. So the authors postulated that this could be because water from these shallow wells was contaminated by the chemicals from the drained irrigation water. And another study also supports this conclusion, where they found that men drinking well water had higher rates of EGFR decline. So other mechanisms such as the hardness of water, the fluoride content, and the effect of multiple ion interactions have also been postulated, but this evidence is not conclusive yet. So the other possible etiologies you can see in the figure. I'll just go through them quickly. So based on some evidence that there is some familiar clustering noted, a possible role of genetics has been postulated. So certain genes such as SLC13A3 have been found, and certain infections like hantavirus, leptospirosis, and malaria have also been postulated to be likely causative agents. And we all know the effect of NSAIDs. So NSAIDs, herbal medication, smoking, and illicit liquor are some of the other etiologies which have been put forth. So since we've not been able to identify a single etiology to this, could it be that CKDU is in fact multifactorial? So this study by Jayasumana et al. Found that the risk of CKDU was highest among those who drank well water and had a history of spraying glyphosate. And they found that this well water had significantly higher amounts of hardness and contained certain amount of heavy metals as well. So they came up with this hypothesis, where they said that when hard water was contaminated by glyphosate and fertilizers, which very commonly contain cadmium and arsenic, the intake of such water could lead to the formation of glyphosate, metal, and arsenic complexes within the circulation, which could lead to nephrotoxicity in the long run. So this study by this figure is by an article by Orantes Navarro et al., who put forth a comprehensive hypothesis which suggested that the interaction of multiple factors could influence who develops CKDU. So they suggested that an interaction of environmental toxins, occupational heat stress, social conditions such as poverty, and genetic factors, prenatal and postnatal exposures could all act synergistically to determine who develops CKDU. So finally, sorry. All right. So this is a final section. So what can we do? What can we do about it? So this very interesting study by Glasser et al. Is one of the few interventional studies which have been done in CKDU. So the authors, what they did was they implemented a water rest and shade protocol, wherein cane cutters were given mandated rest breaks, were given continuous supply of clean drinking water, and provided these shaded canopies. And in the observational cohort, before this WRS protocol was initiated, the incidence of AKI was almost 21%, but after the WRS protocol was implemented, the incidence of AKI had come down to less than 6%. And by the fourth harvest, when certain implementational issues were resolved, the incident AKI had come down to as less as 1%. Again, in this figure, you can see that the incident AKI per 1,000 workers has come down drastically after implementation of this, but we really don't know the effect on CKDU per se. So, and we of course also need to reduce the exposure to agrochemicals. And one way to at least reduce the inhalational and dermal exposure is to advise workers who are handling these chemicals to wear personal protective equipment. We also need to incentivize organic farming and discourage the indiscriminate use of these agrochemicals. We also need to provide clean drinking water. This has been done in Sri Lanka and in India also to some extent. So RO plants have been established all over Sri Lanka, and after this project was established, there is some data to indicate that the incidence of CKDU might have come down, but unfortunately we don't have any published data of 2017. So we also need to improve our understanding of CKDU and hotspots. So for that, we would first need a universal definition. So currently there are 4 different definitions that exist. We would also need to develop CKD registries, standardized data collection tools, conduct well-designed observational and intervention studies, develop biomarkers, and develop a biorepository for blood and urine. So finally, how do we treat CKDU? So there is no specific treatment for it, and the treatment would be as that of any other cause of CKD. So RRT, of course, is a big challenge at times, because the access to RRT in these areas is often very poor, and also considering the population we are dealing with, initiation of RRT can have devastating economic consequences to the patient and his family as well. So just a note on the role of RAS inhibitors and SGLT2 inhibitors. This is not really clear, because if this is a condition which is characterized by episodic dehydration, hypovolemia, and AKI, it's not really clear whether giving these drugs will be prudent. In fact, some authors do discourage use of these drugs. There's really not much evidence to support either recommendation. So I'll end my presentation with this. Thank you all for your patient listening. And once again, thank you for the organizers for giving me an opportunity to speak with you.
Thank you, Dr. Hindu, for a wonderful presentation on this very important topic for practicing nephrologists. Actually, it was earlier described in geographically distinct areas, and especially in the rural areas, the diverse regions in the world, across the world. But I think lots of reports are coming up regarding air pollution with the role of genesis of CKD. No singular cause can be identified. That is why we have postulated multifactorial etiology for the pathogenesis. So, any literature you have come across on air pollution, the level of, because most of the metros in India have crossed the permissible limits. My second question is regarding the use of biogas as fuel, especially in the rural India, in role for causation.
I'm not really sure about either of these. I'm sure that there is some studies which have found that air pollution may be linked to CKDU. I'm sure there must be some reports. I'm not able to recall, but about the biogas, I'm not really sure. I'll just have to get back to you on that one.
I want to add on two more additions. One is salt pan workers. This study has been published last month in Gate Reports. The study was done at coastal areas of India in Tamil Nadu, where near Nagapattinam. It was done for about 2017 to 20, around 400 patients, about the role of heat stress. See, most of the studies are on agricultural laborers. This is salt pan workers, where they studied the urine specific gravity and then creatinine, uric acid, and then they calculated eGFR. They found that more than 40% of the individuals were found to have reduced eGFR. So it is like it's an important study from our own place and published in reports from environmental public health of Ramachandra Medical College. Okay, and the second one I want to add on is this is again a data from Tamil Nadu done by Institute of Madras Medical College and Community Medicine Madras Medical College with the help of Tamil Nadu government. And the data has been published by the government of Tamil Nadu. What was that is they did sampling at different places, villages in Tamil Nadu, around 400 patients. And again, they found that more than 50% of the patients studied were found to have CKDU. That is very alarming, and still more lot of studies are going on. So only diabetes, hypertension and other etiologies were less than 50%.
Yes. Yes, ma'am. Thank you so much for highlighting that point. So what again I would like to tell is heat stress as a mechanism for CKDU. The data for that is predominantly from Mesoamerica. There's not much data from the South Asian countries, but I think there's one study which is ongoing, which is called Heal CKDU. I think we'll have the data from that. It's an interventional study again, similar to the one which I described earlier. So we're just awaiting data on that one.
Sri Ramachandra what she said actually tries to
heat stress.
It's a
Yes.
that, and it clearly studies only heat part.
Yes.
So the remaining areas are all you
Yes.
have combinations of the toxins as well as heat.
Yes,
So
ma'am.
this is one study.
Yes. So that is one study which has come out in heat stress from South Asia. There's not really much other data which exists as of now.
Wanted to know about this verbal like possible. Any particular insight you have into the
So we do. So there are certain review articles which have given a list of several herbal medications which can cause CKDU. We do know, we've all heard of Balkan nephropathy, where aristolochic acid in herbal medications and slimming medications caused CKD. But with CKDU, for example, there's no data on a particular herbal medication. But we do know that certain herbal medications can cause CKD in general. But
which has come off it.
okay. I'm really not sure if there's any data.
A lot of patients come with
Okay. All right.
So I think we have to look into that. What
Right.
exactly causes that, because we know the names of
Right.
and we can analyze and see what will be the components which is the causes.
Yes.
Questions to the audience.
We have noticed a similar clinical picture in few patients who are working in health countries.
Huh.
In
Okay.
outdoor
Yes.
activities, got humid climate, and those working in kitchen,
Right.
got the environment.
Right.
They consume more of aerated soft drinks rather than water. And they develop unexplained renal failure with hyperuricemia and uric acid stones. Biopsy flows classical tubular restriction disease. Exactly similar clinical picture. Actually, the study that Dr. Indu had reported from Institute of Nephrology, Madras Medical College. They have told that the chemical exposure, heat stress, and the environmental pollutants that's been found. And because of that, we are actually from the Institute of Nephrology, Madras Medical College, we are going to embark on a study where we are going to study the prevalence and risk factors of chronic kidney disease of uncertain etiology among agricultural workers in different agroclimatic zones of Tamil Nadu. So we have actually divided the whole state into 5 agroclimatic zones. And we are just going to start studies almost through, and probably in 6 months time we will actually do one study now. Then after 3 months we'll repeat, and then we'll have a lot of parameters that are going to be assessed, and we'll be able to give you the report in 6 months.
Okay.
Should we have a question?
Can you share the protocol because
Yes, madam.
that is possible, I think, just not Tamil Nadu, this is there everywhere.
Yes, yes. We just, from the government, the government's, so we have just started on that. So we share the protocol.
A question in the underprivileged rural population that are at high risk of exposure to groundwater, pesticides and heavy metals. Is there any advice, because they are not, they don't have access to our water in households. So what's the kind of simple advice you can give them that will go a long way to prevent CKD? Is there any idea?
So, for example, this one study which I quoted from Sri Lanka has found that intake of water from spring wells, spring water intake actually reduces. So that is available. So maybe some we can change the source of water. So that is something that can be done. Otherwise, largely there has to be some sort of government support and support of certain NGOs to provide clean sources of drinking water. So Sri Lanka has successfully implemented this program. I think to some extent, even India is doing it in a few places in Andhra Pradesh. I think largely, we need some sort of government support and the support of certain NGOs as well to implement this on a large scale basis. So this can be done. Sri Lanka has shown this is, definitely possible. Of course, ours is a much larger country, so it's much more challenging here. But I think it's possible with some.
We close the session at this point. Thank you, Dr. Indu, for a wonderful talk. We're touching a whole lot of etiologies. And thank you very much, Ringcon, for organizing conference.
Thank you.
Thank you, Chairperson, and thank you, Speaker, for a wonderful insight on CKDU. Moving on to our next section, the topic is multiple facets of multiple myeloma. I would like to invite the Chairperson, Dr. Shilpa, Consultant Nephrologist, Multiple Hospitals, Bengaluru, Dr. Vimala A, Head of Department and Senior Consultant Nephrology, Cosmopolitan Hospital, Kerala, Dr. Kiranmai Ismail, Professor, Department of Nephrology, Osmania Medical College, Hyderabad, Dr. Manjari Sharma, Professor and Head, Department of Nephrology, Guwahati Medical College, Guwahati.
Expanding.
I request our chairpersons to introduce the speaker.
Good morning, ladies and gentlemen. I'm extremely proud to introduce Good morning, ladies and gentlemen. I'm extremely proud to introduce our own young, brilliant nephrologist, Dr. Maitri Shankar. She'll be speaking on multiple facets of multiple myeloma. Maitri is an assistant professor in Institute of Nephrourology, Bengaluru, associate program director, Nephrology Social Media Initiative, Long Call Fellowship Instructor. She is a secretary of Win India Karnataka chapter. She has received the gold medal in DNB Nephrology and Best Nephrology Thesis Award. C. Jason Best Visual Extract Award in 2021 and NEFJC Founders Award. She is a member of ISN Education, ISN Social Media Team, and VA Editorial Board. She has published more than 960 national and international publications. Over to Dr. Maitri.
Thank you, Dr. Shilpa. Thank you, Dr. Shilpa Shaktiman, for that kind introduction. So I'll be talking on multiple facets of multiple myeloma and kidney biopsy today. So this is the brief overview of my talk. We start off with epidemiology, followed by pathogenesis, the diagnostic criteria, classification, and treatment. Multiple myeloma essentially constitutes 10% of all hematological cancers. The median age of occurrence is around 70 years. In Indian population, it is around 60 to 65 years. But it can also occur in middle-aged population, like at around 40 years. So we cannot totally disregard the possibility of multiple myeloma in a middle-aged patient. Certain individuals have genetic mutations, which confers them at higher risk of acquiring multiple myeloma. Kidney diseases are one of the most common complications of multiple myeloma.
50% of the patients with multiple myeloma develop AKI or CKD during the course of the illness. 20% to 50% have AKI or chronic kidney disease among the newly diagnosed cases, and 1% to 3% have severe kidney injury requiring kidney replacement therapy. So what is this monoclonal gammopathy? It is the overproduction of the monoclonal immunoglobulins that is detectable in the serum or the urine. This is because of the clonal proliferation of the immunoglobulin producing plasma cells or B lymphocytes. So these plasma cells predominantly produce immunoglobulins, IgG, when compared to other immunoglobulins like IgA, IgM, and so on, and free light chains. The B cells and lymphoplasmacytic cells predominantly produce IgM more than IgG. So when I say clones, it essentially means plasma cells, B cells, and lymphoplasmacytic cells. And monoclonal proteins are the abnormal immunoglobulins and free light chains. There are certain terminologies: paraproteinemia, M protein, monoclonal gammopathy, dysproteinemia. They're broadly the same, and these terminologies are usually used interchangeably. So multiple myeloma actually starts off as MGUS. MGUS is monoclonal gammopathy of undetermined significance. That is when M protein is less than 3 grams per deciliter and the plasma cells in the bone marrow is less than 10% without any organ damage. So the stage of MGUS lasts for 10 to 15 years. Then it moves on to smoldering myeloma and then finally multiple myeloma. So these stages are called as myeloma continuum. So what is the diagnostic criteria for multiple myeloma? This was proposed by the International Myeloma Working Group, according to which the clonal plasma cells in the bone marrow should be equal to or more than 10%. And then we should have one of the following myeloma defining events, that is the CRAB criteria. C stands for hypercalcemia, R for renal insufficiency, A for anemia, and B for bone lesions. Also, there are certain biomarkers of malignancy which suggest multiple myeloma, such as the clonal plasma cells in the bone marrow being more than or equal to 60%, and ratio of involved to uninvolved free light chains of more than 100, and more than one focal lesion on MRI. We all know that certain hematological conditions are associated with kidney diseases, like the malignant forms of plasma cell dyscrasias, multiple myeloma, and Waldenström macroglobulinemia, and also the malignant forms of B-cell proliferative disorders like CLL and B lymphoma. But over the last decade, there have been many pathological studies and also clinical studies which has shown that even the non-malignant or the pre-malignant conditions of plasma cell dyscrasias and B-cell lymphoproliferative disorders can cause kidney disease. So these are called as monoclonal gammopathy of renal significance. So what are the clues to a nephrologist to suspect multiple myeloma? Whenever there is a CKD or acute kidney injury of unknown cause, when anemia is out of proportion to kidney dysfunction, when a patient has hypercalcemia and hyperglobulinemia, if supposing a patient is a diabetic and he comes in with a history of very short duration of diabetes without any albuminuria, he presents with rapidly progressive kidney failure kind of a syndrome, then you can suspect Cas nephropathy in him. Failure to diagnose multiple myeloma not only leads to delay in treatment, but if we go ahead and if we transplant him, there are high chances of early recurrence and graft loss, and because of which it can lead to medical legal issues as well. So this is the pathophysiology of AKI and Cas nephropathy. There's excessive production of the free light chains, which gets filtered by the glomerulus. This is picked up, I'm not sure. So this is these free light chains are picked up by the tubulin megalin complex, which is present in the proximal tubular cells. They get endocytosed and they get catabolized in the lysosomes. This is the natural process. But when there is excessive production of these free light chains, there is excessive endocytosis, which activates the pro-inflammatory and pro-fibrotic pathways, leading to tubular cell apoptosis and fibrosis. And some of these free light chains which escape the proximal tubule, they reach the distal tubule, they combine with the TAM-Horsfeld protein there and they form a cast. This cast is obstructive in nature. So the area that is the tubule which is proximal to the cast, that undergoes atrophy, and because of which there's leakage of the ultrafiltrate, again, pro-inflammatory state and pro-fibrotic state. So there are certain potential triggers for this cast formation, like dehydration, use of diuretics, contrast agents, and infection. So we have to make sure that we avoid these situations like dehydration, use of diuretics, use of contrast agents, and infection in a patient with multiple myeloma. Depending upon the physicochemical properties of the immunoglobulins and light chains, like whether they are hydrophobic or hydrophilic or abnormal glycosylated, positively charged, they can either get precipitated or aggregated or crystallized or misfolded, like in the amyloidosis, and they can cause various renal pathologies. There are two main mechanisms that can explain the kidney injury. One is the direct deposition of these monoclonal proteins, and then second one is the indirect effects of the monoclonal proteins, such as complement activation in C3 glomerulopathy, endothelial injury causing thrombotic microangiopathy, and excessive activation of VEGF, which causes the Poem syndrome. The diagnosis of multiple myeloma is essentially a multi-specialty collaboration. A nephrologist and a hematologist suspects multiple myeloma, and a pathologist confirms it with either a kidney biopsy or a bone marrow biopsy. Coming to the investigations, serum for protein electrophoresis, this picks up intact immunoglobulin. It does not differentiate between monoclonal or polyclonal protein. It is not very sensitive. When you look at serum immune fixation electrophoresis, that is more sensitive. It subtypes the immunoglobulin also, and it can pick up the type of free light chain also. Urine immune fixation electrophoresis, we need 24-hour urine collection for this particular test. We cannot use random or spot urine sample for this particular test because the results are not validated. Coming to serum-free kappa and light chains, it is best that it is taken along with serum immune fixation electrophoresis or serum protein electrophoresis and not as an individual test result, because it has a high false negative rate, and it is not diagnostic, but we can use it for prognosis. It can be used for follow-up and treatment. Urine for kappa and lambda light chain tests are not recommended because again, the inter-individual variability is very high. The kappa light chain has very low molecular weight of only 22.5 kilodaltons, while the lambda light chain has a molecular weight of 45 to 50 kilodaltons. So in normal population, the free kappa to lambda ratio is 0.26 to 1.65. What happens in kidney dysfunction? As we all know, as already told, the free light chains are filtered by the glomerulus. They're picked up by the proximal convoluted tubule and they get catabolized there. So in kidney dysfunction, there is an increase in polyclonal light chains and lambda light chains, leading to increase in the serum free light chain ratio. So in kidney dysfunction, the normal ratio also is increased to 0.34 to 3.1. As you can see in the graph here, as the stages of CKD goes on increasing, the serum free light chain ratio is also increasing. If you look at the sensitivity of monoclonal protein testing, serum immune fixation electrophoresis, as I mentioned, is more sensitive when compared to serum protein electrophoresis. But a combination of tests such as serum protein electrophoresis, serum immune fixation electrophoresis, and serum free light chain assay has a higher sensitivity when compared to single individual test alone. Coming to urine examination, Bernstein's proteinuria is not picked up in dipstick because dipstick is sensitive to albumin. And we see large discrepancy when we do 24-hour urine protein or PCR versus ACR ratio. Urine protein electrophoresis is also helpful. Some patients may have both Bernstein's protein as well as albumin, such as in patients with amyloidosis and MIDD. This is international staging system for multiple myeloma based on serum albumin levels, beta-2 microglobulin levels, cytogenetics, and the LDH values. So when do we perform kidney biopsy in a patient with multiple myeloma? Whenever there is a persistent increase in serum creatinine levels, when there is albuminuria, and when you're suspecting paraproteinemia, it is essential to ask for Congo red staining. Of course, immunofluorescence with anti-kappa and anti-lambda, and electron microscopy is also very useful. Biopsy is usually useful for prognosticating in a patient who is already diagnosed with multiple myeloma. Coming to the types of kidney injury, we can classify the types of kidney injury based on whether it is paraprotein dependent injury, paraprotein independent injury, or a combination of both. Paraprotein dependent is most common, 78%. Among this, we have Cas nephropathy, which is leading, followed by monoclonal immunoglobulin deposition disease and AL amyloidosis. And we have paraprotein independent cause, 24%, because of hypercalcemia, hyperuricemia, volume depletion, sepsis, drugs, nephrotoxic drugs like NSAIDs, chemo, plasma cell infiltration, and so on. Usually it is a combination of these factors rather than a single factor alone. And we also can get combination of paraprotein dependent and independent factors, and we can also have multiple lesions in the kidney biopsy. There is another classification based on the site of deposition of monoclonal proteins. If you look at doses and MIDD, we see deposits everywhere. It affects the vessels, the glomerular basement membrane, and the tubular basement membrane. The glomerulus is most commonly affected by the intact immunoglobulin, which has very high molecular weight. So it gets trapped in the glomerulus and it causes diseases like PGN-MID, immunotactoid, fibrillary GN, and cryoglobulinemia. So these patients present to us with proteinuria, oliguria, and volume overload, hypertension, something like acute nephrotic kind of a syndrome. Whereas if you look at light chains, they easily get filtered and they're reabsorbed in the proximal convoluted tubule. They affect the tubules more. So they cause this light chain proximal tubulopathy and crystal storing histiocytosis. So they predominantly affect the tubules. So they come in with clinical symptoms of electrolyte disturbances, polyuria, glucosuria, and so on. We can also classify based on the syndromic presentation, as I just mentioned. Cast nephropathy and non-paraprotein related kidney injuries such as sepsis and hypercalcemia can come in with acute kidney injury. Rapidly progressive kidney failure, cast nephropathy and PGN-MID. MIDD and amyloidosis may present as nephrotic syndrome. Again, if not detected at the earlier stages, they may progress to CKD. Fanconi syndrome usually presents with electrolyte disturbances. So cast nephropathy, mostly non-oliguric, normal kidney size with inactive urine sediment. This is a light microscopy image wherein you can see PAS negative myeloma casts here. This is picking up the PAS stain because this is TAM-Hosfil protein. And here we can see a dense cast which is fractured with chain cell reaction at the lower down. Immunofluorescence showing lambda positivity in this picture in the cast. So again, another classification, as I already mentioned, is based on whether the injury is because of the monoclonal immunoglobulin deposits or non-monoclonal immunoglobulin deposits. Under monoclonal immunoglobulin deposits, we have organized and non-organized deposits. And under non-organized deposits, we have MIDD and PGN-MID. Monoclonal immunoglobulin deposition disease, there are three types: light chain, heavy chain, light and heavy chain. Light chain deposition disease is most common, presents with proteinuria and kidney dysfunction. In light microscopy, there is mesangial proliferation, Congo red negative, nodular glomerulosclerosis, and thickening of glomerular basement membrane and tubular basement membrane thickening. Immunofluorescence, there is deposition in glomerular basement membrane and tubular basement membrane, mostly kappa. And electron microscopy again shows deposits everywhere. Under fibrillar, we have amyloidosis. Amyloidosis usually presents with nephrotic syndrome 75% of the time. Kidney dysfunction is seen in 50%. Extrarenal involvement is common in amyloidosis, especially the involvement of heart and liver. So this is a light microscopy image, which is a weakly PAS staining and early nodular appearance kind of picture, and Congo red staining with orange red deposits. And this one is, and this is under polarized, non-polarized light, and this is under polarized light where we can see apple green birefringence. Strong staining for lambda, kappa is weak, and electron microscopy showing random fibrils of approximately 10 nanometers in diameter. Crystalline deposits, we have light chain crystal proximal tubulopathy, crystal storing histiocytosis. Light chain proximal tubulopathy is most common among these. Again, they present with proteinuria, glucosuria, and polyuria. Because of hypophosphatemia, patients may have bone pain and fractures. And hypokalemia, patient may present with paralysis or quadriparesis. Light microscopy shows proximal tubular swelling. Immunofluorescence is mostly positive for kappa. Non-monoclonal immunoglobulin deposits can cause diseases such as C3 glomerulopathy, TME, and Poem syndrome. C3 glomerulopathy with monoclonal gammopathy usually presents with proteinuria, hematuria, and low C3. the monoclonal protein behaves as an autoantibody to the C3 convertase or autoantibody to the complement regulating proteins, which leads to the activation of the alternate complement pathway. On light microscopy, we see MPGN kind of a pattern, and immunofluorescence shows granular C3 positivity. This is a data from the French national cohort, wherein they looked at 201 C3GN patients, out of which 20 patients had multiple myeloma and 30 patients had monoclonal gammopathy of renal significance. So C3GN is mostly associated with MGRS than with multiple myeloma. And you can also see in the graph here that the patient survival and the renal survival both are poor when C3 glomerulopathy is associated with monoclonal gammopathy. So if you look at 100 cases of light chain nephropathy, 99% of them will have multiple myeloma because of the high tumor burden. And that's why it is called as myeloma defining event. Whereas if you look at the other diseases, they are more commonly associated with monoclonal gammopathy of renal significance than multiple myeloma per se. Coming to the treatment of CAS nephropathy, we have to optimize the hemodynamics and the intravascular volume, withdraw nephrotoxic drugs, treat hypercalcemia and hyperuricemia, avoid loop diuretics because it might precipitate the formation of the CAS. Paraprotein independent acute kidney injury, we just have to treat the cause and it is largely reversible. Coming to extracorporeal light chain removal, two types have been well studied now. Of late, there have been other modalities as well. Plasmapheresis, this is usually used in CAS nephropathy, but the largest randomized controlled trial, which looked at 90 patients, did not show any benefit because the rationale is that the light chains are present both in intravascular as well as extravascular compartments in the same concentration. If at all you want to try plasmapheresis, then the idea would be to give daily plasma exchange till the free light chain levels reduce to less than 15 grams per deciliter, and then as and when required till chemotherapy takes effect. High cutoff dialysis. This high cutoff dialysis has a very large pore size of 45 to 60 kilodaltons. There are two randomized controlled trials that have been quite famous. One is the Meyer trial and the other one is the EULITE trial. Both were multi-center randomized trial in biopsy-proven myeloma CAS nephropathy patients requiring hemodialysis. All the patients were given bortezomib and dexamethasone, but there was no difference in mortality in the Meyer trial, and in contrast, in the EULITE trial, there was increased mortality in high cutoff hemodialysis group at 2 years. So there is no guidelines or a conclusive benefit of high cutoff dialysis in CAS nephropathy. Treatment of AL amyloidosis, we classify the patients as low risk, moderate risk, and high risk based on the involvement of the heart, age, involvement of other organs, and the physical performance. And mostly the treatment is based on bortezomib-based chemotherapies and immunomodulatory drugs. So post-bortezomib era has been very promising. There have been many trials which has shown very good renal survival and mortality benefit. There is a huge list of new chemotherapeutic drugs that has come up, and I think the hematologists will be the best people to consult and decide on which chemo drug is best for our patient. And these chemotherapeutic drugs can also be used in CKD patients and patients who are on dialysis. How do we assess treatment response? We look at hematological response with serum free light chains and serum and urine immune fixation electrophoresis. Renal response with serum creatinine levels and urine protein excretion. Transplantation in such patients, the idea is that we have to clear the monoclonal proteins with either chemotherapy or autologous stem cell transplant prior to kidney transplant. And the patient should be fit with sustained myeloma control for 2 years following autologous hematopoietic stem cell transplant before we go ahead with kidney transplant. So this was our multi-center data from Dr. Urmila Madam's institute, Dr. Swarnalatha Ma'am's institute, and our institute, where we looked at patients who were diagnosed with multiple myeloma and the kidney biopsy findings in 61 patients. Most commonly, it was in the males, and CAS nephropathy was the most common lesion in kidney biopsy, followed by MIDD and amyloidosis. The factors associated with the requirement of kidney replacement therapy were high free light chain levels, CAS nephropathy, acute kidney injury, and rapidly progressive renal failure kind of a presentation. So this has been published ahead of print in Indian Journal of Nephrology. So this ACKD visual abstract essentially sums up my talk. So increased production of monoclonal immunoglobulin or proteins can cause tubular injury and glomerular injury. Under tubular injury, we have myeloma, cast nephropathy, light chain proximal tubulopathy, and crystal storing histiocytosis. Under glomerular, we have organized deposits, non-organized deposits, crystalline deposits, and miscellaneous causes. Thank you.
Thank you, Dr. Maitri, for very excellent elaboration on multiple facets of multiple myeloma. I have seen a study where mention about the various presentation of multiple myeloma. Is there any correlation between diabetes and the comorbidity for developing multiple myeloma? Did you find any evidence?
In our
And what was the presentation of those diabetic patients who were diagnosed with multiple myeloma?
diabetic, we had comorbidity was there, but it was not significantly associated with the disease per se. So usually diabetics, if they're present, they used to present as short duration of diabetes with rapidly progressive kidney dysfunction kind of a thing. Some patients with diabetes have also come with nephrotic range proteinuria, like massive range of proteinuria, more than 8 grams, where we go ahead and biopsy and we see underlying amyloidosis as well. So there is no, in our study, we did not see any particular association between diabetics and multiple myelomas. They can present with myeloma cast nephropathy, they can present with amyloidosis as well.
Actually, we have also conducted one study in my department. So what we have seen in those diabetic patients, they presented with myeloma cast nephropathy, number one. In those patients, microscopic hematuria was small. The eGFR decline was very rapid. And then the outcome was poor in those diabetic patients.
Outcomes we could not assess because we referred to hematology department, so we could not assess the in these patients.
We follow those patients for around 6 months to 1 year, and this was the result of our finding. Thank you so much.
Thank you, Dr. Maitri, for that comprehensively. Have few questions to ask. How many of your patients presented with renal failure and retrospectively you may like myeloma?
46%. 46%. Yeah.
Renal failure.
Yeah, correct.
Second question is, my experience so far, erectile disturbance has been the most common cause of fertility, like hypercalcemia. You showed cast nephropathy. So what was your experience with electrolytes and the chemotherapeutic agents used for multiple myeloma?
The electrolyte imbalance, what happens in our population is they usually come to us very late. They usually come to us at the stage of cast nephropathy. So probably 30% of them had hypercalcemia. But if you look at Fanconi syndrome, it was very rare. We hardly found, because I think they don't come to us very early and we don't pick up those electrolyte imbalance like phosphaturia and hypophosphatemia. Hyperuricemia and the hypercalcemia, that was there. Like 30 to 40% of them had. But Fanconi syndrome per se, proximal tubulopathy, it was very rare.
That was a lucid presentation. I have a question. In your study, did you chance upon using the denosumab in your patients?
Denosumab, no matter.
When you get a patient or say API or unexplained CKD and CRAB symptoms positive, how do you go about testing? What's first and for CRABs and not possibility? How do you go about testing? Do you send first SPED, wait for the results, or nowadays that myeloma panel is coming with all the tests, you go directly for that?
We ask for whatever tests I just mentioned. We ask because a combination of tests are more sensitive for diagnosis. And even if the patient is diagnosed with multiple myeloma, we go ahead and do the kidney biopsy because, as I said, there are multiple facets of multiple myeloma and different diseases have different prognostic prognosis. So we go ahead and biopsy even if the patient has got multiple myeloma. And we try to get all the tests that I mentioned because of the increase in sensitivity levels.
You go for all the
Yeah,
tests, not one by one. Regarding the role of plasmapheresis in patients with cryo-associated cryo-TN myeloma or extensive thrombotic lesions, complications.
We haven't come across me. We haven't tried plasmapheresis. We haven't tried plasmapheresis.
another area which I think your presentation didn't bring up, because now we have many survivors post myeloma. And as you see, over a period of time, they develop progressive renal failure. They have myeloma, they get treated, renal failure improve, then over a period of time, they develop chronic illnesses. We have quite a few biopsies where they have shown extensive extension nephritis after being treated for myeloma and have recovered from their hematological malignancy. So I think that's another facet we have to do in chronic kidney disease. It mentioned that treated myeloma patients who are now surviving longer.
Because of chemo drugs and.
And we have to biopsy it because then it becomes a chronic kidney disease of unknown reason, because multiple myeloma is treated. And some of the drugs, lenalidomide, have been shown to be very good drugs over a period.
We have a series of cases which we have presented in IGN, where we have multiple myeloma survivors who have gone through kidney transplantation after an autologous bone marrow transplant, and they are doing well. We have a young girl who had multiple myeloma, lost her kidneys. She went through autologous transplantation, one kidney transplant that failed because of rejection, and the second transplant, and she's doing well. So it's a series which is published in IGN. When can we go for transplanting MGRS progressing to ESRD? What is the current specification?
MGRS, again, MGRS we have to treat. So the patient has to be disease free but why do you have to go for transplant? You can try with chemo drugs.
Yeah, not responding to chemotherapy progress to ESRD. What is the outcome monitor? What is the timeline and we have to wait?
Probably 2 years. Hematological para.
I transplant the kidneys in a person who has an untreated disease. So you need to look into both together. Like if your NGRS is not treated.
NGRS is treated with BCG protocol, but he has progressed over time over 2 years, 2 years. Can we wait for a transplant because we don't have these urologic markers where we can tell that he is a patient.
Actually, NGRS is a story from 2012 onwards. And I don't think that there is yet any, there are 2 or 3 types of NGRS which has very poor prognosis. And irrespective of the bone marrow manifestation and all, they progress to the proliferatory variety and all. But I don't think there is any report of NGRS receiving kidney transplantation and doing well.
Actually, we had one case like that. It was PGN-MID, and we did not know. It was like you said, it was CKD when she presented to us, and we transplanted, and then it relapsed immediately after transplant. And she was on plasmapheresis. On every like weekly once plasmapheresis we had to put her on. So that is the situation. I think better to avoid till you get him. Chances of recurrence will be very high, post transplant. So it is. No, that is MGR.
You have to look for the mutations which are led to it. You have to do a test and see the patient showing that there is no disease. Yeah,
Other not that. We have talked repeatedly regarding NGRS with hematologists.
They are not not interested. They're not. Yeah, they don't treat. Yeah.
Not at both sides. The problem with us is you have a bone marrow disease which you are not sure what's happening. And you have a kidney disease which has gone into dialysis. When you take them, if you have a monoclonality or the genetic defect which caused it, it relapse back into the.
It will relapse back. Yeah.
They are not much enthusiastic marrow transplantation.
We have all our PGN-MID patients, whatever. We are only treating because if you refer to Kidwa, I mean our oncology center, they say there's nothing there. So we have made our own protocol of bortezomib and dexamethasone alone. We're not using cyclophosphamide, but we have seen good results in whatever few patients we have.
I think the practice will differ in different centers. Mumbai, we see oncologists treating them very
Extensive transplant absolutely fine.
For MGRS.
MGRS of various types, we don't know.
You would really pick up and maybe do the
Once we
ensure
diagnose
course.
for biopsy, they are willing to help and be a part of the care.
How's this?
They will not take responsibility.
There are times we discuss whether you move both. Let's see, you're there telling.
Thank you, speakers and chairperson. So we move to our next session. Our next session is management of glomerulonephritis in pregnancy. A summary of newly published best practice recommendations. And to chair the session, I would like to call upon Dr. Narayan Prasad, Professor, Head of Nephrology, SGPGI, Lucknow. Dr. Radha Venkatraman, Consultant Nephrologist, Vijaya Hospital, Chennai. Dr. Jyoti Priya, Consultant Nephrologist, MGM Muthoot Medical Center, Pathanamthitta, Kerala.
Yeah, good morning, everybody. It is my pleasure to chair this important sessions and should I introduce?
Narayan
Am I
Prasad, sir,
audible?
we can't hear you. Can you just?
I am unmuted. Yeah, my mic
Okay.
is working.
Now we can hear you. Sir. We can hear you,
So-
sir. Thank you.
Thank you very much for this kind invitation and to be the part of this great conference, Unicon. And really, it is my pleasure to introduce Dr. Silpa Jesudasan. And we cannot have a better speaker on this topic than this. And she is really a great researcher, and her clinical research area is parenthood in kidney disease patients. So I don't think that there will be any better speaker than her on this topic. So over to you, Dr. Silpa. You can start your presentation.
Thank you very
Thank
much,
you
sir. Can you hear me?
Yeah, you are audible.
All right, wonderful. Thank you very much. I'll just share my slides now. Can you see? Can you see my slides? I will just get started. Can you see this one now?
That is visible. You can start now.
Wonderful. Thank you very much. Thank you to Win India for
They're not able to hear you, maybe you're muted.
Ma'am, we can't hear you, ma'am. One minute.
Dr. Silpa, you are not audible.
Ma'am, you are not audible, ma'am.
Hello, can you all hear me?
Yes, ma'am, yes, ma'am.
You are audible now. You can start.
Yes, thank you so much. I'll start again. Apologies for the technology issue. Thank you very much. Okay, let's try again. So I'd like to thank the organisers for inviting me to speak at this very auspicious occasion. It's a great honour to be invited. And I'm speaking to you from Adelaide, Australia, and I am really sad that I could not be there in person, but again, thank you for the invitation. So my task today is to speak about some new practice recommendations that have been published around managing glomerular disease in pregnancy. Ththese patients who come to our clinic...
Are you
able to still hear?
Sir, can you just mute current results?
थोड़ा सा 4 साल के बाद थोड़ा सा वो टायर्डनेस वाला फेस आ रहा था.
Thank you. So these patients who come to us in clinic, they're often quite frightening patients who may have had a history of glomerulonephritis or may be presenting in pregnancy with significant renal problems. And I think they can be some of the most challenging patients to look after and to get them through to a successful pregnancy outcome. Ideally, in a woman with glomerular disease, we want a pregnancy that is perfectly planned, that everything's organised, the patient is well informed, the renal situation has been stabilised, the glomerular disease is under good control and in remission, blood pressure is under good control, they're on the correct medication, everything else is being managed well, and they have a perfect healthcare system to support them as they go through pregnancy. But of course, we all know that the real world doesn't present us with this sort of patient all the time. And often we have patients coming to us with unexpected pregnancy or pregnancies when they have active disease. We know that the main risk factors for an adverse pregnancy outcome are the preconception kidney function, the amount of proteinuria the patient has, whether or not they have hypertension and how well controlled that is, and what other comorbidities they have. And this includes the type of glomerular disease that they may have. And we know that these risk factors are interactive and they accumulate and can make for some very complex circumstances when we're looking after these women before pregnancy or when they are pregnant. In reflecting on how far this field of obstetric nephrology has moved, maybe in the last 10 to 20 years, there are a number of international collaborations and initiatives that are now underway to advance obstetric nephrology training and unify our clinical practice a little bit more across the world. Because I think nobody, even in the most experienced centres, nobody knows perfectly how to look after these patients. So reflecting this, Professor Fadi Fakhouri, Professor Georgina Piccoli, who have been leaders in the field, have pulled together an international working group who came together to really discuss and write about some of the key challenges in managing women with glomerular disease in pregnancy. And this paper was published, fully published in Kidney International earlier this year, but has been available since last year. And I commend this paper to you. The scope of this paper was not an official guideline. There was no formal evidence synthesis as we would have in a systematic review or other situation, because the evidence is just not sufficient enough to make a formal guideline. Instead, these were pragmatic recommendations about clinical practice based on the literature, but also on the clinical experience of this international working group, which was multidisciplinary from lots of different regions and lots of different areas of expertise. And the actual practice guideline or practice recommendations are quite comprehensive and cover quite a lot of different areas, and there's also extensive supplementary materials. So today, in the time I have, I won't be able to go through everything. So what I wanted to do was pull out the key messages that might be that might help change your clinical practice or help answer some clinical confusion or questions that you may have when you're looking after these women with glomerular disease who want to have a pregnancy. So the first point that I want to make is in reviewing the literature for these practice recommendations, it became absolutely clear that better data is needed. We know that chronic kidney disease, if we take a step back and just look at CKD, not glomerular disease, affects anywhere between 0.3 up to 3% of pregnancies, such a wide variation. We don't really have fantastic numbers on how prevalent these conditions are in pregnancy. They're probably underestimated. Our pregnancy data sets, our hospital data sets capture these very poorly. And we don't actively look for kidney disease in this young population and certainly in young pregnant women. Often that screening is just not there. Most women won't even have a kidney function test in pregnancy until there's a problem. So we know that most of our data comes from retrospective case series. There's no clinical trials. There's very little prospective data, but this is changing. And one thing I would encourage you is if you are keeping data on patients with kidney disease in your unit, in your centre, please do try to include some information about their pregnancy outcomes, because that prospective data will be very helpful. And there are some new initiatives that are really starting to pay off in terms of our knowledge. One such example is the CURE-GN network from Canada and the US, where we've got women who are being prospectively enrolled, and now we can start to get better information about what their pregnancy outcomes are when they have glomerular disease, and more importantly, what the impact of a pregnancy might be on their GFR decline. And here's the paper that shows that if you have a complicated pregnancy, you're much more likely to have a faster decline in GFR over time. This is the critical information that we need to be able to advise our patients about pregnancy. I guess the second message that comes through very strongly is that we have shifted away from counselling against pregnancy in women who have kidney disease. We used to forbid it. We used to say, look, you mustn't get pregnant, it's too dangerous. In some circumstances, that may still be the case, but in general, outcomes have been improving. And because of this, we are respecting what we're calling reproductive autonomy for these women. And rather than saying, no, you can't do this, let's think about how this pregnancy might be, what impact it might have, and work with you in shared decision making so you can make an informed choice with your family and with your partner, and understanding the social context that you're coming from as well, and what healthcare resources are available. So the recommendations for counselling in the practice recommendations are now around shared decision making, looking at the psychological impact of these pregnancies and what it might mean for that woman to not be able to have a baby, as well as the medical aspects, and individualising the assessment of risk for each individual patient and talking to them and explaining to them what the outcomes may be. Of course, this will be very dependent on the context that the woman is coming from. Not every woman is going to be able to access the care they need to have a very complicated high-risk pregnancy, but it may be possible in some situations. So the recommendations are to assess the status of the patient in terms of their current history and really get a good understanding of what their current glomerular disease activity is like. In the case of membranous nephropathy and lupus nephritis, we now have very good serological markers that can help us assess disease activity, and these have been very helpful in telling us what a pregnancy may do to this patient. And then you can put people into different categories of risk: low risk, medium risk, high risk. The highest risk patients are the ones who have active disease, who have deteriorating renal function, and who have only been in remission. If they have been in remission, only in remission for a short time. Ideally, we want a long period of remission. We want the disease to be under control. And while we're waiting for this remission and the best time for a pregnancy, contraception is also very important. In this low risk or medium risk group, you can discuss with them what would happen if they had a relapse of disease in pregnancy. You can review their immunosuppression, change their medications, get their blood pressure under control, and talk to them about the impact of the pregnancy on their kidney outcomes, and then follow them up regularly to make sure they're keeping that safe pregnancy scenario. In women who are higher risk, then this becomes difficult. One of the biggest challenges is trying to convince women who desperately want to have a baby and progress with their pregnancy and progress with their family that they have to wait or that they cannot proceed. Often they're under enormous family pressure and an internal desire to get started and have that complete their family. I think what we need to do here is explain to women what the benefits are of deferring a pregnancy until their glomerular disease, particularly if they have active nephrotic syndrome, until it is more under control. And these can be very difficult conversations. That's why you need to start this counselling quite early. In the best practice recommendations, there is a algorithm for the type of follow-up that these women need during their pregnancy, and I won't go into that in detail, but the main thing is to monitor the disease activity as well as renal function. Now, we know that the kidneys are hit by massive physiological changes in pregnancy. They're the hemodynamic changes that are hormonally driven and driven by increase in blood volume and cardiac output lead to a significant increase in GFR. And so pregnancy is essentially a stage of very early onset and persistent glomerular hyperfiltration. Now, you can imagine in these women with chronic kidney disease and impairment due to glomerular disease, this can they have a lot of work to do to adapt to these physiological changes in pregnancy. And what we see here are the main markers that we would use to monitor kidney disease all change in pregnancy. So there is this dip in the serum creatinine, I think we all know about this, that occurs from the second trimester. Starts very early on in the first trimester. The nadir is in the second trimester. And so we have to adjust our reference range for what is abnormal kidney function in this group. And this is very nice data from North America that shows that even in normal women without kidney disease, the serum creatinine does tend to rise in the third trimester. In our women with glomerular disorders, if we see this happening, we're very worried that this may be preeclampsia or this may be relapse of their disease. And sometimes our job is to reassure everybody that, look, this may be physiological in pregnancy and there's no need to panic and deliver the baby. So it's very important that you interpret serum creatinine values according to gestational age. It's not possible to use eGFR during pregnancy. It's not validated. So you have to stage the chronic kidney disease stage based on preconception values where possible. Similarly with proteinuria, there are lots of different physiological effects that lead to a minor amount of proteinuria in pregnancy, and this can be quite normal. But obviously more than 300 milligrams per day starts to become pathological. Most commonly, we use the urine protein to creatinine ratio. This is quite reliable. The 24-hour urine protein is the gold standard, but of course we cannot always do that in a complete way. It's not very easy for the patient, and often it can be an incomplete collection and quite inconvenient to do. So for this reason, we do prefer the urine protein to creatinine ratio. In some situations, it is important to get a timed collection, particularly if you're trying to work out how nephrotic a patient is. What we still don't know yet, and the guide or the recommendations do acknowledge this, is what is a significant increase in proteinuria in women who already have proteinuria. And in the recommendations, the consensus was that a doubling of proteinuria during pregnancy is probably the most concerning. And they're the women that you really need to be careful about. But that the evidence is not really strong in that area. So what happens if you're concerned about a new diagnosis of glomerular disease in pregnancy? And this is in the women who present with impaired kidney function, with new onset proteinuria or nephrotic syndrome, with an active urine sediment or hematuria or other systemic features of lupus or other conditions, for example. So the recommendations put forward an algorithm for how you may approach these patients. And increasingly, we are relying on the peripheral and serological markers rather than thinking that we need to do a kidney biopsy. And membranous nephropathy is probably the classic example where the widespread availability of the antiphospholipase A2 receptor antibody has really changed our approach to whether we biopsy in this disease or not, and how it can help us make the diagnosis. So as much as possible in the recommendations, it is we look to the peripheral markers to help us sort out what is de novo disease in pregnancy and what what may be glomerular disease. The key clinical conundrum is whether to biopsy or not. Now, I quite like to biopsy women with glomerular disease before pregnancy to make sure that their disease is under control, particularly women with lupus who may have subclinical active disease. But biopsying during a pregnancy can be quite challenging. And really here we have to consider the risk and benefit at each gestational age. So in early pregnancy, it's quite safe to biopsy, and if you have the opportunity, do it, because it helps you establish the diagnosis, and then you can make the plan for the rest of the pregnancy without guessing. However, beyond 25 weeks, the bleeding risk is much higher, and most people would be quite reluctant, and certainly in the international group, the consensus was that they would very rarely biopsy beyond 25 weeks unless they thought it would substantially change the management before delivery. Beyond 25 weeks, if you're thinking, 30, 32 weeks, it may be that you just deliver the baby and then do the biopsy afterwards and treat the kidney disease after delivery. Nephrotic syndrome, the practice recommendations have suggested that we adjust serum albumin according to gestational age, because it normally does decrease in pregnancy, and that severe hypoalbuminemia is when there is the serum albumin is less than 50% of what is normally seen or in the normal range for that gestational age. And the 3 grams of proteinuria or more, that definition still holds as it would in the non-pregnant patient. And the differential diagnosis for nephrotic syndrome is also similar to the non-pregnant state. The recommendations here for severe nephrotic syndrome in pregnancy are around symptomatic treatment. The consensus group had a very strong focus on nutritional management, including fluid and salt restriction, the use of diuretics with caution and not dehydrating the patient too much, and then managing thrombosis because these women are at high risk of thrombosis. So all of these patients really should be on aspirin anyway for preeclampsia prophylaxis, and then you may need to consider heparin and other as an additional thromboprophylaxis in severe nephrotic syndrome. Again, in this situation, when there is severe nephrotic syndrome, diuretic-resistant edema, the question arises, do we need to do a kidney biopsy? And again, the recommendations suggest only do this if there is enough gestational age that you'll be able to start some immunosuppression and maybe prolong the pregnancy. Another big clinical conundrum is, do you start empirical immunosuppression without a biopsy? And in some situations, when you're really desperate, the group felt that you could try a short trial of pregnancy-compatible immunosuppression. But again, you need to consider the gestational age and whether you'll be delivering the baby before the immunosuppression really has time to work. I won't go into the details of immunosuppression for each type of disease, but here we have minimal change, membranous, IgA nephropathy, and MPGN. And the point that I want to make here is that our treatment options have slightly shifted away from being only corticosteroid based. So I think in the past, people would give a trial of prednisolone. There's now a great shift amongst the international community to try calcineurin inhibitor, particularly tacrolimus, as a first-line agent in these cases, and particularly for membranous nephropathy, a majority of people would try tacrolimus first. It's very effective to treat nephrotic syndrome in pregnancy. The other standard immunosuppressions, steroids, azathioprine, are certainly always available. IVIG and plasma exchange can certainly also be used. There was some discussion about whether it's reasonable to give cyclophosphamide or mycophenolate in the 3rd trimester, but really the consensus was that you should be thinking about delivering the baby if you're getting to that point. Lupus is the most concerning condition in pregnancy, particularly if it's uncontrolled. And it's important to remember that the disease can flare at any time during pregnancy and particularly postpartum. So these are the women that we worry about the most. We try and ensure they have at least 6 to 12 months of controlled disease and remission, because we know that going into a pregnancy with active nephritis gives the worst outcomes. And so you do have to plan ahead and watch these women very carefully once you've taken them off their usual immunosuppression and onto pregnancy-safe medication. So for women who are known to have lupus, who are planning a pregnancy, the best practice recommendation was to continue that maintenance immunosuppression. You don't have to start immunosuppression just because they're pregnant. If they didn't need immunosuppression and they were stable, you could just continue on like that in the pregnancy. And hydroxychloroquine is a really important component of that immunosuppression that really does improve the pregnancy outcomes, both maternal and fetal. If a patient presents with new onset lupus or relapsed lupus in pregnancy, you do have to give them some induction therapy. And here the recommendation is azathioprine and calcineurin inhibitor, usually tacrolimus, as well as some background corticosteroid. And for the majority of patients, you can actually get them through the pregnancy on this treatment. Tacrolimus is being increasingly used in lupus nephritis. Other drugs, rituximab, as well as IVIG and plasma exchange, again, remain there as options, but indicate that the pregnancy is likely to be ending fairly soon anyway. So here we really have, when glomerular disease is flaring in pregnancy, this balance between prolonging the gestational age versus trying to save the maternal kidney function and the health of the mother. And generally the consensus was that the more advanced the gestational age, the more inclined the clinicians should be to deliver and then treat the mother properly, rather than trying to prolong the gestation. But this is a highly individualised decision, and so no definitive recommendation has been made. It needs to be based on each individual context. Another area of controversy was discussed in by the working group, and this was how to manage renin-angiotensin blockade leading up to pregnancy. There are two approaches. The first approach is I think the majority approach now, which is to say that uncontrolled hypertension, uncontrolled proteinuria going into a pregnancy is more dangerous than the drugs themselves, and to continue these medications until conception and then immediately stop. This avoids the patient being deprived of the renoprotection of these drugs for many years, maybe, while they're trying to conceive. The second approach is to say that, look, these drugs are a risk to conceive on, and therefore they should be stopped in any woman who's trying to conceive, and that the risk of proteinuria emerging should be accepted. And really the consensus from the group was that we didn't recommend either approach 1 or approach 2. Instead, the statement is that these approach 1 and approach 2 need to be weighed up according to the individual patient circumstance, the severity of proteinuria, how important it is to continue these medications, as well as how reliable the patient is and what their own preferences are. Blood pressure management, the consensus group put forward a blood pressure target of 130 on 80 to continue treatment until the blood pressure unless the blood pressure was less than 110 on 70. And this is based on many on evidence from very good trials, the CHIPS study, the CHAPS study, large trials that have informed us that these are the appropriate blood pressure targets. Of course, these trials have not been done in women with glomerular disease, but they are, nevertheless, we are extrapolating the outcomes of those trials into this high-risk cohort. The consensus group also recommended home blood pressure monitoring, recognising that clinic blood pressure may not always accurately reflect what's going on. And really a focus on blood pressure as being a very easily measured and modifiable parameter was very strongly emphasised, as well as the use of aspirin for preeclampsia prophylaxis in this group. Coming to preeclampsia, one of the other great challenges is trying to differentiate from 20 weeks onwards if we're seeing worsening renal function, proteinuria, hypertension. Is it preeclampsia? Is it a flare of their glomerular disease? Is it chronic kidney disease progressing? And here we have to look outside the kidney, particularly at the placenta, to tell us whether this is placental dysfunction or renal dysfunction. And this is where the new angiogenic biomarkers, soluble FLT1 and placental growth factor, have really emerged as useful tools that we are now starting to incorporate into our clinical practice. These markers only became available in Australia for routine clinical use about a year ago. Many regions of the world do not have access to these markers, and we are only learning how to use them in real-world clinical practice. However, I think these will be an important ally in our care for women with kidney disease and glomerular disease going forward. And this really will help us with this balancing act of, do we deliver the baby or do we keep going? Is it preeclampsia, which requires delivery, or is it something else? And I'm hoping that this will help us achieve more gestational age for these babies, because the preterm birth rates are exceptionally high in women with glomerular disease and chronic kidney disease. So I'll finish there. My summary is that pregnancy with glomerular diseases are definitely feasible. They may be complex pregnancies, but they also may be absolutely fine. And we need to plan early and individualise the risk with our patients and share with them and their families what those risks might be, and come to decisions together about whether pregnancy is possible. The game changers I think that we are dealing with now are the emerging serologies, particularly antiphospholipase A2 receptor antibody membranous, the steroid avoidance strategies and the wider use of calcineurin inhibitors as first line, the placental biomarkers, as I've just mentioned, the emergence of better data sets, and there are many international initiatives that are now underway to try and build global collaborations around data so that we can get better information to guide our clinical practice. So I'd like to end there. I would like to again thank the speakers, the organisers, for inviting me to this auspicious occasion. Congratulations to WIN India. I think you're doing a fantastic work, and it's wonderful to see the strengths that you're going to. And this is again the paper, the group that was behind this. I'm just a very small part of a very large collaboration led by some incredible people. There is the citation for the paper. Thank you very much. Happy to take any questions.
Thank you, ma'am. We have 5 minutes for Q&A session.
So, thank you very much, Professor Shilpa, for the excellent overview on glomerular disease and pregnancy. And can I ask you one question that always the clinical clinicians encounter in day-to-day practice when some of the patient of the SLE, lupus nephritis, become pregnant, and that flares during pregnancy, serum creatinine go up, and there is always a dilemma whether to do biopsy, not to do biopsy, but definitely diagnosis is already there, so most like to defer for the biopsy. So how to choose immunosuppressions during that period? So what you need to do?
Yeah, I think if you already have the diagnosis and you think that their disease may be flaring and relapsing, you have a good understanding of what's going on. One option would be to avoid a biopsy and simply increase the immunosuppression that they're already taking. So for example, if the patient is just on prednisolone, you may increase the prednisolone dose and add azathioprine. If they're on prednisolone and azathioprine, this may be a time where you may wish to add in an agent such as tacrolimus. And in whatever they're taking, just slightly increase that and see if you can actually control the disease. I wouldn't necessarily push for a biopsy unless you really had uncertainty as to what was going on. And I think unless it would really change your management. So my first step would be to take, whatever they're currently taking, increase that and see if that is assisting the situation. Of course, in later gestation, it's hard to work out, could it be preeclampsia? And that's where you need to look at the blood pressure, you need to look at the placenta Dopplers, you need to look at the baby very carefully, perhaps those biomarkers if you have them available, and try and differentiate, is this disease flare or is this preeclampsia? And that can sometimes be very difficult.
One thing happens, there is always some renal failure comes into the picture, and definitely most of these patients are already on prednisolone and azathioprine as a maintenance. So adding on, there is some fear of adding on the tacrolimus causing this may precipitate rise in the serum creatinine.
Yes, and yeah, thank you for bringing that up. I didn't have time in the talk to discuss tacrolimus, and the best practice recommendations didn't really go into it, but there are challenges using tacrolimus in pregnancy, because we all know that the therapeutic drug monitoring that we use to measure tacrolimus levels in pregnancy changes quite significantly. So you should not be targeting the same levels in pregnancy that you do in the non-pregnant state, because the bound versus unbound fraction of tacrolimus changes substantially in pregnancy. It is the unbound fraction that that is physiologically active, but we only measure the fraction that is bound to whole blood. So tacrolimus dosing can become difficult. There is concern that we're using too much and overdosing the patients on tacrolimus, which causes the creatinine to rise and may look like preeclampsia. So I would encourage you to be comfortable with lower levels of tacrolimus in the pregnant patient. We do this even in our transplant patients. We let the levels be a little bit lower than we would normally be comfortable with in the non-pregnant patients.
Thank you very much. My co-chair, Jyoti Priya, Dr. Ravi Shankar, and Dr. Radha might be there.
Yes.
Have you any questions? You can interact.
Yes, thank you very much, ma'am, for that very clear talk. I just have one thing to add and also a question. In ladies that have proteinuria under control with ARBs, whether it is diabetics or other glomerular pathologies, I think it's a good idea to continue ARB till conception, because they have increased risk of infertility and they might take time to conceive, sometimes even 6 months to 1 year. So during that time, if prematurely stopping ARB might give them more risks than benefits. So I request you to comment on this. Thank you.
I completely agree with you. I think that is a very important point. And I see a lot of the patients who are seen by other clinicians in my state, and sometimes they come to me for pregnancy planning and they have FSGS, for example, have not had ACE inhibitor or ARB for 2 or 3 years, and have 2 or 3 grams of proteinuria for many, many years. We wouldn't accept that in our usual patients, and I think we are not serving our patients well if we let them be so proteinuric for such a long time, because they are accumulating damage to their kidneys, which also has an impact on their pregnancy outcome. But some people don't agree with that approach, and I think the problem is we don't have the evidence to say that one way or the other is best. But I think the majority of people would agree to keep these drugs going because they are so beneficial, and we don't know when conception will occur. The other thing to remember is that the amount of proteinuria pre-conception is a very important determinant of the pregnancy outcomes, and has been very closely linked to what happens with gestational age, birth weight, preeclampsia rates. So the less proteinuria they have going into the pregnancy, the better. But you can't do this with all women. You need a very reliable patient who is going to be checking to see if she's pregnant, because what everyone worries about is someone will come 16 weeks gestation, continuing to take their medication, and there's effects on the baby's kidneys. So you have to select your patient carefully.
If any more questions?
Yeah, I have
Last question. We are running out of time.
Okay. Thank you, Dr. Shipa, for that lucid presentation. As you rightly pointed out, management of glomerulonephritis in pregnancy is very complicated. Especially, we have to consider it under two categories. One, the impact of glomerulonephritis on pregnancy, and the pregnancy on the underlying glomerulonephritis. And in fact, more complicated is the management of an active glomerular disease or a de novo one in pregnancy. So my query is regarding the role of rituximab, though it's not indicated in the guidelines, but in certain scenarios like membranous nephropathy, vasculitis, where we have off-label or studies undertaken in the role of rituximab. So what is your opinion in giving rituximab in pregnancy in the management of active glomerulonephritis?
So a couple of points. I think you're quite right. It is off-label. So, you know, we have to explain that to the patients if we're thinking about that. I have not actively given rituximab in pregnancy. There are a few cases, obviously, where that has occurred. But I have had a few patients who we had given rituximab to, and then they became pregnant within that 6-month window. And so you worry about B-cell depletion of the baby and rituximab crossing the placenta, etc. I think we all know rituximab takes a long time to work. So in membranous, for example, it may take up to 6 months to have the full effect on remission. And similarly in lupus and other situations. So you have to be confident if you're going to give it that you will have enough time for it to have an effect, to have an impact on the gestation. And this is where you need to decide, are you giving the rituximab to save the mother or to save the baby and help get better gestational age? I think it's complicated. I think it would have to be done with a lot of discussion with the obstetricians and with the woman and her family about what the outcomes are. But certainly I know people have used it in some situations to try and salvage the renal function during pregnancy and quite successfully.
Okay, thank you. I think we need more papers on that because our therapeutic armamentarium in pregnancy is very small, limited because of the safety profile of the drugs.
Yes, and you know, belimumab, voclosporin, some of these other newer treatments that are coming through are absolutely, you know, in our recommendations in this practice recommendation, they are not recommended because there is just no data. But I would encourage you to think about the wider spread use of tacrolimus. We have, you know, the group has found this, in our experience, to be quite useful as a rescue treatment in lupus and some of the other glomerular diseases, and it's something that that you should consider before thinking about some of those other agents that have much less information. I mean, we are also accustomed to using tacrolimus in pregnancy, and you know, I think that is a good option.
Okay, thank you, ma'am. I think we'll wind up this session. Thank you.
Thank you very much. Thank you very much, everyone.
Thank you. Bye-bye.
So without much delay, we'll move to the next session. Next session is the clinical pathological case. And I would like to invite the chairperson for the session, Dr. Umesh Khanna, a consultant nephrologist and renal transplant physician, Lancelot Kidney and GI, Dr. Megha Open, Professor Pathology, Nissan Institute of Medical Science, Dr. Sita Lakshmi, consultant clinical pathologist, Dr. Menefras Hospital, Chennai, Dr. Mahesh, consultant nephropathologist, Manipal Hospital, Bengaluru, Dr. Vinay K.S., Associate Professor, IIT Bangalore. And I now request the chairperson to introduce the speakers.
Good morning, friends. It's indeed a pleasure to be a part of this iconic meeting, which is very rightly called WinICon, and I think we have already won the importance, and the excellent fare dished out today is testimony to the fact that WinICon has arrived. It's my pleasure to introduce Dr. Namrata and Dr. Anila Ibrahim, the people who would conduct the CPC. And as you all know, CPC is the much awaited heart of a conference. Dr. Namrata is an assistant professor in the Department of Nephrology, Dr. Ram Manohar Lohia Institute of Medical Science, Lucknow. And she would initiate the clinical part. And then Dr. Anila Ibrahim, whom we all know as a renal pathologist, Renopath, Center for Renal and Urological Pathology Center in Chennai. So may I invite Dr. Namrata to start the proceeding? I have always admired a person who conducts a CPC. It's always very difficult to be in that hot seat, trying to be like Sherlock Holmes, find out what the ultimate diagnosis is. So I think, Namrata, congratulations to you, and I'm sure it's going to be easy for you to come up with the diagnosis, knowing the clinical acumen you have. Can you all hear? I can't.
No, I can't hear either.
I think the audio needs to be. Not audible?
The slides are also not moving forward.
Yeah. No, but I can't hear Namrata speaking.
Yeah, I can't hear either, and the slides are also not moving.
I think the suspense in the CPC is being built more and more. People are eagerly wanting to hear. Yeah. Yeah.
Hello, sir. Can you hear me, sir?
Yes.
Yes, now audible.
Yeah. That's it.
Sir, I hope I'm audible now, and I'd like to begin.
Yes. Yes,
Even
you
I
are.
don't-
Take a deep breath. We'll give you all the time that you have lost, and don't be tense. Please go ahead.
Right. So I'm Namrata Rao. I'm an associate professor in nephrology at Dr. Ram Manohar Lohia Institute, Lucknow. Yeah. Yes. So this patient presented for the first time during the COVID pandemic, during the peak of COVID pandemic, as has been told to us. She is a 32-year-old lady who was a Gravida 3 Para 2. She presented at 7 weeks of gestation to the gynecologist with a reduced urine output of 1 week duration, which means to say all the pathology began a week back when she was 6 weeks of gestational age. It is unclear as of now. We do not know whether she had any fever, flank pains, any swelling of her limbs, any breathlessness, any bleeding in urine, any cola colored or frothing urine. She had 2 previous pregnancies which were unremarkable. At the 7th week of gestation, the gynecologist advised her to undergo medical termination of pregnancy, which she did, as she was told to have uncontrolled hypertension, advanced renal failure, and proteinuria. 1 week following the medical termination of pregnancy, she was told to have persistent hypertension, oliguria, and renal failure, for which she was referred to the nephrologist. So examination at this time, which is 2 weeks from the onset of illness, she was hypertensive with a blood pressure of 160 by 100 millimeters of mercury, with all the peripheral pulses palpable and no radiofemoral delay. All other clinical examination is normal. So by that, I would think that she had no visible rashes, no joint swellings, no flank tenderness, no bleeding manifestations, heart murmurs, or adventitious sounds. So the laboratory parameters which are given to us show that she is anemic. The TLC is slightly risen at 11,500. The platelet counts are preserved at 3,20,000. The peripheral smear does not show us any fragmented RBCs. It just shows a hypochromic and normocytic anemia. The urine RM shows albuminuria of 3+. I assume the urine RM is from the time when the output was more than 400 ml. The pus were 2+ with persistent microscopic hematuria as well. The urine culture given first time was growing E. coli, which was sensitive to meropenem, and the repeat cultures were sterile, which were done 2 weeks later. Among the serologies, it's mentioned that hepatitis B, C, HIV, ANA, anti-dsDNA, ENA profile, and anti-Smith antibody were negative, and the complement C3 and C4 were normal. The ultrasound imaging was told to have normal-sized kidneys with some echogenic perinephric fat, which was suggestive of acute pyelonephritis. So this is a timeline I'm showing here, which tells us that this patient at the time of presentation was at 6 weeks of gestational age. We are told that she has a baseline serum creatinine of 0.7, which I assume is any time before the 6th week. She is a G3P2. At week 1, when she underwent the MTP, her creatinine had already risen to 6.1 and her output had fallen to about 400 ml. At this time point, the gynecologist did the MTP, and the patient, because the urine cultures were growing E. coli, was given IV meropenem. During this time, she also received antihypertensives and diuretics. And with all this management, the creatinine came down from 6.1 to 4.6. And there was some improvement in urine output as well, from a value of say 400 ml to about 800 ml. She was continued on antihypertensives and diuretics, but just a week later, she came back with a creatinine of 10.6, and now the urine output had gone to less than 100 ml. So this was the presentation of our patient. Well, the picture that is given to us shows when the biopsy was done. And we all know that when we look at bulky kidneys with some perinephric fat, we're always perinephric fat stenting, we're always thinking of acute pyelonephritis. But let's also remember that obstructive uropathy and acute glomerulonephritis can also be associated with some degree of perinephric fat stenting. So let's come to the differential diagnosis. I'm sure as far as the syndromic diagnosis is concerned,
None of us will be in doubt that we are looking at acute kidney injury, oliguric, in this patient who's post-abortal status after a first trimester FTP with accelerated hypertension. So when we look at AKI, then we also look at whether it is pre-renal, intrarenal, or post-renal. And this post-renal looks less likely with the possibilities, with the history given so far. So among these possibilities, pre-renal one we would keep would be complicated UTI per se, leading to a urosepsis picture, leading to pre-renal AKI, or some kind of periabortal sepsis, though that appears very less likely considering our timeline that when the patient presented, she already had advanced renal failure. Then we come to the intrarenal causes, could be glomerular, vascular, or tubular interstitial. Among the glomerular causes, the elephant in the room is acute glomerulonephritis. And in pregnancy, the possibilities we can entertain here are IgA nephropathy, infection-related GN, lupus nephritis, ANCA-associated vasculitis, and anti-GBM nephritis. Among the intrarenal tubular interstitial pathologies, acute tubular necrosis per se, which could be sepsis-related, acute tubular interstitial nephritis, either infection-related or possibly the drug-induced one, or that which is related to post-abortal sepsis, and acute pyelonephritis would be tubular interstitial causes. Among the vascular causes, early onset preeclampsia and thrombotic microangiopathy, probably renal limited, can be kept as the diagnostic possibilities. So when we talk of acute GN presenting as AKI, we are basically talking of an acute nephritic syndrome, where all these different possibilities can be thought of, like presentic GNs, as well as among non-presentic, we could think of proliferative non-presentic GNs. And among them, you have immune complex GNs, autoimmune GNs, and anti-GBM nephritis, all of which can be differentiated by the IF. So, considering GN as a diagnostic possibility, I'm sure all of you will agree with me that there are many things which support the possibility of acute glomerulonephritis in this patient as the pathology that we expect on a biopsy. What goes for it? We have a classical triad. We have a patient who is presenting with hypertension, hematuria, and oliguria. And the urine albuminuria is 3+. You have a lot of activity. And presentation during pregnancy. We all know that many GNs actually relapse during pregnancy, say lupus, say IgA nephropathy. So many of the GNs can relapse during pregnancy. So pregnancy is an immunomodulatory state in which a de novo GN can also occur. Also, generally, if it were to be preeclampsia, it would have resolved with the termination of pregnancy. But this patient went on having the pathology, which continued beyond the medical termination of pregnancy, which again goes for an acute GN more than it goes for the preeclampsia-like syndromes. And presentation during COVID pandemic. I'm sure the person who gave us this protocol wanted us to keep it in mind that this could be related to the SARS-CoV or it could be related to vaccination status, both of which are unknown to us at this time point. All of us have seen in our clinical experience that the virus and its vaccination have both led to a lot of GNs. So this for me somehow makes me go towards GN as a diagnostic possibility. So what is really against it? Against it is the initial spontaneous improvement. How come she improved from that creatinine of 6.1 to 4.8 and the urine output improved to a certain degree without any steroids or specific management, things that we generally associate with the occurrence of a GN. And the absence of hypocomplementemia and typical serologies, which are usually associated for a young person who presents with a GN. And again, accelerated hypertension, this is not a point which would go against GN, especially in children. We know that accelerated hypertension is one of the presenting features of GN in that age group. But in adults, we take it more for TMA than for GN. So this is not something which is really odd. And the absence of typical inciting events for, say, post-infectious GN, like the fever, sore throat, skin infections, etc. But do we consider pregnancy as an inciting event? I think we may. So if GN is a possibility, which GN are our bets on? First, I would like to take up the immune complex GN, considering how common it is in this age group and in the female sex in general. Pregnancy is associated with relapses in IgA nephropathy and lupus and de novo presentations as well. In this patient, there is a history of UTI, which is confirmed by the presence of both pyuria, hematuria, as well as the urine cultures growing E. coli. And there is, so it is possible that this could be an infection-related GN, which was precipitated by the UTI. Also, the improvement in renal function, which occurred after the MTP plus the treatment of UTI, some partial improvement which took place, that can be consistent with the responses that are known to occur in infection-related GN. So these are certain things which I feel take us towards a possibility of immune complex GN. What goes against it is the absence of hypocomplementemia. Generally, lupus nephritis, cryoglobulinemic GN, post-infectious GN, C3 GN, the common garden variety GNs are associated with hypocomplementemia and immune complex GNs. Also, the typical serologies are absent, somehow ruling out lupus nephritis for me. And the viral markers also, which go against the cryoglobulinic GN. So what remains? Among the immune complex GNs, for me, these two possibilities still remain, which are IgA nephropathy and infection-related GN. So let's go forward with these. Is it likely that this patient has IgA nephropathy? It is the commonest primary GN described in most cohorts, including pregnancy cohorts, including the CURE GN cohort that Madam Shilpa had discussed just a few minutes ago. And IgA nephropathy first presenting in pregnancy with a crescentic picture has been well documented in case reports. And the absence of hypocomplementemia, normal platelet counts, all of these also go towards a picture of a possible IgA nephropathy in this patient. And again, we know that AKI and IgA nephropathy could be either because of, say, a crescentic picture, or it could be because of a hematuria cast causing the AKI. In this picture, because she did not have history of any cola-colored urine mentioned in the history protocol to us, and also that the pyuria was prominent. It is written that the pustules were 2+, whereas there was just persistent microhematuria. I would say it goes more for the possibility of crescentic GN rather than hematuria cast AKI if we are thinking in terms of IgA nephropathy. So what is odd? Again, pustules more than RBCs. It's not a very great pointer, but we always associate IgA nephropathy with having more of RBCs than WBCs. So that is somewhat odd. And secondly, why was there that partial improvement which occurred after the antibiotic course in the MTP? That is difficult to explain with the diagnosis of IgA nephropathy. So could it be infection-related GN? The concomitant culture positive UTI and that some improvement which did occur with the IV antibiotics, they support the diagnosis of infection-related GN in this patient. Also, among series, it has been seen that hypocomplementemia is not universal in infection-related GN. It's possibly been reported in about 60 to 80% of cases. So it is possible that even though hypocomplementemia was not there in the index case given to us, we may still latch on to a diagnosis of infection-related GN in this case. Again, predisposing conditions have not been universally present in the series reported from 2013 onwards. This also will not take us away from the diagnosis of infection-related GN. So what's odd here? One is the lack of fever in presentation. To label as acute pyelonephritis, why would you have a young patient who's otherwise immunocompetent at a very low, just 6 weeks of gestation, not present with fever, flank pains, and the typical things that UTI brings over. So that is something which is odd. And also, why was there a subsequent deterioration after the infection was treated? Why did she again go on to have a creatinine of 10? And why did she again go on to, the oligonuria? That is difficult to explain with just the infection-related GN. And then it's not well described. I could not find any data with regard to pregnancy's association with infection-related GN. So that was a perfunctory search. I'll look more into it. Well, C3GN also comes under this spectrum, but again, I thought it was less likely than infection-related GN because infection-related GN, even in the absence of hypocomplementemia, may be responsible, but C3GN would likely have more of hypocomplementemia than infection-related GN. And again, hypocomplementemia is also not universal in C3GN. 10 to 25% may still have normal complement levels with C3GN, which can present this way. So then I would go on to post-immune GN. Reason why we have written this here is when the serologies were mentioned exhaustively, we were not told about the ANCA. We were not told about ANCA titers. So it's somewhere, we shouldn't be missing that. I'm sure that if that were to come through, that would be a bouncer. I'm sure my seniors will not spare me for. So again, it's very uncommon to occur de novo in pregnancy in general, and only case reports have been there. But again, COVID vaccination has been associated with ANCA development in young people, and that's what I was coming to. And infections can trigger ANCA vasculitis episodes as well. So this UTI could have been a trigger to the ANCA vasculitis in this patient. But what is odd is the degree of proteinuria. Do we expect a 3+ proteinuria to commonly occur with ANCA-associated vasculitis? Probably not. And presentation with accelerated hypertension. Again, it is known to present with mild hypertension or so. So accelerated hypertension and the degree of proteinuria and not having the anchor report. So that's why I'm keeping it a little below the other two diagnostic possibilities which we kept in now. Same things, again, similarity and rarity of presentation and that improving and deteriorating course. These are against the anti-GBM nephritis as well. So I do not wish to discuss it further as of now. So next, coming on to renal limited TMA, could that be a diagnostic possibility? We know we have a patient who doesn't have we don't have the typical Maha picture in this patient, no fragmented RBCs in the segment. We don't have much of thrombocytopenia either. C3 is normal. So can this be just renal limited TMA? That is a possibility. Presentation during pregnancy makes us think about this as a possibility. Also the presentation with accelerated hypertension. And we know that in susceptible individuals, pregnancy can trigger microvascular injury. So again, could it have been that the malignant hypertension per se triggered a TMA? That is also not very well known. And we all know that COVID as well as its vaccination have been associated with thrombotic microangiopathy development in susceptible patients. Again, as I said, many odd things here. So I would not like to keep it high up above. And again, this improvement, which was followed by secondary deterioration, are we looking at two different triggers for the TMA here? Or is it like the control of hypertension was not good, so the patient landed up with another deterioration, is something which we can still discuss. So lastly, we come to early onset preeclampsia as a diagnostic possibility. Presentation in early pregnancy is the only reason why we should possibly even discuss it. It is uncommon, but it is a serious complication with the incidence of this complication increases with maternal age. Though she is not a very old mother, but at 32, she is relatively older than the majority of mothers we see during our routine practice. It is associated with poor fetal-maternal outcomes and poorer renal prognosis. We know that lots of odd things about this. This did not improve with the pregnancy termination. So therefore, I'm not entertaining this as a huge possibility. But we all know that TMA in pregnancy is a huge conundrum. There could be primary HUS, some genetic defects underlying the pregnancy itself, and the fact that this patient may have contracted COVID, the status of which we do not know, or the vaccination, or the intercurrent infection that she developed. Any of these could have led to a renal limited TMA in our patient. So to take us out of it is a little, to rule it out completely is difficult for me at this stage. Lastly, about the pyelonephritis. Should we be still keeping it as a diagnostic possibility when the pathologist gives us our true picture? That's difficult to say of now. But as a clinician, I would say if something is showing me pyuria, hematuria, urine culture positivity, the ultrasound showing me echogenic perinephric fat in the first trimester, would I treat it as a pyelonephritis? I would. I would not be able to say that this is a GM and this is not a pyelonephritis. So as a clinician, I agree with the choice of the clinician in the first scenario also that they treated the patient with the IV antibiotics. The secondary deterioration in this patient may have taken place because of, say, secondary acute tubular interstitial nephritis. Why did that occur? It could have occurred because of, say, the infection itself, infection triggering allergic responses, or the drug that was given, meropenem. It is known that cephalosporins and penicillins are associated with drug-associated ATIM. So that could have happened. And lastly, because this is a CPC, and I have been trained that CPCs are always up with, bouncer kind of diagnosis, I would not be really surprised if Madam was to show us, say, evidence of some fungus somewhere, and it would be great to know if something of that kind is there. Again, odd for pyelonephritis from my point of view was that why would we see so much accelerated hypertension? Why would we see oliguria? Oliguria is still possible because of severe acute tubular interstitial nephritis, because of, say, papillary necrosis, if it were to be bilateral, or there is, or there was an underlying condition, say something like a VUR or something, which actually precipitated this pyelonephritis. It is possible, but her previous uncomplicated pregnancies go against that possibility. So let's come to this. Do we agree with Occam or with Hickam? See, Occam's razor would say that, if you had two explanations, just go with the one which requires least amount of assumptions. And Hickam would say that, usually patients can have as many diseases as they please. I wouldn't mention the other words because this is a very holy auditorium and I do not wish to say such things here. So I'm sure, who would you vote for? If it was Occam's razor, I would say crescentic IgA nephropathy. This patient had something to begin with. Say she was a pregnant patient. She developed some kind of crescentic GN, which was likely something like crescentic IgA nephropathy. And when the abortion took place, she was found to have a urine culture positivity. That could have been a periabortal UTI, which was treated and which ended up at the time of biopsy. When Hickham's dictum is considered, it could be acute pyelonephritis per se, which occurred at 6 weeks of gestation. And that led to the infection-related GN. at the 7th week, and this was followed by a severe acute tubular interstitial nephritis, which is why some amount of improvement took place when the pyelonephritis was treated, and secondary deterioration took place because there was ATIM. So I don't know what you all will vote for. We'll discuss that now. So these are the cards which are laid down after my discussion. One, it could be Tecentric IgA nephropathy. It looks like the, in terms of epidemiology, it looks like a very likely possibility. IgA dominant IRGN, because somehow I'm not able to remove IgA from my cards. So somehow I would still like to keep that, or any garden variety infection related GN. I would like to keep that as a possibility. Thrombotic microangiopathy, COVID related, because the first sentence said COVID. And again, it's difficult to exclude COVID without knowing the RT-PCR report or the vaccination status in this patient. And severe acute tubular interstitial nephritis, possibly as a secondary phenomenon. So this is the clinical diagnosis I came up with. The syndromic diagnosis was acute kidney injury. The compartment involved, I felt, was the glomerular compartment with the secondary involvement of the tubular interstitium. Pathological diagnosis, I felt it was crescentic immune complex glomerulonephritis with likely, I'm hoping and expecting to find some IgA on the immunofluorescence with the severe acute tubular interstitial nephritis as well. With possibly even WBC casts, indicative of whatever pyelonephritis took place some time back. And the etiological diagnosis, I would like to keep two possibilities, either IgA dominant infection-related glomerulonephritis or IgA nephropathy. And the bouncers, which I don't know, I might get some, are that it could be a renal-limited thrombotic microangiopathy more than a quasi-immune GN. Thank you.
Thank you, Namrata. It was a very good dissection of the entire clinical scenario. And I must congratulate you for bringing it out so well and putting us all at the edge of whether it's HOCAM or HICAM. So can I ask the audience, what are you voting for? So comments from the audience as to what is the opinion of the House, one by one, if anybody wants to.
Thank you, Dr. Kanda. Excellent presentation, Namrata. Excellent dissection of the case. And I would only add to the diagnosis. When we are seeing IgAs, maybe I cannot eliminate IgA. My first goes IgA, whether it will come in the IA as a part of an atypical IgA, in which COVID might be a trigger of atypical IgA. I cannot eliminate IgA fully with you. And only to offer a combined thing on the platter, that we are seeing TMAs also appearing with G. I don't know, this patient might be having some genetic things which got a second peak or trigger. We are very fond of now putting the second peak in the TMA mechanism as well. So if it is a IgA and TMA combination, in which sometimes in IgA also we find a TMA histology, whether it is related to this accelerated hypertension component separating, or we are finding malignant hypertension as a presentation of TMA as well.
Thank you.
Any other comments? Any other opinions? Yes.
So yes, I agree with the IgA, but API also remains very high on the cards, given that drugs can cause toxicity. That can be a problem which has caused globulopathy in addition. So I would go IgA, API.
Not TMA.
From the history with microscopic hematuria and the other parameters, I think it clearly points out that it is the nephritic nephrotic syndrome. Though you do have a nephrotic major proteinuria, you do have a nephritic picture. So glomerulonephritis is a definite possibility, as everybody voted. I think IgA comes first to your mind. And another thing which I found here is, because COVID status has not been mentioned, though it is mentioned very deeply that it is the COVID pandemic. So what is the patient, whether she tested positive or whether she has already undergone a vaccination? None of this is known, and COVID-related nephropathy is also well known. And the FSGS is the most commonest form of COVID-related nephropathy. So rapidly progressive glomerulonephritis, and what about the status of anti-GBM antibody? Like COVID always produces more of a vascular pathology. So I don't think I would rule out the vascular pathology if she turns out to be a COVID positive patient. The vascular pathology associated, but ANCA is negative. ANCA status is not
known. It's not known.
Not known, yeah.
So,
It's very, it's kept in suspense.
Pathologists had all the.
Any other opinions before we ask Dr. Anila Abraham? Clinical opinions.
It's happy to without any extraordinary symptoms, and as Dr. Namrata has nicely teased out all the possibilities of it being intrinsic. I mean, just on the history leaking, the prior lecture that we heard, the MTP was done at 7th week and later the biopsy. So it was, I mean, it would be the first biopsy and then later to decide on what to do. That would be a prudent cause. I would still bet on just looking at the history, though we are pathologists here, pointed on Vinay. I am sure that Vinay would agree that it's more of the intrinsic, as you put out. The IgA would be on the high-end bets, and the COVID is enigmatic, and we would like to know from Dr. Anila, who is from well known to all of us, very good orator. She links the gaps between the clinical and the findings. So let's hear to Dr. Anila to unveil the pathology aspect.
Thank you so much. And respected chairpersons and my dear friends, that was an excellent analysis, Dr. Namrata, and full marks to you for that. And I sincerely thank Professor Edwin Fernando and the team from Stanley Medical College. This was their patient. And the same question I asked is, did the patient have COVID? And the answer was no. And ANCA and anti-GBM were negative. So that was purposely not told to, to give you a wider platform to discuss, a wider choices to make. So let's see what it is. So this was the biopsy here. And you can see that even at low power, it's a very active biopsy. All the interstitial inflammation is very obvious here. So 50% of your answer is correct already. And at this lower power, probably, I don't think this pointer is working. There are some glomeruli here. I hope you're able to see it. And these glomeruli are not normal. You can see mesangial expansion in them. Okay, yeah. So here, even at the low power, you can see that there is some activity happening in the glomeruli. So again, you are right that there is definitely a glomerular component here. There is some globally sclerotic glomeruli too here, and a lot of interstitial inflammation. Now, a closer view. Let's go to the picture on the left. The two glomeruli here with proliferation, and the proliferation is mesangial proliferation. So your diagnosis of IgA by light microscopy, yes, it's still a lot of mesangial proliferation. The segmental sclerosis, yes, that's also seen in IgA nephropathy. What else do you see? Is the interstitial dense inflammation here, and a lot of tubular necrotic debris within the tubules. A closer view of the inflammation shows there are still a number of neutrophils, though there are lymphocytes and plasma cells. There are occasional neutrophilic casts too, and neutrophilic tagging along the tubular basal membrane, which is diagnostic of acute pyelonephritis. So she was treated for acute pyelonephritis, probably not completely. So there was an initial dip response, but the pyelonephritis was, since it was not completely treated, it still manifested in the kidney, and that would be the reason why her creatinine was going up. So the tubular interstitial compartment is an acute pyelonephritis part. Now let's go to the glomerular pathology. But before that, I want to just show you, she's a 32-year-old lady. This biopsy had 12 glomeruli, and there were 3 that were globally sclerotic. Now, you do not expect to see 3 out of 12 globally sclerotic glomeruli in an otherwise healthy lady. But how are you sure? So there's something now, this is the table that we always follow now to diagnose or to differentiate whether it's an age-related sclerotic lesion or a pathological sclerotic lesion. So you first go to the age. Now she comes within the 30-34 age bracket. Then this biopsy had 12 glomeruli. So you look at that on top with the number of glomeruli. And then you go down and then you see what is permitted for her age and for the number of glomeruli in the biopsy is up to 1 globally sclerotic glomeruli is acceptable as part of a routine or physiological process. But anything above that should be considered pathological. So she had 3 sclerotic glomeruli. So definitely there is a glomerular injury which is been not very acute. It's been there for some time, causing global sclerosis. Right, so this is the glomeruli here. We only saw the H&E where there was some mesangial expansion. Now the PAs and the silver. Now PAs and silver are very, very important slides for a pathologist because that gives us a clue. In fact, HE is just for the scanner. We rely so much on these 2 stains. And we have inbuilt controls in all our pathology biopsies. So for a PAs, the tubular basal membrane is, and the Bowman's capsule is considered as a positive control. And for the the silver stain, the tubular basal membrane and the Bowman's capsule appear black, which is supposed to be like normal. A silver positive is supposed to be black. Here it is PAS positive, but I don't know on the screen if you're able to appreciate, probably not. It's not as bright as what I would expect it to be in, say, in like mesangial expansion due to diabetes or something, but there is definitely, it is not a PAS negative thing. It is still PAS positive. But what is happening to silver? It is completely silver negative. So now PAS positive material and a silver negative material, the whole line of thinking goes to another tangent. PAS positive, you still have IgA nephropathy, but PAS negative, IgA nephropathy comes way down the list, except that when you have a lot of immune deficits. Now, what is silver negative? Silver stains collagen. So if it is the mesangium is expanded because of collagenous tissue, it will be black. But if the mesangium is expanded by either the deposits of immune deposits in massive amounts, or if it is by any organized deficits, then you will have a silver, like a myeloid, you will have a silver negative appearance. So this is silver negative, right? And going to the trichrome stain, blue is the positive for collagen here. And this is a different stain of blue than you see here, a little more darker and purplish, which says that there is some material that is not collagen, definitely that is deposited there, which correlates with the silver findings. So what about the pattern of injury? All we saw was a mesangial proliferative pattern. Some areas you can see double contours. So when you see double contours along with mesangial proliferation, that becomes a membranoproliferative pattern of glomerular injury. So on light microscopy, now we have membranoproliferative. I'm leaving aside the tubular interstitial part now. So what are the differentials on the glomerular pathology based on this? A myeloid, yes, because it is a silver negative material. And Dr. Maitri gave an excellent talk on MIDD. Yes, it could be MIDD because that's also negative. Could it be MPGN pattern? Yeah, it is an MPGN pattern, right? Membranoproliferative. Could it be immune complex mediated, complement or chronic TMA? Still could be, because massive deficits may not stain. Immune deficits may not take up the stain on silver. Lupus nephritis, always a possibility. Yes, IgA nephropathy is still on the list. Fibrillary glomerulonephritis, that's another condition where you have a silver negative material. And of course, there's immunotactoid glomerulonephritis. So first step is, after the light microscopy routine stains, we always do a Congo red when it is silver negative. On the left is our patient's biopsy. It shows mesangial expansion, but this material is Congo red negative. This is some Congo red positive. We had a seminal vesicle here with a lot of Congo amyloid, and this is how it should be a bright orange color. It's negative. So this silver negative material is also Congo red negative. So amyloid is now ruled out. It could still be one of the other possibilities. Now, what is the next step that we do? So light microscopy is over. Let us go to the immunofluorescence. So there was G, C3, kappa, lambda. A was negative, M was negative. So IgA is ruled out, right? Closer view of the G, there was intense G positivity over the capillary loops and the mesangium and some areas on the tubular basal membrane also. And this was a Partly sclerotic glomeruli that also took up again to show that the sclerotic glomeruli were pathologically involved. Now I just showed you the staining. It's very important not to just say whether the staining is positive or not. You need to always characterize the staining in an immunofluorescence. Now, all the three pictures I've shown you are, that's blocking the thing. All the three are of IgG in different pathologies. On the top left is anti-glomerular basal membrane disease, where you have a linear IgG staining. At the top, left bottom is a typical granular GBM staining that you see in membranous nephropathy. Now, our patient neither had linear nor granular, and this on the right is typically called as a smudgy positive staining of IgG. Now, that term is diagnostic, so that rules out a lot of things. MPGN, it still could be complement mediated, is ruled out because G is much more brighter. Chronic TMA should have been completely IF negative. Immune complex mediated still, yes, is a possibility. Though C3 we would have expected more. Lupus, yes, you do not have to have C1q positivity. Fibrillary immunotactoid is still there on the list. The next thing is diagnostic. Okay, so whatever we saw as smudgy material there in the glomeruli, as well as partly sclerotic glomeruli and focally on the tubular basal membrane, we had deposition of DNA JB9. So this is just to compare the IF findings with the IHC findings. So now that's straight away you've got the diagnosis of fibrillary GN. Yes, it's a CPC, so we need to put something little tricky here for you. So anyway, it was a scientific committee that chose the case. So this is just an overall picture of light microscopy, a membranoproliferated pattern here, Congo red negative, G intense, smudgy positive, and DNA JB9 positive. So final diagnosis was fibrillary glomerulonephritis, acute pyelonephritis, and then there were some features of chronic renal parenchymal injury with 3 out of 12 glomeruli showing global sclerosis, mild IFTA, and mild arteriosclerosis. So we are 45 minutes behind schedule, so I'm not going into the details of fibrillary GN. Just to tell you that till DNA JB9 was discovered, we were only dependent on electron microscopy. And we all know, all for our MCQs and quizzes, the typical question is size of the fibrils. 8 to 12 and 12 to 24, 30 immunotactoid. But actually, when you sit under the electron microscope, looking at the thing at a magnification of more than 60,000, and the higher the magnification, the resolution comes lower, it becomes more grainy. And what are you measuring? When you see all these 8 to 10, it's not the length of the fibrils, okay? It's the diameter. So just imagine you are measuring the cross section. It's actually practically very, very difficult to measure this diameter and compare this with this. Immunotactoid is easier because it's a tubular structure and the outlines are more darker. So the endpoints are easier to make. Whereas a myeloid and fibrillary is so subjective. And in fact, the institutes where I trained, they rely heavily on the Congo red positivity. Congo red positive, and you see fibrils, it's like fibrillary. Because look at those, the overlap. You may have something that is 12 nanometers. Is it a myeloid or is it fibrillary? So EM is not very reliable. Sometimes diabetic fibrillosis also can look just like this. So until DNA JB9, it was Congo red. But then DNA JB9 completely changed the field for pathologists, and it was like a huge boom. So we know, I'm not going into the theory of DNA JB9. It's now considered a very sensitive and a specific marker with a specificity of more than 99%. So you can now make a diagnosis with confidence of fibrillary GN without an electron microscopy. So clinical parameters, just to look at what is on the right, it's usually of middle-aged people, little more in women, all presenting with proteinuria and renal insufficiency, hematuria, and hypertension they have. Many of them are related to hepatitis, autoimmune disease, and diabetes, malignancy, dysproteinemia. None of our patients, our patient did not have any of these conditions. So though we said it's a disease of middle-aged, ours is a 32-year-old lady. Now, there are case reports of fibrillary GN happening in very young children. The most recent one, this is of a boy from Japan who, during their routine IgA screening, he was picked up for his proteinuria and a biopsy was done. It turned out to be fibrillary GN. And what are the patterns that you can see? Fibrillary GN, just like lupus, can have any pattern. You can have a mesangioproliferative pattern. You can have a membranoproliferative pattern. You can have a membranous pattern. See, when you talk of membranous and spikes, you only think of membranous nephropathy and lupus class 5. But in your list, you should also consider fibrillary GN rarely can present with GBM spikes. Or you can have an endocapillary proliferative, or there are even crescentic fibrillary with more than 50% crescent. So it's a great mimicker. We rely heavily on the IF pattern of staining. So, also, this is a case which we just got accepted for publication. It's not yet come up in the presentation here in IGN. And this was a case where underlying IgA with superimposed fibrillary GN. So that is also a possibility. Fibrillary GN can be a secondary pathology in some conditions. And this was our case where EM showed both electron-dense deficits of IgA and fibrils in the mesangium. Now, to make things a little difficult for us, you have, I just said that it's a great mimic on light microscopy. You have all patterns, and we rely heavily on the IF. There are case reports of IF negative fibrillary GN, but these are the cases that are always DNA JB9 positive. So DNA JB9 is holding very strong in the diagnosis. Again, our first differential we ruled out was a myeloid because it was Congo negative, right? Now there are fibrillary GNs which can be Congo-red positive. So that is adding on to the confusion. But here again, DNA JB9 is always positive. And in Dr. Maitri's presentation, there was a picture where she showed the entire list of pathologies that you can see in myeloma. And she said the CAS nephropathy is the disease-defining lesion. And way down the list was of a monotypic fibrillary GN. Initially, fibrillary GN was considered as could be monotypic fibrillary GN, could be a part of MGRS. That is, only a small proportion of fibrillary are monotypic. Most of them are polytypic like this. You have G, kappa, and lambda. Rarely, very rarely, about 10% of fibrillary GN can have only one light chain. And you cannot immediately, just because it has only one light chain, you cannot straight away call it, just like how we treat PGN-MID. Right, PGN-MID, you have to do a paraffin IF and confirm it. And then you do have to do a IgG subtyping. And only in the end, can you say something is a monotypic? And but with the end of it, now the consensus from Mayo Clinic, which has done extensive work in fibrillary GN and DNA JB9, is it should not be considered as a monoclonal gammopathy of renal significance. Yeah, it's a last slide. I'm so sorry. DNA JB9. Now, all this while we were talking about fibrillary GN as a fibrillary GN. Now, the most latest, which came out last month, is fibrillary tubular interstitial nephritis. Okay, these are conditions where the glomeruli don't take up the stain, and the tubular interstitium alone shows the DNA JB9 positivity. So again, to add on to the variety of spectrum of diseases. So EM is mandatory and EM can be done. Prognosis is poor. Treatment, there is no treatment. Many of them progress to ESRD. It is known to recur in transplant patients up to 30% of the time. And this is a case we had of a post-transplant de novo case. And now to conclude, we really don't know much about the patient. This is what I just got the history from the Stanley Medical College. The patient was put on antihypertensives, lost to follow-up during the peak of COVID, came back, went to the hometown, came back here with severe elevated creatinine. Mother came forward for the transplant, but the patient died within 2 days, probably of a cardiopulmonary event. Thank you.
Thank you, Anila. Before I hand over the mic to my fellow chairpersons, it was kudos to the Stanley team for providing us an excellent case. And Anila, you really dissected it well, dissected as the pathologists do. But a pathologist always has the last laugh. But my heart goes to Dr. Namrata for really presenting it very well, analyzing it very well, and we really enjoyed this CPC. My chairpersons, yeah, full marks. Yeah, over to my other co-chairpersons.
Excellent case. excellent case. This diagnosis of papillary glandular is a surprise to one of us.
That's why it's in the CPC.
Yeah.
Bombshell, yes.
It's always a treat to listen to approach and technique that Anila madam. Madam, I just wanted to know the DNA. Only I have seen there. I have this also.
I'm not aware of IF. IHC is very easy, easily done, 24-hour turnaround time and beautiful staining with no background staining. It's a beautiful stain. Easily done.
Is it available in most of our companies? Because it's something new, right?
No, ma'am, it's available.
It's available.
You routinely do any silver negative, now we straight away do DNA GB9 along with Congo Red. Congo Red and DNA GB9 is done in
like a combo.
Yeah.
That's good. Very nice case. I thank all the organizers for giving us the opportunity to listen to all these exciting things. We really thank Anila and Nita for the excellent presentation. Thank you.
I just want to thank Dr. Anila Brown because she was in Kochi yesterday for a meeting. And immediately after the talk, she came out.
Thank you so much.
Round of applause.
Thank you, thank you. Thank you so much. I wouldn't have missed this for sure. I could have.
We appreciate the professionalism.
Thank you, thank you.
Next year, when ICON 2022 will be held in association with ISOT and Ahmedabad. So we welcome you to Ahmedabad next year, 2022.
So I'd like to call Dr. Kalipani, head of the department of nephrology, Chandra Medical College, Dr. Sheila Parvati. Gandhi Medical College. On behalf of the organizing committee, we would like to thank the organizers for giving us this golden opportunity in the ICON Scientific Acquisition Council. And we are very much happy of the overwhelming response. I request participants who got first place in yesterday's preliminary test, Dr. Shakti and Dr. Bhava Pragna, who got 15 out of 20 marks, and they will be occupying the place of place A, team A. Dr. Shakti and Bhava Pragna from Osmania Medical College. And I request Dr. Jerry Joseph from Stanley Medical College and Dr. Ravi Kiran from St. John's Medical College to occupy the place of Team B. Who got marks of 14 out of 20. And I request Dr. Lohita, Dr. Samuel from Osmania Medical College, who got 13 out of 20 to occupy the chair place of Team C. And actually, third place was acquired by 3 teams. So we are allowing all the 3 teams to participate. So there will be 5 teams to participate: A, B, C, D, E. Dr. Parikshit, Dr. Hithar from Manipal Medical College to occupy the place of Team D.
Dr. Prajwal and Dr. Nikki from St. John's Medical College to occupy the place of Team E. And I request Kavya and Vaishnavi to score the marks. Without any confusion, Team A is Dr. Shakti and Dr. Bhava Pragna of Usmania Medical College, and Dr. Jerry Joseph, Dr. Ravi Kiran from Stanley and St. John's Medical College, Team B, and Lohita and Samuel, Team C from Usmania Medical College, and Porikshit and Ithot from Manipal Medical College, Team 4, and Prajwal and Nitin, Team E. And the rules of quick quiz are, there are total 9 rounds. Each round has one question for each group, and each question carries 10 marks, no pass, and the question will be passed to the audience. And time to answer is 1 minute. After 1 minute, the question will be passed to the audience, and no negative marks. The question unanswered by the audience, and will reveal the unanswered by the audience, will reveal the answer. And in case of any doubts or queries, the quiz master decision is final. I request Kavya to come down and score the marks. Kavya and Vaishnavi. Are you comfortable? Okay, shall we start? So first of all the best for the quiz. Next, and there are 9 rounds. First, we'll move with the anatomy, physiology, and history of kidney diseases. And the first round, the first question will go to Team A.
One second.
After 1 minute, after the buzzer, the question will be passed to the audience, and no negative marks. Answer the question within 1 minute, okay? And the question won't be passed to the next group. Okay, without much ado, we'll start the program. The slides are not. Yeah. So round 1, anatomy, physiology, and history of kidney diseases. All are true about medullary rays of ferrin, except present at corticomedullary junction, part of cortex formed by proximal and distal tubules, formed by collecting duct and stride segment of proximal tubule. It extends downwards and called as ducts of Batting.
Your time starts now. The question is for A. Group A.
we would like to go with option B. Is it final? You have 20 seconds more, so once you say it is over, we will press the button. We'll move to the second question. So you want to fix it with option B. Press the button. So answer is D. It extends downwards and all as ducts of Burton. These ducts of Burton are present in only medulla, and this ferine medullary rays. This is the misnomer. Actually, they are present in cortex. Question to B. Next question to B. Are you ready? So match the following: inner medulla, inner stripe, outer stripe, and cortex. It's a sequelae, and here. One, pars recta, proximal convoluted tubule, thick ascending limb, collecting duct. Second is renal corpuscle, proximal convoluted tubule, distal convoluted tubule, and collecting duct. Three is both thin limb, collecting duct, ducts of Bell limb. And four is thick ascending limb, thin limb, collecting duct, and ducts of Bell limb. And A, B, C, D options. You match the following and let us know what is the correct answer. And your time starts now. Timer. Timer. Sure. Sure. Okay. Then please. Okay. So the answer is B. These ducts of Bell limb are present in medulla. So your correctly picked up. So team B gets 10 marks. Questions to B. All are true about ammoniogenesis except 60 to 70% of ammoniogenesis by proximal tubule, and phosphate dependent glucosaminase is the cytoplasmic membrane enzyme, helps in metabolism of glutamine. Sulfotides are high charged anionic lipids responsible for medulla ammonia load. And increased phosphate-dependent glutaminase activity, increased GDH, and increased phosphoenol pyruvate carboxykinase is it option D. So all are true about ammoniogenesis except. And your time starts now. Timer. So the answer is B, because ammonia is mostly formed in proximal tubule, and that PDG is a mitochondrial enzyme, not a cytoplasmic enzyme. So the answer is B. Next question to B. All are unmeasured anions except albumin, lactate ketone. C is phosphorus sulfate. D is chloride and bicarbonate. Your time starts now. Timer. They would like to go with option B, ma'am, please. Is it okay? So it's correct. Chloride and bicarbonate are measured anions. So team E, identify the picture. Robert Heptinstall, Robert M. Clark, Richard Herrick, and Ronald Lee Herrick brothers, Thomas Graham. So ABCD coined the term dialysis, pathology of the kidney, first successful transplantation, renal biopsy in prone position. You have to match A, B, C, D, you check, and you have to match and you have to select one option. And your time starts now. Timer. Option A. I would like to go with option A. So freeze it. So they would like to go option A, ma'am. Can you read the answer? Okay. Actually, 3 is Herrick brothers, and it's a first successful transplant is C. So C is so the answer is B. So the answer is C, correct. So no. The answer is correct. The answer is A. Yeah. So they get 10 marks. They get 10 marks. Okay. So we move to the second round. The first round is over. And at the end of first round, team A 0 marks, team B 10 marks, team C 0, team D 10, and team E 10. Okay. Now we go to the second round, but in the second round, the first question starts with team B. Okay. So we are moving to second round on glomerular diseases. Identify the picture. You see Robert Koch, F. Monk, J. Cherk, and Olhard. Thanks, sir. They'd like to go with option B. Okay, the correct answer is it is correct answer J. Cherk. So they will get and you are lucky enough. Next question is team C. Team C. The following picture shows WBC cast, RBC cast, granular cast, and hyaline cast. Okay, thanks, guys. It's not if you know the answer, so they would like to go with option B. B. Okay. So it's correct. RBC cast. The RBC cast, they get 10 marks for this. And for D, all are true about collapsing FSGS except higher proteinuria, lower albumin, increased creatinine, fast development of proteinuria, extrarenal manifestation few weeks or days before proteinuria, and common in older patients, white males. True except. They would like to go with option D. Okay. So answer is D. So FSGS are common in younger patients. All are true in primary membranous nephropathy except IgG4 most prominent in IgG deposits, C1q staining 90%, C3 staining over 95%, and TBM staining IgG complete is rare. Complement is rare. TBM is tubular basement membrane. All are true except. It's B. Yeah. B. Yeah, it's correct. C1q staining 90% is wrong. The last question is to be A of this round. Granular IF staining for C3 with no or little immunoglobulin G indicates all except alternate complement pathway dysfunction, C3, infectious MPGN, DDD. Like to go with the option. Would like to go with option. Indicates all except. Just tell the option. They would like to go with option. So it is the correct one. Infectious MPGN with classical pathway, not alternate pathway. So all have 4 equal in this round. So everybody gets 10 marks for this. Now we move to the third round. The third round is recent advances in clinical trials. And this third round starts with the team C. Match the following regarding treatment of membranous nephropathy. Beck et al., Coggins et al., Fervanja et al., Ladunovich et al. Options are PLAR, ACTH, steroids versus placebo, and mentor trial.
Thanks, Raj. They would like to go with option C, please decide. The answer.
The answer is D. So Beck et al. Is PLAR and Coggins et al. Is steroid versus placebo. Fervanja et al. Is mentor trial and Ladunovich is ICTH.
Next question to team D.
Rituximab is preferred in maintenance therapy for ANCA vasculitis in all except PR3 ANCA disease, azathioprine allergy, low baseline IgG less than 300, frail older adults.
Thanks, Raj. Seconds more. Seconds. Yeah. They would like to go with option A.
The answer is low baseline IgG less than 300. Okay, so it's wrong. Team E. Genetic testing in adults with FHG is done to limit immunosuppression exposure where patients resistant to treatment. True or false? Shall I please?
Please. Yeah, please.
Yeah, it's correct.
So they get 10 marks for this. And then last. To team A. Next question is to team A.
Identify the trial in lupus nephritis. ARA LV, Aurora 1, Aurora 2, none of the above. And your time starts now.
Please. So they went with option B, huh? Can you get the answer?
The answer is Aurora 1. Comparison with the oclosporin and MMF combination in lupus nephritis. So answer is Aurora 1.
It is to team B. The last question of this round to team B.
Identify the trial. Nefigan, Protect, Align Study, NefGuard. It's an all in IgA nephropathy.
Thanks, Rajna. So they would like to go with Nefigan option B.
D or A? D. Yeah, it's correct. It's
They will get 10
NefGuard.
marks for it. So we complete all the 3 rounds. So at the end of the 3 rounds, we go for the score. So team A, they get 10 marks, and team B got 30 marks, and team C 10 marks, team B 20 marks, and team E 30 marks. Now we will move to the next set of questions.
So from college, we move to the practice, no? It's more of clinical questions. So the first is on acute kidney injury. So the relate the two images and name the recently identified cause of acute kidney injury in young women. The options are, the first one, option A is supravasamal poisoning due to hair dyes. Option B is keratin treatment associated oxalate nephropathy. Option C is amyloid due to hair dyes. And option D is keratin treatment associated presentic GN. Your time starts now. And the question goes to Team D. So they would like to go with option B, keratin treatment associated oxalate nephropathy. Of course, that's a correct answer. Systemic absorption of keratin is rare, but it is known to occur nowadays. And this is one of the reports from KI. We'll move to the next question, that is to Team E. So all of the following is true regarding trimethoprim and sulfamethoxazole except acute renal failure secondary to sulfamethoxazole is secondary to crystal deposition, and elevation in serum creatinine in patients on trimethoprim and sulfamethoxazole is mainly due to allergic interstitial nephritis, and nephrotoxicity is pronounced in patients with underlying chronic renal insufficiency. Failure of blood urea nitrogen to rise in proportion to serum creatinine should prompt to diagnosis of elevation of creatinine by trimethoprim. So your time starts now. This is to Team E. They would like to go with option B. That's the right answer because not all the time the rise in creatinine in a patient on trimethoprim sulfamethoxazole is due to pathology. It can be because of the competition with the transport, the tubular transport. Now the question goes to A. Which of the following is true regarding acute kidney injury associated with IV bisphosphonates? It is related to its dose and frequency of administration. It is related to the rate of infusion of zoledronic acid, and lower dose with increased frequency of administration is advisable. Option D, all the above. Your time starts now. So they would like to go with option D, all the above, and that's the right answer because whenever we work in multi-specialty hospitals, most of them would write admission and dosage as per nephrologist. So we should be knowing all these things. So now following fourth question, this is to Team B. So which of the following is true regarding contrast associated acute kidney injury? Option A is N-acetyl cysteine is of proven benefit to prevent contrast associated acute kidney injury. IV fluids administration prior to and after the procedure is not recommended in view of risks of exacerbation of CHF in cardiac patients. IV isotonic sodium bicarb is as effective as isotonic saline, and Poseidon trial looked at IV isotonic saline infusion based on LVEDP, that is left ventricular end diastolic pressure, to prevent contrast associated acute kidney injury. Your time starts now. Yeah, they went with option A, and that's the right answer. Because most of the times, as I said, in multi-specialties, they would be asking us the evidence when we start N-acetyl cysteine, they say it's no and all. So this is the latest evidence that we look at the LV end diastolic pressure, and based on that, we can titrate our fluids.
So if the LV end diastolic pressure is less than 13, we have to infuse this at 5 ml per kg per hour. If it is between 13 to 18, it is 3 ml. And if it is more than 18, we try to restrict the fluids in cardiac patients. Next question. This is to team C. All are true about organ crosstalk and kidney except CCR2 plus myeloid cells are involved in kidney vascular crosstalk. Osteopontin is responsible for acute lung injury following acute kidney injury, that is kidney lung crosstalk. And tryptophan-derived uremic solutes are responsible for decreased post-ischemic angiogenic response. Disruption of the central circadian rhythm is intricately involved in the development of parathyroid hyperplasia in CKD patients. Your time starts now. It's a very important question for final years. Organ crosstalk and AKI, they would definitely ask. Twenty seconds. 20 seconds. They would like to go with option C, but the correct option is option D. It is disruption of the peripheral circadian rhythms, but not the central circadian rhythms, which is recently published in Nature Reviews Nephrology. So now we'll move to our own unit, that is CKD and dialysis. This round round 5. Fourth. This is 4 rounds. This is 5th round. At the end of round 4, the first team A 20, team B 40, team C 10, team D 30, and team E 40. Okay. So now the first question is to team. Next E. Okay. So it is to team E. All are true regarding diet and chronic kidney disease except protein restriction to reduce the progression of chronic kidney disease was tested and supported with evidence by MDRD study. High fiber diet reduces the progression of chronic kidney disease. Mid-arm circumference is a validated tool to check the protein energy wasting in CKD patients. High levels of CRP indicates increased visceral inflammation in these patients. Your time starts now. They would like to go with option B. But that's a wrong answer. High fiber do reduce the progression of CKD. C. Protein restriction was tested for the first time in MDRD study, but they haven't proven with support that it is useful. They have proven only DASH diet is useful in preventing the progression of chronic kidney disease. But of course it is true, but that trial did not support it. Okay. Second question, 84-year to team A. So 84-year-old women with creatinine of 1.8 milligram per deciliter. She is treated with denosumab following a low trauma vertebral fracture. Lab test prior to the treatment was PTH 286 picograms per ml, vitamin D 16 nanogram per ml, and total calcium was 8.3 milligram per deciliter. Phosphorus was 4.7. Lab tests were repeated 3 weeks later. What is the most likely adverse effect of denosumab to be observed on laboratory tests? And the options are option A, hypercalcemia, option B, acute kidney injury, option C, hypocalcemia, and option D, toxic levels of denosumab. Your time starts now. So they would like to go with option B, acute kidney injury, but the correct option is option C. So whenever you encounter patients on denosumab, especially if the prior tests are on the lower side or they are having vitamin E deficiency, hypocalcemia is known to occur with them. This is question 3 to team B. All of the following are rhinoprotective gut microbiota except option A, Bifidobacterium, option B, Lactobacillus, option C, Faecalibacterium, and option D, Agathella lenta. Your time starts now. Because day in and day out, after you pass out from your this one, you will be forced to write these things. You should be knowing which is good, which is bad. Yeah. They went with option C, but that is a wrong option. Option B is correct. This is the reference which is recently published in Frontiers in Nephrology. Agathella lenta is one of the, it promotes CKD, instead it reduces the CKD progression. So this is the fourth question. This is to team C. So which of the following drugs mechanism of action is depicted in the given picture? So the option A is sacubitril valsartan, option B is Findrinol, option C is imiglamin, and option D is dapagliflozin. And your time starts now. Just look at the picture because it's the day of infographics. We don't read all the trials nowadays. We just look at the summary. $25 seconds. Only 20 seconds. It's very easy. Just go through the slide carefully. Don't get confused and stressed. Option D. They would like to go with option D, but that's a wrong answer. It's a very easy. It's an antifibrotic drug, which is research now. Everybody are interested to start that drug. That is Findrinol actually. It's a mineralocorticoid receptor antagonist, which is the drug which is known to prevent fibrosis. We don't have any drug till now to prevent the fibrosis of kidney disease, right? But that drug do have some complications, some monitoring of hyperkalemia. We need to be aware of that. So the last question of this round, this is to team D. This is a part of networking. So identify the nephrologist and their current position in ISN. It's also important to know who are what and why are we meeting. And I'm sorry, I have options. So option A is Dr. Sanjeev Gulati, current president ISN, and Dr. H.S. Kohli, president-elect ISN. Option D is Dr. A.K. Bhalla, current president ISN, Dr. H.S. Kohli, president-elect ISN. Option C is Dr. Sanjeev Gulati, president-elect ISN, and H.S. Kohli, current president ISN. And option D is Dr. Vivek Kutte, president ISOT, and Dr. Sanjeev Gulati, president ISN. Your time starts now. It's already started. No, every day you get mails. Just go and check your mails. You will know these answers. That's why I put this question. Welcome to ISN, and the top of the brochure only you will have the answer. So I will know who has looked into the brochure, who has not looked into the brochure. $20 seconds. So they would like to go with option C, but that's a wrong answer. Option A is the correct answer. Okay, so Sanjeev Gulati sir is the present ISN president, and Dr. H.S. Kohli is going to be the president-elect. So we complete the...
At the end of round 6, round 5, team A 20 marks, team B 40, team C 10, team D 30, team E 40.
So we'll move to the next round. That is on RRT, HT and PD.
This question. Team A.
62-year-old female end-stage renal disease patient on regular 3/7 dialysis. She presents with palpable subcutaneous nodule with overlying erythema, which progressed to violaceous rash. So this is a rash. All are true except regarding this question. The cutaneous lesion is because of ischemia and inflammatory response involving the cutaneous blood vessels. Vitamin K deficiency and vitamin K antagonism increases the risk of this condition. Levels of utin A are upregulated in these patients. Copnerization is seen in this condition. Your time starts now. They would like to go with option A. But that is the wrong answer. I have asked all except. So levels of utin A are actually down-regulated in these patients. This is the case of calciphylaxis. Question 2 to team B. 59-year-old female end-stage renal disease, 3/7 dialysis, comorbidities, diabetes and hypertension, had osteoporosis on routine screen. His PTH is 1200 picograms per deciliter, taking maximum dose of calcitrol and ethyl Bone-specific alkaline phosphatase is high, vitamin D normal, phosphorus is 5 mg per deciliter, calcium is normal. Which of the following agents is best for his osteoporosis? And the options are alendronate, B, denosumab, C, teriparatide, D, romosozumab, and your time starts now. They would like to go with option B, please. So that's a correct answer. So in a patient of CKD with high turnover bone disease who is non-dialysis, anti-receptive therapy of choice is anti-receptive therapy. If it is on dialysis, it is denosumab. If it is only low turnover bone disease, we prefer teriparatide. And romosozumab is recently being tried in low turnover bone disease, more so in low turnover bone disease. This is question 3 to team C. Name the curvilinear structure shown in the diagram which is encountered during PD catheter insertion. Because of late we are promoting PD catheters by nephrologist itself. The red line ones. Option A is inferior epigastric arteries. Option B is inferior umbilical arteries. And option C is superior umbilical arteries. And option D is superior epigastric arteries. Your time starts now. It's very important because when we do the procedure, we try to avoid these structures. You want to see the picture again? Sorry. 30 seconds. Fifteen seconds. Option D, you would like to go with superior epigastric arteries, but that's not the correct answer. The correct answer is option A, it is inferior epigastric arteries. So the next question to team B. Identify the process and its advantage in the clinical application. Just look at the picture. I'll keep it for a few seconds and we'll move to the options. Is it done? We'll move to the options. Option A is MARS, which is used in decompensated liver failure. Option B is plasma exchange used in TTP. Option C is double filtration plasmapheresis to reduce the replacement volume in patients undergoing plasmapheresis. And option D is online hemodiafiltration with ultrafiltration monitor. And your time starts now. You want the picture? So your no options is okay. Yeah, they went with option C and that's the right answer. Of late, we are doing more and more of ABO incompatible also. This is more useful in ABO incompatible and highly sensitive transplant patients also. So this is the last question to team E. The kidney project is all about. Option A is creating a bioartificial kidney as a permanent solution to kidney failure, reducing the preventable deaths from AKI to 0 by 2025 to do a successful xenotransplantation. And option D is to provide affordable and accessible kidney care to all. Your time starts now. Of late, all the patients are more educated. They are asking for a permanent solution from dialysis. Option A. So they would like to go with option A, and that is the correct answer. So the kidney project is all about creating bioartificial kidney as a permanent solution to kidney failure.
So at the end of round six, the marks are team A 20, team B 50, team C 10, team D 40, team E 50.
Thank you. Now I'll give over to the podium to Sai Vaniman.
So now we'll move to round 7, transplant immunology and immunosuppression. Now the question to B. So the question to team B. A 32-year-old male, chronic kidney disease, ESRD, mother as the donor without induction on triple immunosuppression with worsening graft function 1 month post-transplant, and creatinine was increased to 2.8 with TAC level of 12 nanogram per ml, and graft biopsy shows isometric vacuolization suggestive of TAC toxicity as it was given in the figure. Recording calcineurin inhibitors, which is false. Cyclosporin was first isolated from 2 strains of imperfect fungi, Cylindrocarpon and Trichoderma. Tacrolimus binds to FKBP12 and inhibits calcineurin. Cyclosporin is almost metabolized in the liver by CYP450 enzymes. Calcineurin inhibitors do desulfation of NFAT protein and helps in translocation into the nucleus. The time starts, which is false. Time starts now. Yeah, it's correct. Actually, it's a dephosphorylation, but here we have written as desulfate. And the question goes to team C regarding mTOR inhibitors. Which of the following is not true? Option A, increased proteinuria due to tubular dysfunction. Option B, Cas nephropathy due to keratin deposition. Option C, collapsing glomerulopathy. And option D, isometric vacuolization of proximal tubules. Which is not true. Okay, they are correct. And isometric vacuolization is seen in CNI. And with mTORs, even Cas nephropathy is seen, but here keratin is deposited and converted negative. Then the question goes to team D. Regarding MHC, all are true except highly polymorphic. MHC class 2 is more restricted than class 1. And class 2 groove, option 3 is class 2 groove is open, accommodating larger antigen. Option D is origin of the peptides in MHC class 1 is extracellular. Only 19 seconds. 15 seconds. So it's wrong. Origin of the peptides in MHC class 1 is intracellular. This is the pathways. They are depicted in Peter Morris. Class 1 is intracellular and class 2 is extracellular. And MHC is important for your final exam. Next, move into team E. Regarding cross match, all are true except CDC positive, flow positive, DSA positive is high immunological risk for rejection. And option B, CDC negative, FCM positive, DSA positive is intermediate risk for rejection. The Amos wash technique used to remove low affinity IgM antibodies in CDC technique. Terasaki used flow cross-match to differentiate HLA class 1 and HLA class 2 antibodies.
Thanks, guys.
Twenty-five seconds. Yeah, it's correct. Terasaki is with CDC and Taylor et al. Is with flow cross-match. Surgery of the Soul, Reflection on a Curious Career was an autobiography of a famous plastic surgeon in the field of transplantation. Identify the person. Sturgill, Robert Swatch, William Demchuk, Joseph E. Murray. Shall I speak? So, you are correct. That is Joseph E. Murray for successful transplantation. Actually, he is the plastic surgeon. And when he was resident during Second World War, one patient of Woods, he was having 70% burns. And there they were doing skin graft from the cadavers, and there they were seeing the rejections. And his teacher told, when you do the skin grafting with the congenic twins, it won't get rejected. After coming to this Boston hospital, he saw 2 twins coming with renal failure. So he thought the immune barrier can be overcome with this congenic twin donor. So he was successful, but he is a plastic surgeon.
So at the end of this round, team A 30 marks, team B 60 marks, and team C 20 marks, team D 40 marks, and team E 60 marks.
And round E, pre-transplant evaluation. And now the question to team C. A 35-year-old gentleman, O positive blood group, and post-renal transplant graft failure within 3 months, ESRD on MHD since 10 months with multiple access failure, and now on AV graft in right upper limb with PRA of 60%, registered in organ transplantation center, registered by NOTO, 7 months back in view of absence of emotionally related suitable donors. The points he gets during deceased donor assessment according to NOTO guidelines. 14, 15, 16, 17. And it is very important because according to NOTO, you have to give the kidney to somebody, having highest marks. So the marks you should know, and NOTO has released recently the 7 guidelines. You have to answer anything fast.
Then it is to audience.
Then it is to audience. Anyone?
Seconds.
Actually, it's D. These are the 7 rounds, okay? And this is the marks for this case, and this case.
For you to memorize that, they can ask is there any district transfer? You should tell them there is transfer.
So you should know those 7 things.
Why the first person is getting money, I'm not getting. They'll ask all the questions are midnight. You should be able to tell this. We have a score. You know to memorize this. Just tell them we have.
Okay. We'll move to next question.
No, it is to next question.
Like team D. Regarding transplantation in HIV patient, everything is true except HIV viral load undetectable and CD4 count more than 250. ART therapy changed from protease inhibitor to integrase inhibitor. Exclusion of Kaposi sarcoma prior. Induction therapy is contraindicated in HIV transplant. Your time starts. Yeah, it's correct. Induction therapy is contraindicated in HIV transplant. It is wrong. We can give induction. Coming to team E. According to TOTA guidelines, 2014, which is false. Grandparents and grandchildren are included as related donors. Swab donations are accepted. During apnea test in declaration of brain death, the PCOT is maintained to 40. Physician, anesthetist, and intensivist can declare the brain death. Your time starts now.
You would like to answer? So they would like to go with option C, please.
C. Yeah, it's correct. During apnea test, the PCO2 should be 60, not 40.
A.
In ABO incompatible transplantation, all are true except the long-term survival is good with ABO incompatible transplantation than DSA positive transplantation due to accommodation. Anti-blood group isohemagglutination titers of less than 1:8 is considered safe. And hemoxygenates 1, BCLXL and BCL2 may be important for accommodation. Rituximab used in desensitization protocol decreases the sensitized plasma cells and decrease the chance of humoral rejection.
Thanks, Rajna. They'd like to go with option A.
No, it's wrong. Actually, long-term survival is good with ABO incompatible than DSA positive, and it's the rituximab used in desensitization protocol for it doesn't decrease plasma cells, it decreases the naive cells. Bortezomib decreases the plasma cells.
So now the B, the last question, because of shortage of time, they are finishing the 8 rounds only. So this is the last question of the quiz and it is taking B.
According to NOTO recent guidelines, the blood group O deceased donor kidney is allocated to the following blood group patient in order. Option A, O, A, B, A, B. Option B, A, B, A, B, O. Option C, O, B, A, A, B. Option C, O, A, B, A, B.
Your time starts now. They would like to go with option B, please.
It's wrong. Actually, O, A, B, A, B.
So I think we have the scores at the end. So team A stands at 40 and team B stands at 60, team C stands at 20 and team B at 50 and team E are the winners of today's quiz. They stand at 70. And stay with me. Prajwal and Nitin from St. John's Medical College. So they get the first prize of the quiz and second prize goes to team B. Please your name. Yeah, from Ravi and Jackie from Stanley and St. John. And third prize to team B. You have that prize also.
Dr. Parikshit and Dr. Hita from Manipal.
Yeah, Parikshit and Hita from Manipal Medical College. But all of them have done really very well because we have tried to include all the questions from basics to fast science. We'll have the prize distribution just. So I would like to invite Renuka ma'am to please give the prize, first prize. I think all of you can collect the certificates from us later.
And I request Prajwal and Nitin to come out.
So Prajwal and Nitin. Team B, second place. Ravi and Jay Prasad. And third prize goes to Team B. They do have a cash prize. Please check it. Congratulations and thank the organizing committee for giving us the great opportunity because we try to put in our clinical experience and basic knowledge into this. Thank you so much. Thank you, the organizer, for giving us this opportunity. So, our next session is now child hygiene and preparing. So, to chair the session, I would like to call Dr. Srikara T. Explain Technology, IIM Bangalore. Dr. Rana Fatima, Head of the Department, Pradima Institute of Medical Science, Karimnagar. Dr. Shankar Prasad, Professor and Head of the Department Nephrology, AMC Manipal. Dr. Asha Mohan, Consultant Nephrologist, St. Philomena's Hospital, Bangalore. And I request the chairperson to introduce the speaker. Dr. Akrita ma'am has a flight to catch, so we are going silent for 9 minutes.
Good afternoon, everyone. On behalf of the WIN and the chairperson, I would like to invite Dr. Chaudhary Madam to give a lecture on trials in IgA nephropathy. Madam is Professor of Nephrology from IPGME Kolkata. Please welcome.
Thank you for your kind introduction. And I also want to, being a part of WIN itself, I'm happy that we could have organized, and thanks to the WIN Karnataka organizers for giving us the nice venue, nice hospitality, and the opportunity to speak before all the trainees, all the enthusiastic trainees I have observed during these 2 days. So we are in IgA nephropathy for a long time. In 1968, it was discovered, and we know that it is a common glomerular disease and we are treating it. Everybody of us are treating it. Still, why the need for a clinical trial? I justify that first, and then we'll step into the trials. The older trials, what did they teach us? How will we make practice points from that? And the newer trials, how they're teaching us for precision medicine and individualized therapy. So IgA nephropathy, a very common glomerular disease, yet perplexing because diagnosed conclusively by presence of IgA on IF and a variety of light microscopic picture. And you can expect the clinical picture will vary as your light microscopic pictures will vary from MCD to MPGN, even a rip-roaring crescentic GN. So strong geographic variation too. If you look at the Western cohorts only, you will find a relatively slower progression over years. If you look at the Chinese data and Japanese data, they are in screening of IgA, picking up IgA earlier, so little different from us. And as shown by this IgA cohort, Susina, all patients from the day of presentation very fastly progressed to IgA ESKD. So in 50% individuals, it's a progressive disease, 20 to 40% progress very fast. And proteinuria is a very, very important marker, along with hypertension, impaired renal function at diagnosis, and two other lifestyle issues come up, smoking and obesity. We are not to forget that people have shown 16% IgAs from the autopsy samples who are quite asymptomatic, present in general population, may be discovered accidentally and should not be treated aggressively anyway, because aggressive treatment has also some cost to pay. So let's pick up a patient and justify the trial's utility. So 28-year male having recent onset fetal edema and hypertension, and a routine health checkup showed that he had a creatinine of 2.3 with 2.36 gram proteinuria per day, undergone a biopsy with a nephrologist and showing M1, E0, S1, T1. We know that we classify IgA biopsy by MESC score, and C is 0. So there is a IgA risk prediction score, which will not tell you that what immunosuppression will you give, but it will tell you that what is the cumulative risk in near future. So do enroll a patient in a disease registry so that you can follow them. And according to this Barber's risk prediction network, as it has published a risk prediction tool, I'll show you that these patients' risk of 50% decline in estimated GFR or progression to ESKD at 5 years is going to be 57%. So this is a high-risk patient. Before this risk tool was available, we used to classify the high-risk patients by the proteinuria, initially 1 gram, then all the trials showed, okay, the worst result is with 2.4 gram per day of proteinuria, even risk is 1 gram, and when goal is for of protein, which we will take as surrogate marker while we will be discussing the trials on IgA. So in view of current uncertainty over the safety and efficacy of two pillar towers, that one is the immunosuppressive therapy and one is the supportive care therapy. The hottest debate, Nephromadness 23, had happened on AJKD blog. The youngs must be conversant with the Nephromadness 23 on AJKD blog, and it was the hottest battle between the supportive care and the immunosuppressive care. So the KDIGO recommendation came out that consider enrollment in a clinical trial, and particularly if your eGFR is more than 30 ml per minute, that you can put them to various different trials and look at what lesson do you gather for the future. So these are the landmark trials, and these are this IgA-ACE published in 2007, this DAPA-CKD and PROTECT all have intensified the supportive care management. Let us look at that. What is supportive care management in IgA? So it is BP reduction, and predominantly with ACE inhibitor or ARB, which was revealed by the IgA-ACE trial that I had shown to you, which looked at the eGFR reduction over a 38-week period time in 45 each arm, where the one group was placebo or some other non-AC derivative for controlling BP, and the other group was on ACE inhibitor. And that established that without doubt that benzapril was used as the ACE inhibitor there. BP reduction, and that too with ACE inhibitor, had become the choice. RAS blockade with ACE ARB for this BP reduction as well as proteinuria reduction. We know that SGLT2I has extended its wings into the domain of non-diabetic CKD, and DAPA-CKD and EMPA-KIDNEY has shown the protection for proteinuria. We know that antifibrotic agents, endothelin blocker and ARB are also coming out. I will discuss those newer trials in detail. The older trials I didn't discuss in detail. So weight loss, smoking cessation, these are also supportive care. So whenever an IgAN drops into your chamber, don't forget to give these lessons too, that they have to go for weight reduction, smoking cessation, dyslipidemia. Fish oil and tonsillectomy are relatively less conflicting evidence and less strong recommendation. And these are all to be considered in supportive care therapy. So then the major trials in the immunosuppressive care, but looking at steroids, budesonide, MMF, Cicasa, hydroxychloroquine, rituximab, and CNI. And we will discuss these few in detail. So let's go to the immunosuppressive care versus supportive care. The first strong trial that was the STOP IgN trial. I'm discussing it in detail because it will be the foundation laying trial for many lessons to treat IgA nephropathy. So it was 162 patients and ultimately 76 and 78 in 2 cohorts who received either supportive care, or I have explained what supportive care is. And on the other hand, these patients received supportive care plus immunosuppression, but the immunosuppression was not a single drug. It was a mixed bag. Some patients did receive cyclo, some patient AZA, some steroid. So that remained a weakness of this trial. It was mostly on the European ancestry, so mostly a white trial, and rest you can see the outcome that at the end of 3.2 years, 3 years, mean 3 years, the composite all-cause death. This is also an important trial because it did not look at the surrogate markers. In trials of this glomerular disease, 2 important surrogate markers are proteinuria reduction and eGFR. These you can take as short-term goal, this surrogate marker. You can look at these surrogate markers for short-term goal of improvement. But when you want to look at the long-term improvement, then you have to take in account the cumulative data of decrease in eGFR, ESRD, or eGFR loss, or all-cause death, ESRD onset time, or individual components of this. And you can see that these 2 arms didn't show any significant difference. Rather, when you look at the side effects, you will find that the immunosuppression arm did have lots of side effects. Then came the question, the proteinuria reduction, eGFR protection, who did better? This group has an eGFR more than 50 mil. So both these groups were then allocated to steroid therapy. So they can look at differentially that which group did better. The high eGFR group did have better, better with the supportive care plus immunosuppression therapy. So when an IgA nephropathy patient drops to you at OPD, you need to look at the GFR first to enroll him to any trial. If it is not an RPGN or AKI, you have to look at the GFR, you have to look at the proteinuria, you have to look at the current clinical renal function that will translate to eGFR, and then you will decide that which group it would go. Repeatedly, the trials have shown people with lower eGFR did worse with immunosuppression. Maybe that they have already turned chronic GN. These patients who had been put in the immunosuppression plus supportive care group in this STOP IgN trial, they were put on therapy relatively longer after the biopsy was done. After the biopsy was done, it was a period of 3 months to 3 years. So many patients might have gone into the chronic GN phase when treatment with any more treatment with immunosuppression will not help them out, rather will give them poor outcome. So you can see the high number of infectious events in the immunosuppression group and relatively lower with the supportive care. So what did we learn from this trial? The addition of immunosuppressive to intensive probably did not improve significantly the outcome loss at 3 years. More adverse effect in immunosuppression arm, and in subgroup analysis, patients with higher eGFR
were more likely to achieve the full clinical remission rather than the lower eGFR group. Now, in 2022, we had a publication of the 10-year follow-up cohort of this STOP IgAN group. It was nearly 92% of the previous trial group who were looked at. It was a retrospective, but median follow-up was 7.4 years. And the primary endpoint, as you have seen, that the ESKD less than 40% eGFR compromise. All these primary outcome happened in 36 patients out of 72 in the supportive care, 35 out of 77 in the additional immunosuppression. So again, there is no significance. Each individual components taken like ESKD, 40% eGFR decline separately, they also showed the same thing, that immunosuppression is no better than the supportive care therapy. Always immunosuppression on top of supportive care. Never supportive care gone, only immunosuppression. So, blood pressure management, dietary advices to restrict sodium intake, protein and fluid intake, lifestyle modifications, as I have already told, and additional measures is to sensitize them against NSAIDs, avoid the prolonged severe hyperkalemic conditions. You may consider hydroxychloroquine. There is a Chinese trial which have shown the hydroxychloroquine as an advantage. SGLT2I currently off label, but it will soon earn its global relevance in this IgA nephropathy supportive care. So then came the tasting study. People looked at that the variable immunosuppression, a bag of mixture. So let's try with steroids alone and let's go down in eGFR. Let's include 20 to 120 mil. So in this testing study, there were 20 mil eGFR2. Proteinuria taken was more than 1 gram. 262 were randomized and 136 and 126 receiving respectively methylpred versus placebo, and minimal follow-up loss, so very good trial follow-up. There was a significant reduction of time average proteinuria. The annual eGFR slope also improved very nicely. Remember the numbers, they will come into relevance when we will compare the trials. It is 2 versus 7 fall of eGFR happened in the placebo group. In comparing the 2 trials, we will show that. But what happened, you see, there were many serious adverse events. There is very significant number requiring to reach the significance level. Very low number of patients need to be treated to reach the significance level, but the serious events are also very, very high. So if you treat 5 people, you reach the steroid treated group, you reach the number of significance to have the steroid level. So these safety outcomes gave a strong alarm that it has to be terminated. It was terminated and it was readjusted to low dose testing trial. Low dose testing trial shows the trial protocol where there is a new recruitment period with the reduced dose. Those who are receiving full dose, again, taken down to reduced dose, and the reduced dose minimum follow-up up to 2.5 years, and the follow-up ended, and they published the low dose testing study in 2022. It also has the hard endpoint like cumulative reduction of eGFR, more than 40%, ESKD, and you can find this is the placebo who experienced more events than the treated group. So placebo experienced significantly higher event. So low dose testing also showed that the steroids or immunosuppression may help, and serious adverse event with the full dose versus low dose has come down from 30 to 5, that is 1/6 reduction of the reduced dose. So we can think of 6 to 9 months of steroid in appropriately selected patient after this low dose testing trial is on, and our steroid dose should be lower. Before putting the patient on steroid, we must discuss with the family the goods and bads on either side. We stratify the risk by the risk prediction tool, and that interview is utmost important while you treat your patient. So it is a stumbling path taken by steroids. The testing was the largest RCT, and as I have told you that it has shown the steroids are effective, side effects have come down. Another concern is that benefits from methylpred may diminish over time. A delay in need for dialysis or transplant is also a very, very important thing that a nephrologist wants, and delay in progression sometimes is encouraging, as it suggests immunosuppression can confer some benefit. The lack of longer term benefit from steroid has been shown in other studies too, 10-year follow-up of IgA. You can see that the testing study is mostly done on Asians, and it was Caucasian. That is one difference. The proteinuria level was 2.4 gram higher, in the mean proteinuria was higher, and the placebo versus the GFR fall in placebo group was much higher when you come to compare this one. Whether all the parameter of supportive care was taken better care here, we do not know. We do not know whether ethnicity have played a role, and the biopsy also is showing a difference in terms of having a lot of M1. So consider enrollment in a trial with this alarms. And then the MMF in IgAN, you can see the conflicting results, and mostly in Chinese population. The main trial is important, which has the question that whether MMF will be effective in patients with IgA nephropathy at high risk kidney function loss with optimized supportive care, and the finding supported MMF use, but in Chinese only. So KDIGO recommendation goes with still now with the use of MMF in Chinese population only, not in general population. The 23 main publication may change it because last KDIGO 2021 was done without main. So this is another patient-focused study which had shown that IgAN patient needs new drugs because they have lot of unmet needs. So the new drugs that came in that looked at the personalized medicine and other pathways of IgA 4-hit mechanism. I'm sure that Shomita will take the 4-hit mechanism nicely because she will talk on the molecule which will deal with the mucosal immunity, budesonide, and B-cell activation, complement activation, inflammation. All these will be addressed by this new drugs, and the targeted therapy is coming in IgA nephropathy. So this is the budesonide, which alters the mucosal immunity, acts at the level of Gd-IgA1 development and the inflammatory cascade over there. So I am talking before Shomita, otherwise Shomita would have taken this and gone into detail. I will not talk about it in detail, but it was done with biopsy verified IgAN. The Nefecon trial was a phase 2 trial, which was done with 16 milligram versus 8 milligram Nefecon and placebo. And it had shown the surrogate marker improvement in terms of time-dependent reduction of significant reduction of UPCR and significant reduction of eGFR after the 9 months therapy. Similar, we had done in our institute, and we had published it. We had shown it in the WCN, so it had gone for abstract publication in KIR, that how budesonide we were using Budes here, which was available for treatment of the gastro patients, and we picked up that, and that is the conclusion is that we observe significant proteinuria improvement, significant GFR improvement. Give me 5 minutes. And total incidence of treatment emergent adverse events were similar across both the groups. So this was an evidence with Indian patients which are lacking. So I think when we will it will be published soon. So it will definitely give you some extra point on Indian patients. So 27 patients who received budesonide, 4 had uncontrolled blood pressure. We excluded them from analysis. And rest patients, when we looked at, it was observed the patients with increased proteinuria were of younger age group, and most of them had M1, E1 lesions in their biopsy. We did a follow-up after withdrawal, and we think that we may need to prolong this budesonide therapy. Similarly, NefIgArd came where Dr. Bharat really prolonged this up to 12 months. And after that, he also showed a proteinuria reduction and EGFR improvement. So budesonide has come up on top of supportive care therapy as a promising therapy. And few molecules from Mediat and Forts are available. One is Eganef, which we are using also. So overall safety data is comfortable. I'm not going to the new progress I'm coming to. The new progress in supportive care is targeting the endothelin pathway, and the new progress in immunosuppressive care is targeting the complement pathway. The new progress in supportive care, you see the mesangial cell proliferation, that can be the cytokine release can be blocked by ET1 Ang2 blocker and ET1 blocker atrasentan, and both blocker sparsentan are being tried. And they are the cause of inflammation, ECM production, podocyte distortion, endothelial dysfunction. And tubulointerstitial inflammation is another candidate to interfere with, and mediators like ET1 and Ang2 are playing role there. So sparsentan, atrasentan, bardoxolone, all PROTECT is already published. So in phase 3 study and shown promising accelerated FDA approval, it did get, and Affinity Phoenix are on table. So then came the question, it's the PROTECT, I'm not going into detail. It caused proteinuria reduction and EGFR improvement, unclear benefit on long-term EGFR preservation, only surrogate endpoint we use, and it is limited to GFR more than 30, whether less than 30 will be benefited by this supportive care, we do not know. In IgG biopsy slide, no C1q is present, but C3 colocalization more than 90% and many other other complement components. So people looked at which are alternative and lectin pathway involvement, and yeah, really it is the lectin and pathway involvement and alternative pathway involvement. You can see the hits that can activate this pathway, and we can well appreciate that IgA triggers are the infectious event triggers. So the microbial carbohydrates, MBL, MASP1, 2, endotoxin, bacterial cells, take over. They can activate the complement pathway. They can take the lectin or alternative. They will converge upon the C3 convertase. BD will remain the important player. The proteins, FH proteins, FHR proteins are also expected to be players. So people have started to see that whether these inhibitors like this antisense factor B inhibitor, C3b inhibitor, C5 inhibitor, MASP2 inhibitor, all these can do some good for IgA nephropathy. All these are in phase 2 trial, and they are soon going to give us important input which can personalize medicine later on. Iptacopan, ravulizumab, and vemicopran are also the monoclonal antibodies that are being tried. So can we predict future? We look forward to a greater supportive care optimization is definitely a rule. New option targeting production of abnormal IgA. We can use this mucosal immunity, barrier protection, new option targeting mucosal immunity and complement pathway, both. Many of them are in phase 2 trials, and we know that the future depends on what we do in present. So definitely we have to follow this clinical trial enrollment and staying up to date with the clinical trials that are coming up, and exercising the use of maximal renoprotective things for our IgA patients. This is an invitation for ISOT to all. Please come, join us, and have an academic feast. We have a lot of things to do with you.
Hear me? Hello? Wonderful time. Only thing, see, we are attaining IT. So all of my patients, more than 80% of our patients, they present with advanced clinical. You know, it's a diversity of presentation, diversity in treatment also. Yeah. And we are using budesonide for so many years and getting good results. So can we, whatever the immunosuppression, can we based on best score? That's what, if there is a E1 best score.
Yeah.
Yeah, see, if there is a E1 and
We
C,
got,
definitely we need to use some immunosuppression.
yeah. What we have looked, the Valiga cohort did tell us that E1 is a group which may improve with immunosuppression. Valiga cohort analysis had shown it tilt towards the E1 may respond to immunosuppression. But here we, in our trial, is very small handful number of patients. For predicting that, we have to go for a multicentric, biopsy-based and very well followed up cohorts. Otherwise, we cannot do it. People have tried to ascribe the biopsy as the predictor of the immunosuppression therapy. But the Valiga cohort, the clinical and pathological cohort, they tried to work together, but it did not come as successful as to predict, well, E1, you go for immunosuppression, M1, you go for immunosuppression. But definitely that if you have lot of sclerosis and tubulointerstitial chronic injury, don't go for immunosuppression.
Yes.
If your EGFR is too low and it is not an AKI and RPGN presentation, don't consider immunosuppression. Because
See, doesn't come. The patient was on AJ nephropathy, diagnosed AJ nephropathy, doing well with our immunosuppression. She was all right.
yeah, it's
Suddenly she
been-
came with RPGN. Then we did re-biopsying. She had present come. So present cancer is now more common in Indian also because previously there were no present, now she was present information.
that can happen, can happen.
Yeah, that can happen.
Good afternoon, madam. Can I ask one question?
So I want to, as sir said, Vivistanide has been used in the INU from quite some time, and I have a good experience with that. Sir, Vivistanide can be given in the lowest people also.
Yes, no, we are using, actually we are using only protein mineral test, even creatinine cannot be there for small we are using Vivistanide. And see, one thing we have to remember, 3 milligram of Vivistanide is equal to 10 milligram of also. Because see, we are used for 9 months. We use for middle 9, what is the 16 milligram? No? 16 milligram might not available. 15, make it 15, because 3 tablets, 3 milligram to 3 weeks. For 9 months.
Shomita will take one budesonide molecule.
But here it's a control risk, it's not target. That we have to remember. Whatever you are having is control risk.
Not the
Not
Tarpeo.
Yeah,
Not the Tarpeo that has been used in Nefigard. It's
Yeah.
not the Tarpeo.
it's not a target. Getting good with that.
So next is the role of SGLT2 inhibitors in IgA nephropathy. It is now the new standard of care actually. A low dose of DAPA and EMPA can usually help for proteinuria.
That can be additive.
Yes,
You can
yes.
add with the AC
AC inhibitors, after optimization of AC inhibitors, we can add on SGLT2. Along with that supportive therapy. And if the patients are not responding, we can go for steroids. And the newer drug is Sparsentan from Protectra, which is coming as a brand name of Filspari. Yeah, we've not used, but this is the literature.
Yeah,
that,
irbesartan versus Sparsentan, 300 milligram irbesartan versus.
You can start using that. What is the pyranodol? That is also known.
We have also
How long we can give Vivistanide or
Yeah, we have followed what was published in the Nefecon because we did in between Nefigard and Nefecon. We did it 9 months, but in Nefigard, Dr. Barrett has used it for 12 months. And we had made a question at the end that we do not know how long we need to be using this budesonide, that we can increase the span and look at that whether the risk-benefit ratio. It doesn't have any serious adverse effects, but after 9 months, I have observed some cosmetic disfigurement, some swelling of face. So part of it is definitely systemically absorbed, not that 100% is not absorbed. But infectious events, 0. Both the group, as those were directly under our follow-up in our GN clinic. So infectious events were no excess. In both groups, it is comparable. Madam, even if you consider a 2.4 gram proteinuria, that is subnephrotic, but you put the whole thing as it is in the IgA risk prediction tool. It is not only proteinuria that is conferring the risk. The risk prediction tool, if you regularly do, it will take only 2 minutes. That is available.
Is it an abrupt stop? Is it an abrupt stop?
Yeah, it was no, we did it, we did it, tapered it over 3 months. In our protocol, we tapered it over 3 months.
You have to decide. The patient, I am tapering since only 2 years, 3 years also.
If the patient has taken oral steroids, can we use it? Maybe given for
Yes.
oral steroids taken.
Yes, we had done an unpublished trial with steroids too in EGFR less than 30, as it was in the testing protocol. But that showed us that steroids have let it down for some period, only to have a rise again after 6 months, 12 months, 14 months. There was a rise of proteinuria. Now we have used it after 6 months. For previous 6 months, we didn't allow use of any immunosuppressive in the trial. If it is more than, there are patients who are had been given steroids, but there is a gap of 6 months minimum who have received this budesonide in our trial.
Thank you, madam. Thanks for the wonderful discussion.
Thanks to chairperson for wonderful insight on IgA nephropathy. Moving on to our last session before we break for lunch. The topic is budesonide, molecule and mechanism of action. And I would like to invite the chairpersons on stage, Dr. Rashmi, consultant nephrologist, Medical Hospitals, Bangalore, Dr. Vijay Kher, Chairman Nephrology, Epitome Kidney Urology Institute, New Delhi, Dr. Maria, consultant nephrologist, Regal Hospital, Bangalore, Dr. Sampath Kumar, consultant nephrologist, Meenakshi Mission, Madurai. The speaker is Dr. Soumita Bagchi, Associate Professor, All India Institute of Medical Sciences, New Delhi. She will be talking on more of budesonide molecule and the mechanism of action. Over to Soumita. Ma'am, you can maximize your screen and start speaking.
Just 1 minute. Am I audible?
Yes, ma'am, you're audible.
Yeah. Good afternoon, everyone. And at the outset, thank you for the invitation. I am sure everyone is hungry. It's past lunchtime, so I'm going to try to be brief, especially since a large part of the discussion has already happened during Dr. Arpita's talk. So I'm going to be talking about budesonide, the molecule and the mechanism of action in context of IgA nephropathy. We all know this is a challenging disease, and despite numerous research and papers and a lot of trials, about 20 to 40% progress to end-stage kidney disease in 10 to 20 years. And the treatment beyond supportive therapy remains unclear. We know that Asians have a more severe disease compared to the Caucasian population with a poorer renal survival. And as of now, all guidelines say that steroids, systemic corticosteroids should be the first line immunosuppression used in patients who have severe disease. So if we are already saying this, then why do we need an alternate molecule is the question. I mean, an alternate steroid. So all the debate about efficacy versus toxicity of systemic steroids hovers around the STOP IgAN testing trials. We know that these two seminal trials looked at immunosuppression compared to supportive treatment in IgA nephropathy and came back with diametrically opposite results. STOP IgA said that no, immunosuppression doesn't give any additional benefit, while testing said that yes, patients treated with methylprednisolone have a better reduction in proteinuria and stabilization of eGFR. So what was different between these two trials was essentially that the ethnicity of their cohort. STOP IgA had a Caucasian cohort, while testing had predominantly Asian patients who are known to have more severe disease, which is more likely to require immunosuppressive therapy. But one thing they agreed on, both these trials, was that systemic steroid use was associated with frequent and serious side effects, especially serious infections, and this was especially true when conventional dose of steroids was used. The other problem is that being a smoldering disease in IgA, we often, when in our clinical practice, see that initial steroid use may bring down the proteinuria, but then the disease again relapses. So do we need long-term immunosuppression? And that has always been a matter of debate, and there is a lack of long-term studies in this regard. And so if we have to give immunosuppression for a longer period of time, do we need a safer drug? We all know, and we all say that, yes, KDIGO says give steroids, but what it actually says, if you read between the lines, is that all these patients who have severe disease, persistent proteinuria more than 1 gram a day despite optimized supportive therapy, should be first offered the chance to enroll in a clinical trial with novel drugs. But this is not always feasible, especially in low middle income countries like India. We recently did a survey with nephrologists, and we found that in low middle income countries, including India, only 8% nephrologists said they would discuss the option of a clinical trial with a novel drug with patients. So basically, we need a safe and safer drug. Now, when it comes to corticosteroids also, KDIGO has put in a lot of caveats. You should be using it caution in patients who have advanced age, eGFR less than 50, diabetes, obesity, latent infections, which would be a large chunk of our patients. Over and above this, we know that in the Indian scenario, the infectious disease burden in the communities per se high, and tuberculosis is endemic. So steroid use is always a double-edged sword in our patients with IgA. And so there's always been a search for a safer immunosuppressive agent with a proven track record in safety. The question of budesonide came in when the discussion started about the gut-kidney axis and the pathogenesis of IgA nephropathy. We know that the gut-associated lymphoid tissue secretes a large amount of IgA per day, and it houses a large number of IgA-producing lymphocytes, about 80% of the total immunoglobulin-producing cells in the body. Secretory IgA is an important first line of defense against microbial invasion, and most plasma cells in the small intestine secrete IgA1. Now, the Peyer's patches, which are basically lymphoid follicles located mainly in the terminal ileum and the colon, they form an important component of the gut-associated lymphoid tissue. They are major antigen sampling sites and inductive sites, and they house the mucosal B cells, which produce the IgA1. So we are all conversant with the 4-8 hypothesis, which is usually used to explain the pathogenesis of IgA nephropathy. So what happens is, in patients with IgA, due to an immune dysfunction, they produce an abnormal form of IgA where there's abnormal galactosylation. It is typically known as the galactose deficient IgA1. This is the first stage, which stimulates the production of autoantibodies to this antigen, which forms the circulating immune complexes. And these circulating immune complexes then get deposited in the kidneys, where they stimulate the cytokine production and activate the complement pathway. This leads to mesangial cell proliferation as well as extracellular deposition, podocyte injury, proteinuria, which eventually can progress to chronic kidney disease. Now, when we associate this 4-hit hypothesis with the gut-kidney axis, the newer thought is that the mucosal immunity system in the gut is abnormal in patients with IgA nephropathy, and they play a major role in producing this galactose deficient IgA1 molecules. What happens is when the mucosal B cells in the Pierce patches are activated by antigens from the normal gut microbiota or even other antigens, they undergo a class which they start producing galactose deficient IgA1, which is the first hit in the IgA nephropathy pathogenesis. So the idea was that in some way, if we could target this gut-associated lymphoid tissue so that the galactose deficient IgA1 production could be stopped in some way without getting the systemic side effects of that immunosuppression, then it would be beneficial for the patient. So basically, the search was for a drug with a potent topical action at the gut level without having significant systemic side effects. So why budesonide? It is a synthetic corticosteroid which has a very potent glucocorticoid activity. Which is and weak mineralocorticoid effect. And its potency is actually 200 times that of hydrocortisone and 15 times that of prednisolone. So at the level where it acts, it is a very effective anti-inflammatory and immunosuppressive agent. And so if any way budesonide can be delivered locally to the distal ileum and the colon, which houses the highest density of the Pierce patches, this would facilitate a local anti-inflammatory effect, suppress the mucosal B cells, and decrease the production of the galactose deficient IgA1 molecule. Now, the dwell time of budesonide in the bowel compartment is around 1 to 5 hours, which would be sufficient to allow this effect to work. The other advantage of this molecule is that it has very poor systemic bioavailability. So less than 10% active compound, which is absorbed, actually enters the systemic circulation. So despite a potent local effect, the systemic exposure is minimized, and so the related corticosteroid-like side effects would also be minimized. 90% of the active budesonide compounds absorbed in the ileum undergo first-pass metabolism in the liver to metabolites with low glucocorticoid activity. However, we should remember that there is some systemic absorption, and because of this, patients on prolonged budesonide therapy show a significant reduction in plasma cortisol concentrations after about 10 weeks due to the negative feedback effect. So some adverse effects of corticosteroids should be expected if the drug is reaching the ileum and the colon and acting there. The other thing we should remember is there are certain situations in which the systemic absorption of the drug is increased, and so the corresponding side effects, the steroid-like side effects, would also increase. So if a patient has liver disease and because of that, the first-pass metabolism of the drug is reduced, then the systemic absorption systemic bioavailability would increase, and so would the side effects. So ideally, you should not be using steroids or any immunosuppression in secondary IgA nephropathy, but if one tends to do that in patients with secondary IgA due to liver disease, one should be very careful about using budesonide. Concomitant use with other CYP3A inhibitors like CNIs and erythromycin and ketoconazoles also increases its systemic side effects because budesonide is primarily metabolized in the liver by the CYP3A enzymes. The safety in pregnancy is not known. Same holds true for lactating women. And if you are using it in lactating women, then the growth milestones of the baby should be monitored. So with these unique pharmacokinetic and pharmacodynamic effects of budesonide, the enteric-coated budesonide molecules were developed a long time back, originally to treat inflammatory bowel diseases where they have been routinely used now. The initial molecules came with a polymer-coated capsule, which was a pH-modified formulation. So basically, it was resistant to gastric acid degradation. So the active molecule would be released beyond the stomach, mainly in the gut, in the ileum, but to some extent in the duodenum as well. Some molecules have an additional matrix of ethyl cellulose with budesonide, which can further modulate the release of the drug into the intestinal lumen in a time-controlled manner. 70 to 80% of the active drug gets absorbed from the gut. Of course, most of it gets metabolized in the liver. But if there is chronic intestinal inflammation due to any reason, the systemic exposure to budesonide again may increase. So as of now, three types of commercial formulations are available. One is a pH dependent release only. The other is a pH and time dependent release due to the ethyl cellulose matrix, which is what is commonly available in most commercial formulations in India. And the third is a multi-matrix structure with gastric acid resistant coating, which also they claim has a better controlled delivery to the colon. So these formulations have been around for a long time, but the interest of using budesonide in IgA came when a new formulation was developed. It used to be known as Nefecon. It is commercially now available as Tarpeo. They said that they used a modification of the target starch capsule technology, which allowed a pH-directed release of the active compound in the distal ileum and proximal colon. Additionally, what they had is inside the larger capsule, they had triple-coated beads, which contained the active budesonide molecule, and the active drug was released from these beads in a time-controlled manner. This target starch capsule technology is not specific for this formulation for Tarpeo. It was actually developed to permit the targeted delivery of active molecules in the gut to the ileum for a variety of bowel diseases. So the first data came in 2011. It was an open-labeled, uncontrolled proof of concept study with 16 patients of IgA nephropathy, 8 mg per day dose given for 6 months with a 3-month follow-up period with a 23% reduction in the albuminuria and stabilization of eGFR. And the drug was well tolerated in these patients. Based on this, the phase 2 trial was done, the Nefigan trial, which was published in Lancet in 2017, which compared 16 mg per day of budesonide with 8 mg per day and placebo, treatment given for 9 months. They concluded patients with milder disease about proteinuria more than 0.75 grams per day and eGFR more than 45 mils per minute. As you can see here, there was a significant reduction in proteinuria compared to the placebo therapy. And what was even more interesting was the stabilization and a relative improvement in eGFR. The author said that the patients, the adverse effects were similar in both groups, but 16 patients did have to withdraw from budesonide therapy because of adverse effects, and most of these were corticosteroid-related adverse events. After this, the Nefigard trial was done. It was in 2 parts. The part A trial results have just been published in KI in 2023. It compared Tarpeo at 16 mg per day with placebo, 9 months therapy followed by 3 months off therapy when the drug was tapered off. The 12-month results have been declared. The part B is going to look at a larger cohort, and the treatment protocol remains the same, but they're going to follow up the patients for another 12 months without therapy to look at the effect of Tarpeo on eGFR. If you look at the cohort, the placebo compared to the Nefecon group, first thing is only around 11 to 12% Asians. And we know that Asians have a more severe disease. So can we really extrapolate these results into our patients is a question. Of course, they did include more severe patients with about 2 grams of median proteinuria and about 60% of the patients having an eGFR less than 60 mils per minute. The results, again, were very encouraging. The proteinuria decreased significantly, about 48% lower in patients treated with Nefecon compared to those who were on placebo. But what was even more interesting was the stabilization of eGFR. Patients who were on Nefecon actually showed a rise in eGFR in the initial 3 months, which the authors haven't really been able to explain. But there was a relative improvement in the eGFR if you compared it to the placebo group. And when they did the subgroup analysis, the eGFR benefit was seen in those who had more severe proteinuria, more than 1.5 gram per day. Overall, the drug was well tolerated with similar infection rates. And based on this, the FDA granted accelerated approval to Tarpeo for reducing proteinuria only in those patients who have a risk of rapid disease progression, which they defined as a proteinuria more than 1.5 gram per day based on this study. So this is well and good, but this drug is not available in India, unlikely to come, and very expensive. A month's course is about $15,000 a day. I don't think there are too many patients in our country who can afford it in the long term.
5 minutes left.
Yeah, I just have a couple of slides. So experience with other budesonide molecules. Formulations. This is a trial, this is a retrospective propensity match study from Romania comparing 18 patients with budesonide therapy and to 18 patients who received conventional steroids. Budesonide was given for 12 months at 9 milligram per day, tapered to 3 milligram per day for 12 months. Significant reduction in proteinuria, though the eGFR stabilization was not as dramatic, and the drug was well tolerated. This is Dr. Arpita's data. I'm not going to cover it again, but he showed a very good benefit with budesonide therapy. It was well tolerated. Only issue was they gave it at 18 milligrams per day, while the approved dose of these formulations is 9 milligram per day, and that is what has been used in most other studies. So comparisons may be a bit difficult. This is a small case series from Spain looking at 14 patients, both transplant and native IgA. Again, well tolerated and significant reduction in proteinuria. However, a recent case series in KI looking exclusively at recurrent IgA nephropathy after transplant reported that other budesonide formulations, enteric-coated formulations, don't work in these patients. The authors argue that these patients are already on significant maintenance immunosuppression, so maybe that is why if they still develop recurrent disease, budesonide may not work. Adverse effects mainly are hypertension, edema, dermatologic effects, weight gain and dyspnea, and GI side effects. And these are the side effects reported both from the trial with Nefecon and other budesonide enteric formulations. Comparing are the two drugs the same? I'm not sure, because Nefecon says that it is a more targeted delivery, while the other budesonide formulations, they have a controlled and a delayed delivery, but more uniformly in the ileum and the colon, while Nefecon says it's more to the distal ileum. The formulations are definitely different. Tapio has 4 milligrams of budesonide per pill, and enteric budesonide has 3 milligrams per pill. The doses are also different. So the therapeutic efficacy and adverse effect profiles may be different. A head-to-head trial would be interesting and practical, but I don't think that is going to happen. So I'm going to leave you all with a patient in a real world, 42-year-old male, hypertensive since 2 years, presented with a creatinine of 2.2 and a urine protein of 2.9 grams, biopsied outside, IgA nephropathy, M1E0, S1, T1, C0, did not respond to supportive treatment, was started on oral prednisolone, did not respond in 8 weeks, tapered off. MMF was added 1 gram per day, and within a month he developed tuberculosis. So of course, all immunosuppression was withdrawn and ATT was started. This is when he came to us. We decided his creatinine was rising, so we gave him oral budesonide 9 milligram per day. This was 2 years back. We gave it for 9 months and tapered it over 6 months. This is what happened to his proteinuria. It reached another of 0.6 grams per day and then started rising, creeping again when we tapered off the steroids. But the eGFR did not show a dramatic improvement as you see with Nefecon, but it did stabilize very well. So yes, with the current data, we do use budesonide at our center, but we would use it in patients where either we cannot give conventional immunosuppression like this patient at high risk of adverse effects, or when the proteinuria is more than a gram, but still is in the subnephrotic range, and the eGFR is stable more than 45, so that we can monitor and there is not a high risk of progression, which would endanger the kidney function very fast, where rapidly close monitoring is not possible. So yes, as of now, there is some role, but we should remember that what has been approved by FDA is a specific formulation of budesonide and not just the molecule per se. And this trial was not based on Asian patients. There were only 10% Asian patients in this cohort. This formulation is not available in India, but what we have are enteric budesonide molecules which act locally at the gut. But what we know is that these drugs which are available in our country have an established safety record because they've been used for a long time in inflammatory bowel diseases. But we do need more RCTs in Indian patients using these formulations to be more sure about the efficacy of these drugs. Thank you.
Nice talk, Samita. So
Thank you, Dr. Samita, Can I hear me?
Yes, I can hear you, sir.
Yeah. So a question that I want to ask you is, very often we do get patients whose biopsy shows a few crescents. It will not amount to crescentic IgA, but crescents are there, less than 20% of them glomeruli have crescents. Do you advocate this budesonide for such individuals?
So, sir, when we did a study on supportive treatment some time back, which we published in KI reports, we had some of these patients in them, patients with C1 crescents.
Yeah.
So actually, we thought that C1 crescents patients would not do well with supportive therapy, but they did. So it depends more on the level of proteinuria and the eGFR. As I said earlier, I would not use budesonide if I'm seeing a rapid decline in the eGFR, or if the GFR is less than 45, or if the patient has severe nephrotic range proteinuria more than 3.5 grams. In those patients, I would still go with 0.5 mg per kg steroids, Vizalone, I mean prednisolone.
Thank you.
Hi, Somita. This is Dr. Rashmi here. So it was a very nice talk, quite enlightening on budesonide. IgA nephropathy is one of the diseases where you're trying to handle the cause. Initially, it was tonsillectomy. Now we have moved lower down. So the payers packages, but yes, like what you said, it is a very targeted release, and the IgA nephropathy spectrum is very varied. Like if you see a patient who is just nephrotic and only 0.9 creatinine to ESRD. So budesonide is like in a very narrow spectrum of patients. So do you use it? Because in the previous case you discussed, it was not the right choice to make when the patient's GFR was not very high.
No, I would see in that patient, I did use it because I could not have given corticosteroids as prednisolone or MMF because he was being treated for tuberculosis. So if you have a patient who has a high risk of infection and you do not want to give conventional immunosuppression, then I think giving budesonide and monitoring closely, because if you don't give anything in that scenario, the chance of disease progression and the patient losing the kidney is very high in our patients. They just progress very fast. Of course, you still have SGLT2 inhibitors now, so that is something you need to keep in mind. But the problem with SGLT2 inhibitors, I think, is, I mean, DAPA-CKD is good, EMPA-CKD is good, but those trials were not designed for studying IgA nephropathy. And we had 260 patients, some of them were not even biopsy-proven IgA. And you have to understand that the SGLT2 inhibitors also cause pre-renal AKI. If you combine SGLT2 inhibitors and ACE inhibitors, this is something we see a lot in our referral patients. It is started, patients come up for a follow-up after 3 months, the creatinine just shoots up. So you have to monitor closely. And the other thing I really wanted to say is, there's no point in giving everything together. You know, you start ACE inhibitors, you wait for some time, you add, you make your choice. You want to give budesonide or SGLT2 inhibitors, and then you wait. I mean, loading a prescription with everything, and these drugs are not inexpensive. You know, SGLT2 inhibitors are still cheaper. Budesonide is a relatively more expensive drug. But if you want to give it to the patient long term, it is better to go by a stepwise approach and see what works and what doesn't.
Exactly. Whenever there's a new therapy, there's a lot of uproar and usage of the drug. But definitely, it is not the exact targeted release drug which was used previously. That is not what is available here. So we also do use it in our center. I do see that patients do stabilize, but it is a very narrow spectrum of patients in which you can use it. But still, I would, in case the patient has nephrotic range, suppose let us say a patient has nephrotic range proteinuria, only 0.9 creatinine, I would still go with the time-tested therapies, not go with budesonide. So
exactly, but the safety profile.
Currently, it is just an adjuvant
management. Profile is really good. That is something I really like with this drug.
Yeah, so we'll have to stratify patients like where we can use it. Yeah, and definitely it is not very safe, like what we said. Like it has much better effects than oral steroids. Definitely not. That's why they have not committed saying it is safe in pregnancy and lactation. And it is not the recurrence in transplant is again the same mechanism, so it doesn't work there. Yeah. Good. Thank you.
Dr. Sobhita, I've got a question for you.
Yeah.
Dr. Sobhita, you're able to hear me?
Yes, yes.
Yeah, I'm Dr. Rana Fatima. In your patients, you are following after giving this budesonide, you're following the cases by this clinical markers like your urine protein and GFR, can we go for serological markers like IgA because you're targeting the factory of this abnormally galactose-laden molecule?
Okay.
So that will be more.
So we did a galactose deficient IgA level study. It was the first study from India, which we published a few years back. And prognostically, we didn't do serial monitoring, but the baseline levels did not predict the outcomes. I know that Susina's data from CMC says that prognostically the outcome may be predicted from the baseline levels. Now, if you look at the papers on galactose deficient IgA levels, for every paper which says this biomarker works, there are 5 papers which say it doesn't work.
Yes.
So we really cannot say, I mean, it would be interesting to do a study giving budesonide and monitoring the levels serially, but as of now, there is no data for that. I mean, the TAPEOS, the Nefecon trials have looked at galactose deficient IgA, and there is some reduction, but it is not like, I mean, we really can't comment on it as of now.
We have more objective evidence of what we are saying. I think once we have those levels correlating with the clinical parameters.
We need to do a study like that first.
Good. Thank you. Thank you.
Yeah.
Thank you, ma'am.
Thank you.
Chairperson, thank you.
Lunch is being served in the second floor, but since the international speaker has joined, we're continuing with the session. Those who want to have lunch, please proceed and have lunch.
Next topic is evaluation management of CKD mineral bone disease. And to chair the session, I would like to call upon Dr. Shyam Bansal, Director of Nephrology, Kidney and Neurology Institute, Medanta, Gurugram. Dr. Manisha Ramay, Professor and Head of the Department of Osmania Medical College, Hyderabad. Dr. Prabha Senguttalam, Professor Nephrology, Sri Ramachandra University, Chennai. Dr. Aruna Acharya, Head of the Department, SCP Medical College, Hyderabad. And I now request the chairperson to introduce the speakers.
So, good afternoon all. Am I audible?
Yes, ma'am.
Okay, so thank you very much for inviting us here. And it's my privilege to introduce the next speaker, Dr. Ruxana Shroff. She is a professor of pediatric nephrology, Great Ormond Street Hospital, Foundation Trust, UCL Great Ormond Street, Institute of Child Health, London, United Kingdom. She is a very erudite speaker. I've heard her speak on many occasions, and she is an excellent speaker on the topic given, the bone mineral disease. We know that it's becoming very important, and it's not only a disease of bones, but it's in a way a systemic disease with vascular involvement also being quite common. And we have new guidelines about the diagnosis of the disease. We have the new markers as well. We have the DEXA playing a role there, and also the role of bone biopsy, which we don't do very frequently in India. And now we understand we have to treat the individual as a whole, not look at a biochemical parameter and treat that. We have to take all into consideration. So I would like to invite Dr. Shroff to proceed with her lecture. We are really excited to hear her views on this exciting topic.
Manisha, thank you so much for inviting me to speak. I'm honored to be here as part of this this really excellent Congress. Can you all see and hear me?
Yes, Dr. Shroff, you are as well. And the slides are also with.
Excellent. Thank you so much. So my talk today is going to be on the evaluation and management of CKD mineral bone disease. I am really honored to be a part of this group. I've included my disclosures and declarations here. So first, a tribute to Dr. Vidya Acharya. Her pioneering vision, her perseverance, her determination, and her vision is what is really a reason so many of us as women in nephrology have had an opportunity to move forward. There are several other extremely erudite women who have spearheaded this field, including Professor Kumud Mehta, who was my mentor at BJ Wadia Hospital in Mumbai. We know that despite all of this pioneering work, as this editorial has so nicely said, this is a young society and we have miles to cover. There is so much work that needs to be done in the field of CKD, especially amongst promoting health in women. And even to this day, in a society like India, where we like to believe, and I am Indian myself, of course, we like to believe that we are very progressive. Healthcare amongst women is certainly not good enough, and certainly not as good as what the men receive. We can see from several studies, and I know that this will very likely have been covered in previous talks and in the Dr. Acharya oration given by Dr. Naikar, but we see that women do not have the same opportunities that men do. This graph is really powerful. This slide is really powerful in showing that in some parts of the world, such as in India and the neighboring countries, we see that. Sorry?
Ma'am, your slides are not moving.
Slides are not moving.
Oh, sorry. Okay, I did not realize that. Sorry. Let me
show more. The slides are not moving either.
Oh, okay. Let me stop sharing and reshare maybe then. Sorry about that. Thank you for telling me. Can you see my slides now?
Yes. Can. Yeah.
Yeah. And do you see it as a full screen or?
Yes, it's a full screen now.
Oh, good. Thank you very much. Thank you for letting me know. So sorry, I was just saying, if I come to this slide, just in the interest of time, I won't go back. But the healthcare available to women is not what it is for men. And this graph here, this figure here is very telling. It shows that in. Sorry.
Can you make it full screen, ma'am?
Oh, okay. That's what I thought it was full screen. Just 1 second. Is it full screen now?
Sorry? Display
Is
settings?
Is it full screen now?
No,
Yes.
no, ma'am. Can you go to display settings?
Yeah, I've done that, but I've got 2 screens over here.
One more time.
Sorry?
One more time, display settings. Duplicate slideshow. Second one, ma'am, duplicate slideshow.
Okay, somebody has stopped my share screen. Sorry, just 1 second.
Ma'am, can you share it once more, ma'am? Okay.
Yeah, I'm just doing that.
Okay.
Can you see now?
Yes, yes.
Yes, but it's not full screen.
Slideshow.
And now?
Ma'am, can you put it in the slideshow mode, please?
Yeah, it is in the slideshow mode. That's the problem. On my screen, it is in the slideshow mode.
Ma'am, your screen is extended screen, ma'am.
Yeah.
Yeah.
Now
it's
it is clear.
Yes, it's clear.
Now it's okay?
Yes.
It's
Yes.
okay, ma'am.
Okay, thank you very much. Shall I continue from here?
Yes, ma'am. Please do.
Thank you, Manisha. Sorry about this mess. Thank you. So I was just saying that really it is these pioneering ladies who have spearheaded the field of nephrology, including my mentor, Dr. Kumud Mehta from Joybai Wadia Hospital in Mumbai. And our society is a young one, we have a long way to go. And as you see from these figures here, the healthcare available to women is certainly not what it is to men. And this figure here shows what the availability of kidney transplantation in different parts of the world. The dark red colors, which are seen here for India and the surrounding countries, is where men have a 10 times greater access and availability of kidney transplantation as compared to women. This is a really stark statistic and something that does need to be addressed and improved. And you see that this is clearly linked to the GDP of the population, where healthcare in women is only available and more freely available in the richer countries. So it is fantastic that an organization like KDIGO have addressed this issue and will take this matter further, looking at the Controversies Conference for women and kidney health. So coming now to our topic of CKD mineral bone disease, we know that too little calcium is bad for people and too much calcium is also bad. So too little calcium is associated with bone pain, rickets and osteopenia and fractures. And too much calcium is associated with vascular calcification and cardiovascular disease. And we as the clinicians are walking a very fine line in aiming to keep the bones healthy and to prevent cardiovascular disease. Now, fractures are very common in adult CKD patients. They are between 2 and 100 times as common as the general population, depending on the statistics you follow. But importantly, the mortality, the 1-year mortality after a hip fracture in CKD patients is more than fivefold that seen in adults. So these are very stark statistics and something we really have to keep in mind. When we look at the aims of our management, really I would turn to the SONG HD and SONG Kids initiative, and there are very similar desires for adults and children. And the core outcome measures that children and their caregivers and adults on dialysis want is to prevent skeletal deformities, bone pain and fractures, to maintain normal growth, prevent secondary hyperparathyroidism, prevent vascular calcification, and decrease cardiovascular mortality. And you see that all these factors are in fact essential and required in order to allow normal life participation or to partake in daily activities appropriate for your age, such as just going to school and playing with their friends for children. Now, the outline for my talk today will be briefly to discuss the monitoring with biomarkers versus DEXA, looking at dietary requirements for calcium and phosphate, discussing the different types of binders, the vitamin D analogs and calcimimetics, and I'll show you a simple case-based study to start with. We'll try and use practical tips where possible, and all of the recommendations given here are based on these 4 large guideline groups: the KDIGO, the NICE from UK, our European Society for Pediatric Nephrology, and the Pediatric Renal Nutrition Task Force. So this little boy came to me from India, came to London, Great Ormond Street from India. He had gone doctor shopping, as a lot of patients tend to do, and had gone all over the world, including Singapore and the US, asking for improvements in his health care. He had a late diagnosis of posterior urethral valves and quite severe chronic kidney disease. And he came to London basically asking for growth hormone therapy. When we saw him there, we saw that his height, when he came here at the age of 8 years, was severely stunted, and it was well below -5 standard deviations. He had extremely severe rickets with this, as you see here, the anterior bowing of the tibia and a lordosis and scoliosis, and very, very severe rickets and fractures as well. And we started treatment. I must show you his X-ray. This was his X-ray when he came to us with a bowing of the femur. We first thought that such severe rickets with such severe mineral dysregulation was likely to be a hypophosphatemic rickets, but in fact it wasn't. And he had no other genetic abnormality at all. So giving him a simple combination of calcium and vitamin D, cholecalciferol and alpha calcidol, and controlling his serum phosphate and his PTH and his vitamin D improved his health, improved his height. As you saw on the previous graph, he grew extremely well. And He grew extremely well with excellent linear growth. And in fact, this is how his bones improved in the course of simply 1 year with giving vitamin D and calcium. Now, clearly, these bones are never going to come back to normal. But this bowing of the femur improved with simple treatment of vitamin D, calcium, calcium-based phosphate binders, and calcium supplementation. So you do not need expensive treatment or expensive monitoring to manage these children. And it is very, very important here that we understand this graph and we understand the requirements of the growing bone. So as you see on the x-axis here, this is a person's age from 0 to 100 years, and the y-axis shows the amount of calcium in the bones. So the bone mass or the bone calcium content increases from just 25 grams at birth to 1.2 or 1.5 kilograms in an adult male or female. And this very rapid calcium accrual in the bones is essential to mineralize the growing bone and to keep it strong and prevent fractures. A low bone mineral density, even in healthy children, is associated with fractures, and a decrease in this peak bone mass or the maximum calcium accrual in the bones, even a 10% decrease is associated with a 50% risk of fractures after menopause. Remember, the growing child needs calcium, and our CKD patients, children, need calcium as well. So how would one evaluate MBD in clinical practice? And the treatment of CKD-MBD should be based on serial assessment of calcium phosphate, PTH, and alkaline phosphatase and vitamin D considered together, following trends in levels. It's very important to remember these words, the serial assessment and considered together. And this is because I will show you in the next graphs that it is the cumulative exposure that matters as much as single levels. There is no benefit from performing routine DEXA scans in children. We have shown that DEXA in children and in adults with CKD cannot distinguish cortical and trabecular bone. There's no evaluation of the bone geometry or microarchitecture with DEXA scan, and it systematically underestimates the bone mineral density in children who have poor growth. Therefore, focus on your mineral bone disease markers. And as this study has shown so nicely from the DOPS database, when you look at the area under the curve or the cumulative exposure, those who have the highest area under the curve for serum phosphate levels in the pink bars over here are far more likely to have major adverse cardiovascular events, cardiovascular death, and even all-cause mortality and non-cardiovascular death. Now, I'm not saying that you have to calculate an area under the curve each time you see a patient in clinic, but this graph gives you the stark information about how important cumulative exposure is, and therefore how careful we should be with this. We've shown in studies in children that the cortical bone mineral density, when checked on a PQCT, so peripheral quantitative CT scan of the bone, which is the most sensitive way you can assess the bone mineralization, is associated with the total calcium and inversely associated with PTH and with alkaline phosphatase. The inverse association with alkaline phosphatase really means that this is under-mineralized osteoid, under-mineralized bone. And doing a DEXA scan does not give any additional benefit or additional information. So focus on your basic CKD-MBD markers. Now, having said that, and keeping in mind that phosphate levels are a modifiable risk factor and should be controllable, we know from our International Pediatric PD network with over 900 children studied that actually phosphate control is not that good. In the overall pediatric population from birth to 18 years, 45% of patients had hyperphosphatemia. However, interestingly, when you look at this by age, so in the next few bar charts, you will see here that the infants and the under 5s do pretty well with phosphate control. But in the teenagers, 80% have hyperphosphatemia. Now, this is not something to do with the biology changing suddenly when they become teenagers. This is to do with compliance with medications and even more importantly with the diet. And we'll talk about the diet in a minute. But we know that the bone disease the burden of bone disease is very high in these patients. So in these same patients from this IPPN network, we saw that a significant proportion have a high calcium and phosphate, and they suffer from osteodystrophy, limb deformities, osteopenia, tissue calcification, and bone pain. And when we look at their PTH control here, we see that those who have the lowest PTH levels below 100 have hypercalcemia. Those who have PTH above 300 will have clinical and radiological symptoms of bone disease. Those with PTH above 500 have impaired longitudinal growth. And therefore, we believe that keeping the PTH in this range between, as we say, 2 to 3 times the upper limit of normal is likely to have the best outcomes for children. Now, this is, of course, registry data, so you have to evaluate it in perspective with that, but this is the best data we have to date. We have several other studies which indicate that growing bones need calcium. This is a study from the US looking initially cross-sectionally and then longitudinally in a cohort of children and very young adults, correlating changes on, again, the PQCT or bone CT scan, and showing that calcium and vitamin D are directly associated with improved bone mineralization, whereas 1,25-dihydroxy-D and PTH are inversely associated. And as you see on longitudinal analysis, a decline in the cortical bone mineral density Z-score was associated with a higher baseline 125D and a higher PTH. And a high calcium was required for the cortical BMD increase. Now, these values are not simply surrogate markers, because we saw that a 1 standard deviation decrease in bone mineral density was associated with a 2-fold increase in fracture risk. And this really highlights the importance of calcium for the growing bone. Similarly, in this other study, which has looked at bone biopsies, they've seen on bone biopsy that in children with CKD stages 2, 3, and 4, so this is very early CKD, even before your PTH and your phosphate start to rise, and even in very early CKD, we see that there are abnormalities in turnover, mineralization, PTH, and FGF23, and bone mineralization was abnormal. If you look here, in 29% of patients with CKD stage 2, increasing to 42% with CKD stage 3, and 79% with CKD stage 4. And again, as you can guess, the abnormal mineralization is associated with a low calcium and a high PTH. The dietary calcium intake is very important to remember. Now, I'm sure if there are any dietitians and pediatric nephrologists in this audience, they'll know that if you severely restrict a person's phosphate intake, you're automatically restricting their calcium intake, because most foods which are rich in calcium are also rich in phosphate. So if your patient diligently follows your advice for phosphate restriction, they will become calcium deplete as well. And we showed in this small study that compared to healthy children in the green bar over here, children with CKD, all patients, and then CKD 3 to 5 and dialysis, the calcium, if you look at the calcium intake in the red bar from the diet alone, it is very low and below 100% of the requirement. With the addition of calcium-based medications, usually calcium-based phosphate binders, this increases substantially, with the majority being in the KDIGO recommendation of within 2 times the upper limit of normal. So looking at phosphate again, the dietary phosphate can be from organic sources, which has a bioavailability between 30 to 70%, or inorganic sources with a bioavailability of 100%. And phosphate additives come into this inorganic phosphate category. These are essentially processed foods, and processed foods have an extremely high phosphate, which is all absorbed with 100% bioavailability and is actually very difficult to bind. And it is really when individuals such as our teenagers in pediatric practice go on to their processed foods, their ready foods, their Coca-Cola, this is where they have extremely high phosphate and persistent hyperphosphatemia. The phosphate is indicated by E numbers in the UK and Europe, and essentially anything, especially processed meats, any dark fizzy drinks like Coca-Cola or Thumbs Up, and any even biscuits and bread will have phosphate. So some practical tips have been produced by the Renal Nutrition Task Force. We have practical guides for healthcare professionals, which give step-by-step management plans, as well as advice for children and young people. And for India, Dr. Sukanya Govindan has led the the Indian branch of our Pediatric Renal Nutrition Task Force, and a lot of extremely helpful documents have been generated by them. So please contact Sukanya for these details. The guidelines on phosphate control advise on adjusting the dietary intake of calcium and phosphate to maintain the serum calcium phosphate levels in the age-appropriate range. As I showed you, again, plant sources are better than animal sources, and the additives are the really big culprit here. In children, the choice of phosphate binders must depend on the serum calcium level, and our first-line agent is always calcium-based phosphate binders. So this table here shows the different calcium-based and calcium-free binders. And I won't read all this out to you, but a few important things to highlight over here. Calcium carbonate has a higher elemental calcium content as compared to calcium acetate, and it is less efficient at binding calcium. So it is better to try and use calcium acetate where possible, even though it is a little bit more expensive. We must advise that the binders are always to be given with meals, and they should not be given, especially calcium carbonate, requires an acidic pH to dissociate. So do not give it with omeprazole or an H2 blocker, and do not give calcium carbonate with bicarbonate, otherwise it'll just simply precipitate in the stomach. And also do not give it with iron preparations or phytate or oxalate. There are 2 randomized trials in children comparing different phosphate binders, and both have shown that the phosphate binders are equally effective at controlling serum phosphate. In the older days when the study was done, they used sevelamer hydrochloride, but now sevelamer carbonate is available, and you no longer have the issue of metabolic acidosis with this. The counter side, of course, of using enough calcium is the risk of vascular calcification. You see this here in the coronary vessels, and you see this here on a cross section of an artery. And we know that even in children, the most common cause of death is cardiovascular disease. We've seen in the studies in adults, which have shown a very distinct correlation between the GFR stage, for example, in the green lines for people with a higher GFR, better GFR, versus in patients on dialysis, where the lifetime remaining years are severely reduced in people with CKD. In children, we've seen surrogate markers of cardiovascular disease in the form of a high intima media thickness, as you see here, or a high pulse wave velocity. And these are patients even in CKD stage 2 to 5 and dialysis. So this begins early in CKD. And we know that the risk factors for these are a low 25-hydroxyvitamin D level, a high serum phosphate, and a high serum PTH. And so these are all modifiable risk factors we really must pay attention to. I know that for the adult nephrologists in the group, actually the story is not that different. And again, even in adults, there's a very fine balance between too little calcium and too much calcium. We very recently, as in it's going to be published any day now in NDT, have drawn up this consensus document for children and adults with an expert panel led by Professor Evan Apool from Belgium, where we've looked at the calcium intake for adults with CKD. And we know that KDIGO and KDOQI, excuse me, have addressed the upper limit of calcium, and they've advised on not giving too much calcium, but they do not advise on giving on the lower limit of calcium intake. And a lower limit is extremely important. In many, many parts of the world, using a calcium-based phosphate binder is considered taboo, and that is actually wrong, because a patient with too little calcium will have hip fractures, and the hip fractures are highly associated with mortality. And finally, to look at vitamin D guidelines very briefly, we know that people with CKD do require higher 25-hydroxy-D levels, and at least for children, keeping their growing bones in mind, we suggest maintaining the 25-hydroxy-D levels above 75 nanomoles per liter. We've defined different levels of sufficiency, insufficiency, and deficiency, and we recommend monitoring no more than every 3 monthly because of the long half-life of cholecalciferol and vitamin D in the body. We base our vitamin D levels and the status on what happens with vitamin D deficiency and how PTH responds at different vitamin D levels, as you see over here. You also see there's a high therapeutic window, a wide therapeutic window, and the safety of giving vitamin D is very high. So we did a simple study many years ago now, a decade ago, looking at ergocalciferol versus placebo. And we showed that using ergocalciferol delays the development of secondary hyperparathyroidism in people with stages CKD 2 and 3. We've developed recommendations from the European Society for Pediatric Nephrology, the ESPN, looking at intensive replacement therapy versus maintenance therapy, and shown and developed some guidelines on this. And going forward, Dr. Arpana Iyengar and her team have worked with me to develop a randomized controlled trial with a 3-way randomization of daily, weekly, or monthly treatment with 25-hydroxyvitamin D in patients who are in children who are deficient. And we saw that compared to the baseline cohort, where all patients by definition were 25D deficient, using intensive replacement therapy, either as daily, weekly, or monthly treatment, gave equivalent 25-hydroxy-D levels. And on maintenance treatment, again, you see that the levels are uniformly maintained, irrespective of giving treatment daily, weekly, or monthly. And this really means that we have, for the first time, shown that weekly or even monthly treatment, if that helps with compliance, is a good way to go ahead with treatment for vitamin D. In a randomized trial from the US, they have shown the dose of vitamin D required, and they've compared a dose of 1,000 international units per day versus 4,000 international units per day, and shown that at a 6-month period, 75% of children on 4,000 units a day achieve adequate levels, more than 30 nanograms per mil or 75 nanomoles per liter, whereas only 30% in the lower dose achieve adequate levels. So my personal practice is to monitor 25-hydroxyvitamin D at baseline, 3 months, and then annually. If a patient is deficient, or if they have a high PTH or a low calcium, I would give cholecalciferol supplementation in children with CKD stages 2 to 3 and the transplant patients in CKD 2 to 3. I would aim for levels that are adequate, as in more than 75 nanomoles per liter. Stop treatment at 120 nanomoles per liter, keeping in mind the risk of toxicity is way higher at 250. In CKD stages 4, 5, and on dialysis, we do need to combine cholecalciferol with active vitamin D, again, because of the poor conversion of 25 to 125 dihydroxy-D. This is my personal practice, but at Great Ormond Street, we've been doing this for nearly 30 years with good benefit. So finally, use of calcium mimetics. We need to be really careful with the use of this. There are distinct indications for using calcium mimetics, but it is extremely important that the patient must have a high or high normal level of serum calcium before you start this. And you need to be extremely careful and beware of hypocalcemia, as this can be life-threatening in patients, especially so in children. Don't forget other factors that might affect renal bone disease. Of course, metabolic acidosis, nutrition, the growth hormone axis, steroid therapy, hypophosphatemia in distinct conditions, hypocalcemia, and reduced physical activity and muscle strength all impact on this. And each one of these could be an individual lecture. I'm often asked, what about FGF23? FGF23 is an extremely important research marker. Please do not spend your money measuring this in routine clinical practice. It is not recommended by anybody and but remains an important research marker, and it has a number of off-target effects. Actually, whether these effects are the effects of high phosphate and high PTH, or they're the true effects of FGF23, is difficult to tease out, and animal studies are showing this. But it might be that simply controlling and focusing on the simple measures of calcium, phosphate, PTH, and vitamin D is what will guide you as well as anything else. And so my key message is the interdependency of all these different biomarkers in therapeutic decision-making, how important it is to control them well, and that there's a fine balance between enough and too much calcium for bone mineralization and vascular calcification. Thank you all very much. If I had to summarize in one word, one sentence, what the guidelines say, all of these guidelines uniformly say, control hyperphosphatemia and avoid hypo or hypercalcemia. Thank you all very much, and I'm happy to take questions.
That was a good overview, Dr. Rana. You've seen only one Indian boy, but we are seeing several children because they come to us very late, and we are focused more on treating the children rather than the mineral bone disease, because by that time they die. And what is the role of this bisphosphonates?
Thank you, Dr. Rajkumar. That's a very good question. I have seen thousands of Indian children when I worked in India. And the important message here is this is an easily preventable condition that any doctor or GP should be able to manage. And we need to really educate and focus on early treatment. That was my message there. The role of bisphosphonates in CKD, I must say, in children and in adults is largely based on acute treatment and prevention of and management of hypercalcemia. Routine use of bisphosphonates in CKD patients is not recommended, absolutely not for children, and perhaps only in extremely select cases in adults. And the reason for this is bisphosphonates can affect the CKD progression as well, and it can cause an abnormal mineralization process within the bones that then predisposes to other new fractures as well. So bisphosphonates have a very, very select role in CKD patients, perhaps not really recommended at all. A newer anti-resorptive agent called denosumab, which directly acts on the RANKL receptors in the bone, may be useful. It is used in the Western world a lot, particularly in the bone disease that develops after cancer treatment. And it does have a very good, very beneficial effect.
And how about the FGF23 and Clotho? So much hype is going on. Is it useful in children?
I like your words that there's so much hype. It is really a lot of hype and perhaps not that much actual benefit. So in my practice, we will only measure FGF23 and Clotho for research studies. We do not measure it in routine practice. It's extremely expensive. And apart from, clear focused research projects, it perhaps does not have much benefit because really it's not giving you, it gives important additional information and research, but it is not useful for routine monitoring at all.
Thanks. Thank you, Dr. Shroff, for a very nice talk. So I would just like to know your experience on monitoring of vascular calcification in children. Do you see it often? What are your protocols for monitoring it? And if you see it, how do you treat that?
Thank you very much. So again, I would not recommend routine monitoring for vascular calcification, and none of the guidelines recommend this at all in children. And actually, the KDIGO has not recommended it in adults either, unless they have distinct cardiovascular disease problems. The KDIGO guideline was from 2012, and this year it's going to be revised again. So perhaps there may be more recommendations coming up, particularly because there are now good treatments for patients with calciphylaxis and the reversal of vascular calcification. I would, however, focus on the prevention rather than the treatment, because once it's developed, it's extremely difficult to treat and properly reverse. For children in particular, and even in adults, as I said, there are no recommendations for routine monitoring. The monitoring we do is largely through our research protocols and research practice. In clinical practice, I would not suggest routine monitoring at all. I would suggest a strong focus on prevention, again, based on the routine biomarkers available. If one wants to look at screening, we need to keep in mind that screening studies, such as even a cardiac CT scan, which of course comes with a radiation dose, should not can be performed, but the presence of calcification on a CT scan already means that there's a substantial burden of calcium accumulated in the vessels before it becomes visible on the CT. And this is, of course, perhaps 10 or even 100-fold more severe to detect on an X-ray. So a plain X-ray abdo, AP lateral, whichever view you take, may show calcification in the aorta and the iliacs, but this means that the calcification is extremely advanced. So one should not depend on these measures because they're not really screening measures. They don't give you early detection. They give you extremely advanced stage of the disease.
Okay. So you said about like DEXA not being often used in children. In the KDIGO 2017 guidelines, adults, they have recommended, and initially it was not for the type of bone disease and all that, but for assessment of bone density, because to assess the fracture risk and all that role seems to be important. So we are using it for that and for planning subsequent therapy for that. In children, you said DEXA, is not very useful and you don't do it routinely. What about many of the times the bone markers are able to guide regarding the type of bone disease and treatment, but sometimes there are gray areas. PTH is neither too high, too low. So sometimes you're not able to come to a definite conclusion. So is there any role for bone biopsy, quantitative CT? Do you do it clinically at all?
Thank you. So you're absolutely right, Manisha. So the 2017 guideline recommended, KDIGO guideline recommended DEXA scans to partly for fracture risk and partly to decide the guide therapy. In children, we do not recommend it because it's even more confounded by poor growth, and the growing bone will have changes in the mineralization over time. You're correct about the type of bone disease, and that can only be determined in a child or an adult. It can only be determined by a bone biopsy. And bone biopsies are done very, very infrequently in children. To my knowledge, there's only one center in Europe where they perform bone biopsies, and that too, it's only performed in children, say, with hypophosphatemia or cystinosis or other bone disease. Another thing to keep in mind is that in all the studies that have been done so far in children, the bone disease is largely a type of mixed renal osteodystrophy. So it does not really tell you unless it's the extreme of high or low. And if it's the extreme of high or low turnover, and then you can see changes. But largely, these will also correlate with the PTH level.
Ma'am, we are exceeding the time limit.
I'm sorry, I can't hear you.
Yeah, thank you, Dr. Shroff. That was an excellent presentation. And if there are no more questions, I think the organizers want us to close the session for want of time. So thank you, Dr. Shroff. It was really great of you to accept our invitation. So we close the session. Thanks for the opportunity.
Thank you all very much. It was my pleasure. Thank you. Thank you.
Moving on to our next scientific session, I would like to invite on stage our chairpersons, Dr. Rubina Mohra, consultant nephrologist at CHL Apollo Indore, Dr. Rashi Gupta, consultant pediatric nephrologist, Ahmedabad, Dr. Girish MS, consultant nephrologist, MS Ramaya. I'd like to invite on stage Dr. Anita ma'am, consultant nephrologist at Apollo Hospitals, Bengaluru, and Dr. Alpama Vaidya, consultant nephrologist at Shivamogga, to chair this session. I would request our chairperson to introduce our international speaker, Dr. Anna Wilson.
Good afternoon, everybody. Dr. Anna Wilson is here. She is the specialty director of renal medicine, NHS Grantway. We all know that denosumab is a new agent which has been used in osteoporosis. And to know a little bit more about the clinical scenarios in which it's used, I request Dr. Anna to go on with the presentation.
Hello, am I heard?
Yes.
Yeah, I'm sorry, I can't really hear anyone over there very well. So I'll start. Sorry?
We can hear you.
Okay, all right, thank you. All right, so I'm here today to talk about denosumab, simply for us to understand a clinical scenario in which denosumab would be useful. And I think that's the most important issue with respect to denosumab, understanding which patients you should and shouldn't use it in. So the story begins with a 75-year-old Caucasian lady with comorbidities of hypertension, ischemic heart disease, a baseline CKD-EPI, creatinine, EGFR.
Can you share your PPT, ma'am?
All right.
Share your.
Okay, sure. All right, is it seen now?
No, ma'am.
Yeah, all right, sure. Thank you. Sorry about that. Okay, so the story begins with a 75-year-old Caucasian lady who...
We can't see your screen. It is just showing that you have started your screen sharing, but nothing else is visible.
Sorry?
Ma'am, we
Madam,
can't see your
screen sharing hasn't come yet, madam. It is just displaying it as you have started screen sharing, but we are not yet able to see the slides.
Oh, all right. I'm not entirely sure what the problem is.
Madam, try logging out and logging in again, ma'am.
Okay, I'll do that.
Anna ma'am, should we share the, start the presentation from our side? Like we have the PowerPoint with us.
Good afternoon. My name is Anna Walson and I'm a
All right, am I heard now?
Yes, ma'am. We can hear
Yes,
you.
ma'am. You're clearly heard, ma'am, but the screen sharing is
not okay. Fine. All right.
yeah, we can
Yes,
see
ma'am.
your screen now.
Okay.
Yeah.
And are my slides moving now?
Just change once,
Yes,
ma'am.
ma'am. Can you put it in slideshow?
Yeah, it is actually in slideshow.
Okay, can you just move the slides, ma'am? Yeah, it's moving.
Okay, maybe I should just keep it instead of doing the whole slideshow, doing it like this. Is this okay now?
Fine.
It's okay?
It's okay, ma'am.
Okay, all right. Sorry for that. Let's get started now. So this is a 75-year-old lady with comorbidities of hypertension, ischemic heart disease, a baseline CKD EPI creatinine EGFR of around 90. There's a past history of a fibular fracture, but we're not sure how this fracture occurred. She's a chronic smoker, drinks around 1 to 2 units of alcohol a week. Socially, she's 20 years postmenopausal and has never received HRT. Now, already we can see that this patient has quite a few risk factors for osteoporosis. For example, she is more than 75 years of age. She is a chronic smoker. She's postmenopausal and has never received HRT. A fibula is not a classic site for an osteoporotic fracture. Usually it's the spine or the hip that are associated with osteoporotic fractures, but a prior history of fracture makes a patient at higher risk for future fractures. Another important piece of history that we need to take from patients is whether they have a family history of osteoporosis. If you look at the list of medications, this patient is not on calcium or vitamin D, and they are on a PPI, which is considered one of the risk factors for osteoporosis. She lives alone and is independent for activities of daily living, but we don't have any more information about level of physical activity, which is an important risk factor for osteoporosis, and also BMI, because a low BMI puts patients at risk for osteoporosis. So this patient actually presents to the primary care physician with increasing breathlessness over a 4-week period. There aren't any significant findings on examination, but on testing, the EGFR is dropped around 20 ml per minute. Urine is bland, myeloma workup is negative, and there are no abnormalities on the ultrasound. So at this point, the GP discontinues losartan and eplerenone. The kidney function improves slightly, and renal is consulted. Renal advises to restart losartan and ask for the PPI to be changed to famotidine. Just for everyone's understanding, although this was not done for bone health, in general, H2 receptor blockers are not associated with the same effect on that PPIs. They're generally considered safer. And on follow-up, this patient was confirmed to have CKD because the EGFR remained at the 35 to 38 ml range even 3 months later. So she presented to the GP with low back pain, which was worsening over a 6-week period. And there was no clear history of traumas. There was no fever or neurological deficits. So the GP ordered a lumbar X-ray, and this showed a a mild biconcave fracture at L3 and one at L1. The bones were osteopenic, pedicles were intact, and otherwise there were generally degenerative changes. Now, this is classic description of an osteoporotic fracture. And why is that so? If you look at this diagram, you'll see that generally it is the trabeculae which are exposed to stress that remain preserved longest. So in the vertebrae, the vertical trabeculae are generally preserved longer than the horizontal trabeculae. And so you will see over time, the number of horizontal trabeculae starts decreasing. And this is why with stress, you will find a biconcavity or a concave or a biconcavity developing. And that is considered typical of what are called compression fractures, which you see in osteoporosis. The fact that pedicles are intact makes a malignant process less likely. And of course, seeing osteopenia in other bones again lends more strength to the idea that this is likely to be osteoporosis. So the GP offered lifestyle advice, such as weight-bearing exercises. And this is, again, what is recommended when you're dealing with osteoporosis. It is to encourage physical activity to ensure that bone health is maintained for as long as possible, and smoking cessation. Refers the patient for a DEXA scan. The indication here being in age more than 50 years with a low trauma fracture. For us to understand what a low trauma fracture is, it's classically defined as a fracture that occurs due to a fall from standing height or less. So the GP also consulted rheumatology, and this is because where I work now, it's rheumatology that runs the DEXA service. And the basic question the GP had was, can we treat this fracture even though the DEXA scan report isn't available? And if so, what would you advise? The eGFR was around 32, and the patient also had acid reflux symptoms. So these are the investigations that the rheumatologist had access to. The bicarbonate was in the normal range. Calcium and phosphate were also in the normal range. Alkaline phosphatase was elevated. A PTH had not been checked by the GP, but the GP had ruled out a thyroid disease and diabetes, because both are risk factors for osteoporosis. At this point, how would we respond to this query from the GP? So the Scottish Intercollegiate guideline basically makes it very clear that the presence of a low trauma vertebral fracture is itself considered diagnostic for osteoporosis. So you don't actually need a DEXA scan to confirm that a patient has osteoporosis if you've already see a low trauma vertebral fracture. And that is for the reasons I mentioned earlier, because the very mechanism of this kind of fracture is suggestive of osteoporosis. And also remember that, as Dr. Shroff also mentioned, a DEXA cannot actually tell you what type of bone disease you're dealing with. All a DEXA scan will tell you is that someone has a low bone mineral density, but this could be due to any of these pathologies. All of them will appear to have low bone mineral density, whether it's secondary hyperparathyroidism or adynamic bone disease or osteomalacia, osteoporosis. All of them can have exactly the same bone mineral density. And so a DEXA scan actually cannot confirm what type of pathology you're dealing with. I apologize for this rather busy slide, but just to explain what we're dealing with here, this is again from the SIGN guidelines on how osteoporosis should be managed. So if someone has a spine fracture, the next step is to actually find out if they have severe osteoporosis. And this is basically defined as the presence of one severe or two or more moderate vertebral fractures. Now, how do we know whether a vertebral fracture is severe, moderate, or mild? It is by looking at vertebral height. So if the vertebral height loss is more than 40%, that is considered a severe spine fracture. If it's between 25 to 40% loss of the vertebral height, that is a moderate vertebral fracture. And if it's between 20 to 25%, that's considered a mild vertebral fracture. So our patient had mild vertebral fracture. So you're not dealing with severe osteoporosis of the spine. If you do have severe osteoporosis of the spine, you actually have to go on to other agents such as teriparatide or emocizumab. But if you're dealing with garden variety mild vertebral fractures, then it's bisphosphonates, and in the UK it's alendronate and risedronate that are advisable. right? And so the rheumatologist advised that risedronate be commenced, and this is because of the fact that most of the bisphosphonates cannot be used at a creatinine clearance less than 30%. And in fact, alendronate and zoledronic acid cannot be used at a creatinine clearance less than 35. So in this case, it was only risedronate that could have been prescribed. And there is some evidence that risedronate is slightly better tolerated from the GI perspective compared to alendronate. So this was what was advised. So the GP went ahead and did the usual due diligence that you have to do when you're starting bisphosphonates in patients, asked for a dental check to be done, commenced vitamin D and calcium, and also gave appropriate bisphosphonate counseling. Meanwhile, the result of the DEXA scan was available, and as you can see, these values are not classically in the osteoporotic range, but as I said before, this was reported as osteoporosis because there were also classic vertebral fractures associated with it. And the advice was to continue risedronate with adequate calcium and vitamin D for up to 10 years. And that's because safety data is only available for up to 10 years. Now, at this point, the patient was finally seen by a nephrologist, and now the eGFR had dropped to below 30. And most other parameters were in the normal range. We finally have a PTH value, which was around roughly 9 times the upper limit of normal. So at this point, risedronate is no longer an option. So what can we do? If we go back to our diagram, when alendronate or risedronate are either not tolerated, or are not, cannot be used for any reason, the next step is to see if a parenteral bisphosphonate can be used. But of course, that's also not possible in this case because the creatinine clearance has dropped below 30, and so the only agent we're left with now is denosumab. So denosumab basically is the agent that is used when you have osteoporosis and oral bisphosphonates are not suitable. Well, let me just blow up this slide actually and see if you can this be seen? Right, so let's learn a little bit about denosumab. It's basically denosumab is useful in this condition because osteoporosis is a combination of having low bone formation and increased bone resorption. And bone resorption is mediated by the osteoclasts. And for osteoclasts to form, you need pre-osteoclasts to then mature into osteoclasts. This requires the rank receptor on a pre-osteoclast to bind to the rank ligand, which is secreted by osteoblasts. So that when the rank ligand binds to the rank receptor, pre-osteoclasts then differentiate into osteoclasts. So what denosumab goes and does is it actually binds to the rank ligand and prevents it from binding to the rank receptor, and therefore this process does not take place. Over time, this leads to a decrease in the number of osteoclasts, their maturation, and their survival. So over time, of course, the osteoclastic activity and therefore bone resorption decreases. Why everyone is excited about denosumab is that it is not cleared by the kidneys. It's actually cleared by the reticuloendothelial system, and therefore it can be used at low GFRs. It's also parenteral. You need to give it only once in 6 months. At the dose that is used in osteoporosis, it is 60 micrograms subcutaneously. However, there are important side effects we need to be aware of. And the first and most important is hypocalcemia. And the reason why denosumab causes hypocalcemia is because serum calcium is maintained by osteoclastic bone resorption. So it's when osteoclasts act on the bone that calcium is released from the bone. When you stop bone resorption, serum calcium levels tend to drop. So that's the mechanism of hypocalcemia. There's also, like bisphosphonates, the risk of osteonecrosis of the jaw and or the external auditory canal. The incidence is around 5.2 per 10,000 patient years. And the reason why it causes osteonecrosis is because of, again, it inhibits bone remodeling. And therefore, if you have an injury to the bone or you need a tooth extraction, that area doesn't heal and it can often become secondarily infected. There's also this risk of atypical femoral fractures on treatment. Again, this is because of low bone turnover. Now, when our bones are exposed to normal stress and strain, there will be micro trauma that happens, but the process of bone remodeling helps to repair this micro trauma. When you damp down and prevent bone remodeling, then these micro traumas tend to accumulate over time, and you can have atypical femoral fractures. And this is what an atypical femoral fracture looks like. Why it's called atypical is it doesn't happen in the classic areas of femoral fractures. It doesn't happen at the femoral neck or the intertrochanteric region. It's usually subtrochanteric, and usually you will have a transverse break, and often it is bilateral. And usually patients will not have any history of trauma. It can just happen while they're standing. So that's what's atypical about these fractures. There's also an increased incidence of vertebral fractures on discontinuation. So denosumab is unlike bisphosphonates, whose effect lasts for a long time even after you stop the medicine. Denosumab, because it's cleared by the reticuloendothelial system, its half-life is less than a month. So after you discontinue denosumab, you can very quickly have an increase in bone turnover again, and this can actually lead to an increase in fractures, which makes its use problematic. So the first thing you have to do is ask the patient if they have any problems with their mouth or teeth, if at all you're thinking of starting denosumab. If they're wearing dentures, you have to ensure that they fit properly. You need to assess if they have any risk factors of osteonecrosis of the jaw, especially smoking, and if they have ongoing issues with their teeth. Any previous treatment with bisphosphonates is a risk factor for osteonecrosis of the jaw, and any other treatments they may be on which can impair wound healing, such as chemotherapy, corticosteroids, radiotherapy, can also increase their chance of developing osteonecrosis. If any of these risk factors are present, we must refer the patient for a dental examination and preventative dentistry. The next step is to ensure that you minimize the risk of hypocalcemia. So ensure they get adequate calcium supplementation. This is usually at least 1,000 milligrams of elemental calcium a day. They need to be on cholecalciferol, at least 400 international units per day. And especially if they have advanced kidney disease, they should also be on activated vitamin D. Make sure they're not on any medications. Yes?
Ma'am, your slides are not changing.
Okay, all right. I think we'll just go back to what we were doing before. All right. Can it be seen now?
Yes, ma'am, yes.
Okay, all right. For some reason, when I put them on the slideshow, for some reason it doesn't work. Okay, let's just do it this way. Okay, so you need to review medications that can cause hypocalcemia, such as loop diuretics, steroids, cinacalcet, and ketoconazole, and make sure you check the serum calcium before starting therapy, ensure it's adequate. Remember that the risk of hypocalcemia actually increases the more severe your kidney disease is, and the higher the bone turnover is when you start denosumab. All right, so we need to give the patient quite a bit of health advice before you start them on denosumab. They need to know the symptoms of hypocalcemia. They need to know that they need to report any new or unusual thigh, hip, or groin pain, which could indicate an atypical femoral fracture. Any oral symptoms, ear pain or discharge, they should immediately seek medical attention. They should maintain good oral hygiene, have regular dental checkups, and if they ever need a dental procedure, they must inform their dentist that they're on denosumab. After you're given the first dose, we must monitor calcium for at least 12 weeks after treatment. And especially in patients with advanced kidney disease, the hypocalcemia can be seen as early as 7 days, but usually you would see hypocalcemia within the first 2 weeks itself. And for subsequent doses, we must ensure that the treatment is given on time. Otherwise, like I said, there's a risk that bone turnover may increase and they would be at risk for fracture. So it's so important that the patient remains under follow-up, and we should get the next dose at least within 1 month of the scheduled date. Serum calcium should be checked 2 weeks before the due dose and at least 2 weeks after the due dose. And we must monitor with PTH, although this is not part of the recommendations, but for our patients, we need to monitor PTH, and DEXA can be considered every 3 years if a new fracture occurs, or even routinely every 3 years. Now, unfortunately, patients with advanced kidney disease, hypocalcemia can be quite a bit of a problem. And I've talked to my colleagues here who have experience with denosumab, and they have struggled to manage calcium in patients with advanced kidney disease. Once hypocalcemia sets in, you would usually require very high doses of oral calcium. You may need even IV calcium supplementation, quite high doses of calcitriol. In patients on dialysis, you may need to increase the dialysate calcium concentration, and it can take even months to treat the hypocalcemia. So it's so important to actually optimize the patient before starting denosumab. Otherwise, it can get quite difficult to treat. Once you've started treatment, around 5 years, at least at 5 years after starting treatment, you need to reassess whether this is something you want to continue. If the patient remains at high risk for fracture, and this is usually patients who are more than 75 years of age, who have already had a fragility fracture, either before they started denosumab or while on denosumab, and those who've had a long history of steroid treatment. These are considered high risk features for future fractures, and in them treatment can be extended up to 10 years. If you're thinking of discontinuing denosumab and the patient's creatinine clearance is more than 30, it's important to shift to another anti-resorptive agent, and this is usually bisphosphonates, and zoledronic acid is preferred. Again, this is to prevent the risk of rebound increase in fractures. However, if the patient's creatinine clearance is less than 30, unfortunately, there is no other option available. This patient actually has to be on lifelong denosumab. So you really need to think long and hard before you start patients with advanced kidney disease on denosumab. This is a very handy algorithm which was in the latest issue of the NEFSAP, and I think it really summarizes the management of patients with osteoporosis and CKD quite handily, and let's go through it. So if someone has chronic kidney disease and a fragility fracture, of course, we need to address lifestyle fractures. We also need to address their CKD-MBD, get a DEXA scan, but most importantly, we need to assess bone turnover, because the agent that we use will depend on the bone turnover. Of the markers available to us, bone-specific alkaline phosphatase is not available in most centers, but we can do at least PTH despite its many limitations. So PTH, if it's less than 2 times the upper limit of normal, you would think that this patient actually is likely to have a low turnover bone disease. This is not the group of patients you would want to use denosumab in. It's this group of patients who have a high PTH, especially if their PTH is more than 9 times the upper limit of normal. You can be fairly certain they don't have low turnover bone disease. And this is the group that is most likely to benefit from either bisphosphonate or denosumab, depending on what the creatinine clearance is. There is a gray area between those, in the group of patients that have a PTH between 2 and 9 times the upper limit of normal. This is where a bone biopsy would be indicated, but unfortunately most centers don't have access to it. The authors suggested that they would lean more towards anti-resorptive therapy in this group, but of course, if you're at the lower end of the spectrum, you'd be a lot more cautious before starting anti-resorptive therapy. So this is my summary slide. The indication for denosumab is quite specific, and that is if you have fragility fractures, bisphosphonates are not appropriate for whatever reason. They're either not tolerated or they can't be given because of the patient's kidney function, and you're fairly certain the patient does not have a low bone turnover disease. If a patient has a creatinine clearance less than 60, we must optimize CKD-MBD management before starting, and we must watch assiduously for hypocalcemia. Monitoring is with PTH and DEXA. The duration of treatment, safety data is available only up to 10 years. When you discontinue, provided your creatinine clearance is more than 30, it's best to lock in the benefits of denosumab with another anti-resorptive agent. Zoledronic acid is preferred. However, if the creatinine clearance is less than 30, you have no other option other than to continue with denosumab. So we need to really think about the risk and benefit ratio before starting. I'd just like to thank 2 people who are really helpful in getting insights on in this area. Kripa Elizabeth Cherian, who was a former colleague of mine when I worked in Christian Medical College Vellore. She's associate professor in the Department of Endocrinology, Diabetes and Metabolism, and a real expert in this area in India, and Dr. Alison Black, who is a consultant rheumatologist at the institution I work in now, which is Aberdeen Royal Infirmary. Thank you all for listening, and I'm happy to take questions now.
Thank you, Dr. Anna, for this wonderful talk on the very practical aspect of denosumab use. So you have made it very clear to us. I just have one simple query. If at all, like we would like to shift from denosumab to other forms of anti-resorptive therapy for any reason, so how should we go about it?
Yeah, I think it will really depend on what the indication for shifting is. So, for example, there are reports of patients who've developed atypical femoral fractures on denosumab, and they were treated by actually shifting them, because here, when you have an atypical femoral fracture, you know the problem is low bone turnover. So then you shift the patient to an agent which will improve bone health but increase bone turnover. In our setting, that would be teriparatide. Okay, so generally, most of the problems with denosumab are because either you discontinue denosumab and there was an increase in bone turnover, in which case you would use another anti-resorptive agent. But if the reason for discontinuing denosumab is because of low bone turnover, you would shift the patient to an allembolic agent such as teriparatide.
Right, madam. Thank you very much. And the another simple query is that many a times we get a query that in patients with secondary hyperparathyroidism being there, secondary to CKD, can still teriparatide be used for a short period to improve the healing process? So your comments on that, madam.
Oh, I'm sorry. So this is unfortunately this group of patients, and I'm talking about patients that are advanced kidney disease. There is very little evidence-based data. It's really, if you ask me, I have not had a single patient for whom teriparatide has been used. My colleagues in Vellore, and I'm sure my rheumatology colleagues would have more experience on this. Well, the thing is that teriparatide is specifically useful in those who have vertebral fractures, but are not at risk for developing fractures in other areas. So it's the best population for teriparatide is severe spinal fractures, but not at risk for non-vertebral fractures. Okay, that's the group in which teriparatide is. So I suppose if you had if you had CKD, MBD, unfortunately, if they already have a high turnover bone disease, really difficult. I think you would generally manage these patients with calcium and activated vitamin D and maybe some cynic acid, but I don't see teriparatide being used. So this is the problem with our group of patients. Most trials exclude patients with severe kidney disease. In fact, the biggest trial on denosumab, which was the FREEDOM trial, less than 1% of the patients actually had stage 4, and there was no one with stage 5 CKD. So we really don't know how to manage this, our set of patients. Most of the data is very observational, and that has its own problems because it has its own biases. And it's really a lot of it is based on talking to experts. So I would say as nephrologists, we really need to collaborate with people who are specialists in this field and who can guide us. We need to bring our own insights into this. And I will say that, for example, over here, if you talk to a rheumatologist, they would say, we want PTH in the normal range. But as a nephrologist, you have to talk to your colleagues here and say, for us, we don't want it in the normal range. We want it actually higher than the normal range. So I think it needs a collaboration between nephrologists, because we have a unique perspective on our patients, and people who actually specialize in bone disease and who manage patients with osteoporosis day in and day out, and together think on a case-by-case basis what would be best for a particular patient. I don't think there's ever a blanket rule for what should be done. It's really a case-to-case decision.
Thanks, madam. Thanks for clearing it.
Madam, what calcium level would you recommend before we start denosumab?
What calcium?
Levels would you
What
want
calcium
us to
level?
be?
Okay, so the guidelines again are very vague. The guidelines simply say you should have a normal calcium level, and I know in India that itself is difficult because our patients generally always have calcium at the lower limit of normal. I would say the labs in Vellore, it was between 9 and 11. I would want the calcium to be at least 9.5 and above, because from what I've seen, even by using Cinacalcet, the calcium just drops quite dramatically within a few weeks. And I've had only one patient that I used denosumab in Vellore, and I almost immediately landed up in trouble. In fact, I couldn't use denosumab after this. My colleagues here report the same thing. So you need very close monitoring, because and you need to monitor at least once a week so that you can catch the hypocalcemia early and then work on it. And I would say definitely don't start denosumab till you're at least 9.5 and above at least. And the other thing is, it's difficult for these patients to keep taking that much calcium and vitamin D. For us, it's very easy to prescribe denosumab, because we think, we just have to see the patient once in 6 months. But for the patient who actually has to take 1,000 milligrams of calcium every day and vitamin D, it's not easy. So you also have to think about a patient's compliance once you started them on denosumab. So these are all things we need to take into account. Is the patient going to follow up with us? Is the patient going to actually take their calcium and vitamin D supplements? Can the patient afford denosumab? One injection is around 16,000 rupees in India. So a lot of decisions. It's when new molecule comes into the market, everyone's in a rush to use it, but there are all these implications with taking that decision.
If there are no further questions, can we close the session?
Thank you, madam. Thank you again for this wonderful talk. So if there are no further questions, we will give it back to the organizers.
Thank you. Thank you so much for having me.
Thank you, ma'am. Thank you. Thank you, ma'am. Thank you to the chairpersons.
Going on to our next session. The topic is trials in lupus nephritis. I would like to invite our chairpersons, Dr. R.P. Muthukumar, Senior Clinical Fellow, Hammersmith, UK, who has joined us virtually. Dr. Jyotsna, Senior Consultant, Star Hospital, Hyderabad. Dr. Tanima Bhattacharya, Narayana Multi-Speciality Hospital, Kolkata. I request our chairpersons to introduce the speaker.
Hello everyone. I'm Dr. Aarti. I'm doing my senior clinical fellowship in Hammersmith Hospital. Can you see and hear me?
Yes, ma'am.
Thank you very much to the WinIcon team for having me here. It's my pleasure to introduce Dr. Sayali Thackeray. We have known each other right from the NSMC and the GLOMCon days. And she is currently working as an assistant professor in Sith GMC College, KM Hospital, Mumbai. She's a very, very active participant in the social media. Like, people who are on Twitter will already know about her. And we were in awe when she published her recent GLOMCon publication on lupus nephritis. So over to you, Dr. Sayali.
Thank you, Dr. Aarti, for that kind introduction. Good afternoon, everyone here. I'm very happy to be at the WinIcon today. And I'm thankful to the organizers for letting me talk on this topic regarding which we all are very eager and excited to learn new things about. We always are in search of new information about lupus nephritis. So today I'll be talking to you about trials in lupus nephritis. And this is the outline of my talk. I'll begin with the older agents and the trials which led to the acceptance of the older agents, the conventional immunosuppression that we use currently. Then I'll go to the trials of agents which have been explored until now, and then the trials that led to approval of new agents. We'll take a look at the trials on the horizon, the new trials on the horizon, and we'll take a look at some limitations which we still face even after half a century of trials in this particular field. So before we go into this, let me tell you how what are we facing? How bad is the situation with lupus nephritis? So lupus nephritis affects women disproportionately, women of the childbearing age group. And we know that it affects women in different proportions in different geographical areas or in different cultures. So SLE or lupus nephritis or end-stage renal disease, all of these are 2 to 4 times more prevalent in the African American population than whites. This is the well-known factor that's been known to us since ages. But how do the Asians fare? The Asians fare no better. The Asians also have an incidence which is 2 to 4 times more than the Caucasian population. The other populations at risk are Native Americans and Hispanics. India doesn't fare too well either. So at an incidence of 3 per lakh population, we face approximately 20 to 40,000 new incident lupus nephritis patients per year, which is quite a big number. And this translates into a proportional standardized mortality rate, which is 6 times higher than the general population. You add on to it lupus nephritis and end-stage renal disease due to lupus nephritis, and this mortality statistics goes to 26 times higher. Shockingly, this is twice higher than the malignancies and CV deaths that women experience in the same age group. And this mortality is observed all over the world in all the populations. What is even more shocking is that nothing much has changed over the last 4 decades. So a recent study from a well-resourced nation showed that not much has changed with respect to the standardized mortality rates in lupus nephritis over the last 4 decades. So we all know near home, closer to our clinics, this translates into 20 to 30% of our lupus nephritis patients progressing to end-stage renal disease in 10 years. It may be worse. We do not have much data. And we all know this is a highly preventable mortality. Timely reporting of lupus nephritis, timely diagnosis of SLE to begin with, availability of resources for getting drugs, availability of newer therapies, access to trials, these all can make the difference between life and death for patients with lupus nephritis. So as clinicians, and as trialists, people face this Goldilocks levels of balance that is to be achieved when you start treating a patient of lupus nephritis. So on one hand, we are juggling with trying to achieve remission, maintaining remission, avoiding flares, avoiding progression to end-stage renal disease. And on the other hand, we are trying to minimize the toxicity with respect to infections, reproductive health, cardiovascular disease, cancer. We are trying to extend their life expectancy. The therapy of lupus nephritis, SLE and lupus nephritis, was stunted by SLE being a woman's disease, inadequate SLE advocacy, and the early NIH trials, which demonstrated that a mean time of around 5 years needed to be seen before any treatment arm was found to be superior. So all the rheumatic disease resources were pipelined into rheumatoid arthritis and spondylitis research, where the outcomes were more evident within 4 to 6 months and short results could be demonstrated. So in brief, this is the timeline of the 35 years of trials in lupus nephritis. There have been trials before this, there have been trials after this, but let's go to 1964 when some of the landmark observations on lupus nephritis therapy started coming to the scene. So this is an early trial by Pollock, Pirani, and Schwartz from the United States of America, where 87 patients underwent multiple biopsies, up to 176 biopsies, were divided into 4 groups based on histopathology. And the investigators found that the patients who received steroids survived longer, and the higher doses had a greater advantage over the lower doses of steroids. So this was the first trial which kind of showed that steroids altered the mortality and steroids reduced the progression in lupus nephritis. The early trials in the next decade of 1970s were as aspirational as this. They had as little as 13 women. They had no active control arms, only placebo was used. They were double-blinded. They used newer cytotoxic agents. The most popular amongst them was cyclophosphamide, and a huge dose of steroid was also permitted in both the arms, which also kind of masked the effects that were supposed to be seen with the introduction of the cytotoxic drug. And the results read as great improvement in the renal survival. An editorial from 1973 is interesting. Here they show that they kind of urge a moratorium on case reports, and they kind of decry further publication of poorly designed therapeutic trials, which can only worsen a situation which is bleak. But what was clear from this decade was that cyclophosphamide prevented renal progression. So many trials showed that short courses of cyclophosphamide, six monthly courses of cyclophosphamide, resulted in a short-term difference in outcomes. But these differences were not to be seen in the long term. This is before the NIH era. Now, the NIH era was when systematic studies of lupus nephritis, controlled trials of lupus nephritis, and long-term follow-up was begun. So at Bethesda, Maryland, at the NIH NIDDK, the NIH trials were conducted over a span of 2 to 3 decades. This is the first NIH trial by Austin et al. It was conducted over a span of 12 years in a group of 107 patients, and steroids as the first group were compared with 4 other groups of cytotoxic agents, azathioprine, cyclophosphamide, a combination of both of them, and intravenous cyclophosphamide. This is probably the first trial where intravenous cyclophosphamide was used. And these groups were followed for around 4 to 5 years, maximum for 7 years. What was seen here was that high-dose prednisolone, if you look at the graph here, high-dose prednisolone was inferior to any cytotoxic regimen, be it azathioprine, be it oral or IV cyclophosphamide. And a statistically significant difference was found between IV cyclophosphamide and prednisolone. The oral cytotoxic drugs started to show some difference, some improvement in the survival, but very late. Around after 85 months, the curves separated and showed some kind of a difference between oral prednisolone versus oral cytotoxic agents. So the question came in the first NIH trial, the steroids were used with a very minuscule dose, 1 milligram per kg for 1 to 2 months, followed by a gradual taper, and that's it. That's the regime of steroids that was employed. Was it sufficient enough? So the next NIH trial by Bompas et al. In 1992, it was designed with the aim of answering the impact of pulse prednisolone and pulse cyclophosphamide on the progression of lupus nephritis. So here you get to see the pulse prednisolone for 6 months compared with low dose cyclophosphamide, low dose meaning a monthly dose given for 6 months, and the current NIH protocol that is followed, the 6 monthly dosing followed by quarterly dosing for 2 to 3 years. This trial had more severe lupus nephritis than the other NIH trials. Many more of them were African Americans. And what was seen here was very distinct. While methylprednisolone resulted in doubling of creatinine in more than 50% of the patients by the end of 5 years. So it was a very poor renal survival. And the probability of exacerbations was much higher in the low-dose cyclophosphamide group. The high-dose cyclophosphamide group performed much better. So this was the second NIH trial. The third NIH trial also strengthened this observation that intravenous cyclophosphamide was much better as compared to only methylprednisolone, and the outcomes were as high as 62 and 85%, though observed in a small number of patients, but they were observed in the setting of an RCT. What was, however, apparent now is that cyclophosphamide had a lot of side effects, and these had come through very consistently in all the NIH trials. Be it amenorrhea, cervical dysplasia leading to cancers, or herpes zoster, or at least one or two episodes of infections, or severe infections, hospitalizations, or death. These all were more with the cyclophosphamide group. But still, cyclophosphamide became a popular agent because it was non-specific as an alkylating agent. It had an effect mainly on the T and B lymphocytes instead of the glucocorticoids, which had a multitude of effects on many inflammatory signaling mechanisms. So newer therapies were looked upon, and this is the first therapy apart from an alkylating agent, mycophenolate mofetil, that was researched around the late 1900s. And here, this is a trial from Asia, from Hong Kong and the Guangzhou Chinese group, where mycophenolate mofetil was found to be as effective for induction as cyclophosphamide. And this was a group of Asian people. So here you can see that the complete remission rates at 12 months, at 1 year, was 81%. The partial remission rates between both the two groups were not very different. The relapses were not very different, but the infections were less, 19% versus 33%. And most of the side effects occurred in the cyclophosphamide group, not many of them occurred in the MMF group. So this was the East Asian population, the favorable adverse event profile of MMF. And then came the urolupus nephritis trial. So here the urolupus regime, the low-dose prednisolone and cyclophosphamide regime for 6 pulses, both were followed by azathioprine. This we all know was found to have an equal outcome measure as compared to the higher cyclophosphamide regime, be it treatment failures or renal remission or flares or doubling of creatinine. The low dose performed equally well to the high dose, and with a less significant number of side effects. The long-term follow-up of urolupus nephritis trial, where these patients were followed for 10 years, was also favoring the low-dose regime. 70% of these low-dose treated patients did not need any additional cyclophosphamide pulses during the next 10 years. ESRD and sustained doubling of creatinine did not differ between the two groups, and the survival at 10 years was very good. It was at 92%. But then again, this was Caucasian lupus, which is known to be not very severe. So compared to the NIH trials, the renal impairment and nephrosis here was of a much lesser magnitude. And this population was a homogeneous Caucasian population, unlike that in the NIH trials where you had a mixed population with many multiple ethnicities. So the favoring of low dose of cyclophosphamide may be because the population was Caucasian and they required a lesser dose to curtail a disease which is not so severe. This trial also brought forth the need to look into another agent for maintaining the remission, because on azathioprine, 25 to 30% of the patients experienced flares as compared to mycophenolate. Can I have some water? So in azathioprine treated patients experienced a flare rate which was much higher than the one which was seen in the Chinese study by Chan et al., which was to the tune of 10 to 12%. And here it was almost double double the rate of flares was observed in urolupus trial with azathioprine. Later on, however, the criticism of this trial fell apart. The trial was replicated in a mixed population in the USA and India and the Asian population, citing these two studies from India here from Rathi et al. And Sahai et al., where the low-dose urolupus regime fared equally well as compared to MMF and cyclophosphamide, other high-dose regimes. The decade after ELNP, however, was devoted to finding out other agents for maintaining a remission, for induction and maintaining remission. So MMF was trialed as an agent for maintaining induction and maintenance both, azathioprine mainly as a maintenance therapy, and CLIs were now introduced as a part of multi-targeted therapy for induction. So after the Chinese trial showing very good results for mycophenolate, this is Ginsler et al. This is from the United States with 19 centers and a mixed population. 2 regimes for induction were used, and here too mycophenolate performed well. The ARMS trial, which was the largest RCT in 2009, recruited 370 patients, and here as well, the performance of MMF was, though not statistically significant, MMF was not found to be superior statistically speaking, but then it was equivalent, the results and the numbers were equivalent to that of the comparator arm, which was cyclophosphamide. Further on, the patients who responded in the ARMS trial were continued as a follow-on therapy, as the maintenance therapy with MMF. And here also it is found that MMF was a superior agent for maintaining the remission. Another very well-designed trial came from Contreras et al. This was again a United States-based trial. And the 3 regimes, the 3 popular regimes of maintenance in lupus nephritis were compared head-to-head with each other. Event-free relapses and event-free survival was higher with MMF and azathioprine, and it was much better than cyclophosphamide. And hence this led to the establishment of MMF and azathioprine as the maintenance therapy, as the treatments of choice for maintenance therapy. This was replicated again in a Caucasian trial where azathioprine and MMF were found to be almost equivalent. There is a lot of literature about all these trials with a long follow-up, of around 10 years. And it is interesting to see how these patients are very linearly maintained in these studies. So even the maintained nephritis trial, which was a European trial, showed an equivalent performance of MMF and azathioprine as a maintenance therapy. Then come the CLIs. CLIs were more popular in the Asian population. In China, there were a series of trials. This one was the first pilot RCT. It was followed by a larger RCT of 362 patients, one of the largest numbers of trials in lupus, one of the largest numbers in the trials of lupus nephritis. And everywhere it was found that the multi-targeted therapy with a CLI added to either MMF or a cyclophosphamide, it fared very well. And these were all broad-based immunosuppressive agents. The addition of CLI added an element of selecting the immune response that we needed to suppress. So while steroids, cyclophosphamide, mycophenolate, and azathioprine, they acted as broad spectrum immunosuppressants. Tacrolimus was suppressed more of IL-2 activity, and it affected the T cell activation and the T helper cell signaling much more so. So where were we? We actually have seen the pathogenesis of lupus nephritis. A lot of research has happened in this. And we now know that the innate immunity that gets stimulated by by the destructive effect of autoimmunity, that stimulates the key driver, which is the plasmacytoid dendritic cell. And through its effects on T cell and B cell and further plasma cells, it leads to the effects on the complement and further damage to the target tissues. So were we, apart from the broad spectrum immunosuppressants, would there likely be new targets? Of course, there were likely to be many more new targets, because the pathogenesis of lupus nephritis had shown us that there were many inflammatory signaling mechanisms happening. There were many pathways that were activated in that single entity of lupus and lupus nephritis. So we all know LUNAR trial. After the Explorer trial in SLE, LUNAR trial explored the effect of rituximab as an add-on therapy to the standard induction therapy. And here, though it was not statistically significant, rituximab did not achieve the primary endpoint of being a superior therapy, superior choice of addition therapy. But then a signal came through of it being numerically or it having a satisfactory performance with less amount of adverse effects and less amount of progression of the disease. So overall, there was a slightly better signal for rituximab from the LUNAR trial in the African American population. And later on, in a subgroup analysis, which was done a few years later after the conclusion of the study, it was found that the patients who deplete CD19 cells much more completely, they are the ones who get complete responses. So 78% of the patients who depleted these CD19 cells at the end of 1 year, they had complete responses at 78 weeks henceforth. So 47% versus 13%, the odds ratio was as high as 5.8. So B cell depletion does matter in while treatment with rituximab. So further, after 2 unsatisfactory trial results, rituximab was further investigated as an add-on therapy for refractory lupus nephritis, which was the Rituxi Rescue, and as a steroid-sparing therapy, which was in the Rituximab trial in 2013. In the following years, after a lot of biologics proliferated, FDA put in some guidelines for lupus nephritis drugs. Any drug for getting approval needed to meet the primary endpoint in 2 well-controlled trials. The trials needed to be at least of 1 year duration. The criteria for defining SLE, defining lupus nephritis, defining the severity, they were all decided. And the variability of the other concomitant immunosuppression that needed to be addressed. So steroid variability, which could confound the results, was supposed to be addressed. And the safety profile had to be satisfactory for looking at any kind of an approval. So this is the proliferation of drugs that came through in the last 2 decades. It starts from the plasmacytoid dendritic cell, then the T cell, the interaction from the T to the B cell, then the plasma cells, and the terminal complement pathway. So these are the many drugs. Many more have been researched for SLE, systemic lupus erythematosus, but not all of them could be translated to lupus nephritis. So these are the trials which have been done for patients with lupus nephritis, not just SLE, specifically for lupus nephritis. So we have therapies like B cell depletion, we have plasma cell therapy, plasma cell depletion. We have therapies for B cell, controlling the B cell activation, the co-stimulatory blockade. So here, you know, the anti-B cell therapies are, they act at various points during the maturation of the B cells. And largely they cause a depletion of B cells by cytotoxicity, either complement mediated or antibody dependent cytotoxicity, or by activation of apoptosis. The signaling pathways, the B cell activation pathways, they are mainly constituted by the B lymphocyte activating factor, that is the BLyS or the BAG and APRIL. These act via the agency of their 3 receptors. And once their activation is controlled, the B cell activity declines. So these are the anti-B cell activity, the drugs which target the B cell activity. The other ones are the co-stimulatory blockade, which deal with the crosstalk between the T cells and the B cells. And there are other multitude of therapies arising which deal with the cytokines or the terminal complement. and many others which deal with various different pathways in the inflammatory milieu of lupus nephritis.
Now we have 5 minutes.
Yeah. So in between the last 25 years, many trials have been conducted. They've completed. Some could get completed. Some could not meet the primary endpoints. Some had a lot of safety signals. They had to be terminated early, owing to a lot of complications. But then these are by and large the drugs which failed to meet their primary endpoints, or which were terminated early, and no further research was carried out with these drugs. But then luckily we have some drugs which are now approved for lupus nephritis. So if you look at TULIP LN1, that deals with anifrolumab, which is an interferon inhibitor. This drug anifrolumab is actually approved for lupus nephritis, for systemic lupus erythematosus, not lupus nephritis yet. But then there are 2 drugs, belimumab and voclosporin, which have now been approved by the FDA based on trials which showed a very good effect of both these therapies on lupus nephritis on the background of standard of care. So belimumab is an anti-BAFF agent. It binds the B lymphocyte stimulating factor. It does not let the factor bind to the B cell, and hence the B cell survival is greatly reduced. The trial which led to this approval was the BLISS-LN trial, where it was one of the biggest trials of lupus nephritis with 448 patients, 107 sites, followed for almost a span of 2 years. And you have a good difference in the primary efficacy response and the complete renal response, to the tune of an odds ratio being generated as 1.6 to 1.7. This therapy, a subgroup of BLISS-LN, which was in the East Asians, also shows an equivalent efficacy of belimumab in East Asians and an equivalent safety profile in the same population. BLISS-LN cohort was followed up for a 28-week open label extension later, and there were no further safety signals, and there were no and the response continued to be maintained even through this open label extension phase. So this was belimumab, which was approved recently in 2020, December 2020. Another premise that was evaluated was the BAFF levels are supposed to rise after a B cell depleting therapy, which is something like a rituximab or obinutuzumab. So once the BAFF level rise reactively after rituximab, you need something to curtail the BAFF so that the autoreactive B cells do not proliferate. And this is a sequential therapy which is still being evaluated in a phase 3 trial in lupus nephritis. And here you can see that there is a sustained B cell depletion with this sequential rituximab followed by belimumab approach, which can lead to better outcomes later on. So this is the reconstitution that happens after rituximab. If you add belimumab to it, you have a better population, the orange population of better cells, which will mitigate the pathogenesis of lupus nephritis. So B cell depletion is closely related to rituximab and obinutuzumab. As you can see on the left-hand side column, obinutuzumab maintains the B cell depletion of more than 95%, almost up to 1 year of therapy, which does not happen with rituximab, and that is probably linked to the decreased efficacy of rituximab in lupus trials, or in fact any other trials in glomerular disease. So obinutuzumab was also anti-CD20 antibody, and on the basis of nobility trial, obinutuzumab was further spearheaded into the Regency trial which the results of which we are awaiting now. Voclosporin is another newer treatment. It is a cyclosporin analog with all the advantages of CNIs. However, it has more consistent bioavailability. There's no need for therapeutic drug monitoring. There's no interaction with MMF. There's a favorable effect on lipid and glucose profiles than CNIs. It's a very attractive profile. And on the basis of these RCTs, the AURA-LB and the AURORA-1, voclosporin also got an approval for using with the standard of care as an induction therapy. The follow-up of AURORA-2 also shows no new safety signals, and the efficacy is maintained. As you can see the curves, the efficacy is maintained very well until another 6 months to 1 year after the first trial got over. So this is anifrolumab, which we saw. The other trials which are promising, which are already in phase 3, are the secukinumab, which is anti-IL-7 antibody, and the ravulizumab, which is anti-C5 antibody, which is currently approved for PNH and is under trials for atypical HUS. So these are the complement and cytokine pathway inhibitors. Of course, there are newer therapies like CAR T cell therapy, which are now under evaluation for lupus SLE, but now they will slowly move on to lupus nephritis as well. And take a look at this graph. Here you can see that except for the multi-target therapy, the CNIs along with standard of care, most of the trials do not give a response rate of more than 50%. And this is very, you look at 6 months or even 24 months, the response does not exceed more than 50%. And this is where we are still stuck. We have so many drugs, we have broad spectrum, we have sniper attacks, we have carpet bombing, and we have sniper attacks, but we are not able to bring down the rate of progression in lupus nephritis. So the farther backwards we see, the farther forwards we can see. We have seen all the trials from 1964 to now. And what is next now? What is next is the coming 25 years of the coming 20 or 25 years of trials which are awaiting, which are there in the pipeline, which are still getting conducted. And these deal with the B cell therapies, the co-stimulatory blockade, the cytokines, the complement therapies, and many others. And we are awaiting this decade. We are awaiting the end of the decade for the data from these trials to start making sense to us. Closer home, we have a trial running, Equalize, with itolizumab, which is an anti-CD6 monoclonal antibody. The trial is expected to get done by the end of this year. We'll be awaiting the results. But apart from that, we have a lot of blind spots. Most of the trials are in proliferative lupus nephritis. We do not have much data, much RCTs for childhood onset lupus nephritis, membranous lupus nephritis, for vasculitis, for resistant lupus, for maintenance therapy, the duration of the therapy. We still are stuck with using steroids. We still need more therapy, more trials for steroid avoidance. And we need some short-term predictors of future response because we cannot wait for a median of 5 years for getting a hands-on experience on therapies. How does the therapy perform in real life? So we do need some short-term predictors. So I end my talk with this snippet from James Lind, who did the first RCT, supposedly the first RCT in 12 patients of scurvy. They were sailors and they were each given 6 therapies, two each in each group. And they found that the oranges and lemons that were given to the 2 patients, that resulted in the earliest kind of the sailors were able to resume their duty after the therapy with lemons and oranges. So we have a lot of difficulty with conducting trials in a disease as diverse and as difficult as lupus nephritis. But there are many new agents that have come up, and we are poised to receive much more good news in the future. And it's a very exciting time for lupus nephritis. Thank you.
Thank you so much. For an elaborator, we have here discussion about lupus nephritis. I have a question for you. Hello. Thank you, Dr. For resistant lupus, as you pointed out, like there are situations in our practice which we see they would respond initially, but when you start to take like induction, when you start to taper off the induction, they will again relapse. But when you continue, especially as you pointed out, multi-targeted therapy, if you continue that, like they do well, but when you try to decrease the doses again, they will go into relapse. I have a couple of patients who have been using the multi-targeted therapy for like more than 5 years right now. I don't have an evidence, but they do very well without any side effects that probably using transplantation, where we use all like all the 3 drugs. When I use they do well. But given the fact when you see the lengthy duration of it, when you try to cut down, they're going to do that. Then at that time, it's difficult for me to again treat with induction or to get them back to the track. What do you do for those kind of patients?
So it's a very difficult question, and especially for us who practice in a country like India, where we don't have access to any new research therapies, or we don't have access to trials, which is a good way to deal with patients who do not respond to any therapy. But I agree with you that the multi-targeted therapy may be of much better use in Asians and Indians because the response rates that have come through the trials are the best for multi-targeted therapy to the extent that they seemed unbelievable at times. They were as high as that. And the other approach, apart from the multi-targeted therapy, would be to add on rituximab as pulses or as a recurring therapy. But then you need to track the CD19 cell count and track the depression of the counts and ensure that the counts are actually depleted for rituximab to be taking some effect. Obinutuzumab can be a good option nowadays. And plus, like we have seen, these new therapies adding voclosporin probably if the CNI component is becoming too toxic or you've used it for a span of many years, you may switch on to voclosporin. Of course, the cost is a problem. But then these newer agents add on to the standard of care. Probably that's the only way to go right now because we don't have a single therapy that can directly bring down the side effects or the toxicities of the existing therapies, and the net immunosuppression becomes too much.
What are the newer drugs? What about
The other drug which is approved is belimumab. So it's not available in India, but then if you look up, if you try to Google how to get the drug in India, you need to import the drug. Like basically you need to set up a pathway for importing the drug, and the cost is prohibitive. One vial probably costs somewhere around 80 to 90,000, and we are looking at 4 doses at the beginning and an indefinite number of doses for maintenance later on. That's how the trials use it. So at present, I would say that for the next maybe 5 years, we really don't have many options until the prices come down, and we have some more other trials where the results get announced.
It's open for questions. Oh, the next day, ready. Okay. Thank you.
Thank you, Dr. Sayali. So with a lot of newer molecules coming up, like belimumab and voclosporin approved, where do you see the role of these agents? Themselves alone are probably not able to create a class 4 or a treatment name lupus nephritis. Where exactly you see once they are available in clinical practice? Where is the role of these agents?
So if you see all the RCTs at present, all of these drugs are used as add-ons to standard of care. None of them have been used as a therapy to begin with. So mostly it's like you start with an induction therapy of your choice, suited to your patient. For example, if you have an Asian population, we would go for MMF rather more than cyclophosphamide at times. We may do that. So your choice of induction therapy, and you may add on these drugs as a add-on agent as of now.
For sparing the
not really sparing, because they don't talk of sparing except for the steroids part. The steroids, for example, even in LUNAR trial, the doses of steroids were very, very high. We could not see the effect of rituximab because the doses of steroids were high in both the arms. So the efficacy probably, the benefit could not be brought forth. But if you see rituximab, they used a very less steroid dose at the beginning, and afterwards there were no steroids given at all. So we can consider them as steroid sparing later, but as of now, the trials, whichever are designed, they only curtail the dose of steroids. The other induction agents like MMF or CYC, their doses are not, I don't see them getting curtailed at present. We will have to probably look for more efficacy and this happening to MMF and cyclophosphamide like it is happening to steroid later on.
Thank you, ma'am. Move on to our next session. Next session is the panel discussion. Patients Voice Kidney Diary Foundation. To chair the session, I would like to call upon chairpersons Dr. Umesh Rai, Professor INU Bangalore, Dr. Arvind Kanchi, Senior Consultant Nephrology, Trustwell Hospital Bangalore, Dr. Swarna Shashi Bhattara, Consultant Nephrologist, Regional Hospital Bangalore, Dr. Himamani, Professor Nephrology, MNC Mysore, Dr. Sonia Gupta, Consultant Nephrologist, Udaipur, Rajasthan. Somebody here.
Hello. Good evening. We are at the end of the scientific session. It was a feast tonight. I would invite our panelists and also moderators. This is Marian
Hello.
on the stage, or she's on virtual platform. She's on virtual platform.
అవును దేంట్లో సేవ్ చేసినావు అర్థం కాదు.
Renuka ma'am is on the stage. And if any other panelists are there, Dr. Urmila and Dr. Muthu Jayaraman ma'am.
I am at the airport, but I am on the Zoom link.
Thank you, ma'am. Yeah, I request the moderator to proceed with the discussion. Ma'am, you can proceed, ma'am. Mariam, ma'am.
Hi, a very good afternoon, or rather, very good evening to one and all present out here. I'm Marianne Manasseh. I'm Director Communications for the Kidney Warrior Foundation. And it's indeed a pleasure to be here with the Power Women of Women in Nephrology. And today it's indeed a pleasure for me to share space with 3 senior nephrologists and to discuss some of the challenges faced by the patient community. And wherever you are this afternoon, if you're physically present or if you're present in your respective homes watching this, please give a big round of applause as I introduce our first speaker who's physically present over there. Please welcome Dr. Renuka, Professor Nephrology, St. John's Medical College, Bangalore. So may I request Dr. Renuka to please join us on the dais. Thank you, Dr. Renuka. On this panel, we also have with us Dr. Muthu Jayaraman, that comes from my very own city of Chennai, Senior Consultant Nephrologist, Curie Hospital. And then we have Dr. Urmila Anand, Head of Nephrology, Amrita Hospital, Faridabad. So once more, may I request you to please welcome our panelists on the dais and on the screen. And may I request our panelists to open up their screen so that we could actually see them and we could move forward with the session. Thank you, Dr. Urmila.
Marian, I'm at the airport, so
yes, doctor.
What I'll do is I'll keep myself mute. Whenever I have time, I'll just answer your questions.
Sure, doc. Sure, doc. Yes. So since we have Dr. Renuka is already present out there, I think let's start off with Dr. Renuka. And Dr. Renuka is going to be discussing and sharing a few pointers through her slide on a very important discussion on peritoneal dialysis, which is a huge discussion within the patient community of which works better in favor of the patient. And let's hear what Dr. Renuka has to say from her point of view. While Dr. Renuka is actually getting ready with the presentation, the first time that I had a discussion on peritoneal dialysis, I had the honor to share space with Dr. Urmila Anand. And I remember, I think I was educated on peritoneal dialysis with Dr. Urmila, and I'm really excited to know more about the challenges or the reasons why patients choose or do not choose peritoneal dialysis. And I think we have Dr. Renuka's slide almost ready. Thank you, Doctor.
Thank you, Marianne, for this wonderful introduction.
Let me now start this thing session. See, as we know that our patients, most of them, when they get end-stage renal disease, they are from not from the upper economic status group. They are either middle or lower income status group. So the need comes that whether we can promote CAPD in India to the grassroots level. So let us see what is there in this case. We know that when kidney disease affects 1 in every 10 Indians, and around 5 lakh Indians are believed to be in the need of treatment with dialysis. So even in the Pradhan Mantri National Dialysis Program, there is a demand of 30 million additional dialysis every year. Are we going to have that much dialysis center even if you open in the district level? Is the question. Now, what are the challenges in the management of CKD? Of course, the poverty, the logistic issues of transport, the patient education and counseling, the environmental factor, and the finances. We, as this cartoon shows, that 25.0% of the patients of India are in below poverty line. So this is a beautiful paper in Frontiers in Nephrology, October 22, by Urmila Anand and Co. And they have brought out the social determinants of kidney health. Again, that is economic stability, social and community context, healthcare provision, education, environment and neighborhood, and political and legal factors. So all of us know that there are many causes of CKD, among which most important is diabetes, high blood pressure, obesity, family history of the renal disease, and some lifestyle-related problems like smoking and tobacco use. And most of these, except the family history of renal disease, rest of them are preventable cause of chronic kidney disease, which should be emphasized more rather than thinking of management of end-stage renal disease. Now, what is positive about CAPD? From the patient point of view, CAPD is the best modality of renal replacement therapy. It is useful in the remote areas. It does not require electricity and a travel to the center, and it is good in natural disaster and pandemic. And this pandemic which we had, COVID-19, it has been proved to be very useful, and we have many studies from New York regarding this. It is the best modality for children, particularly school-going children, elderly and handicapped, where there is a logistic issue of bringing them to the dialysis center. There is no precious time and job loss for the family members. PD allows the patient to move freely at home and maintain a flexible lifestyle. One can perform the therapy as per convenience without having to worry about visiting a hospital. PD saves multiple clinic visits and generally more cost effective, and it requires a lower infrastructural requirement. So these are the benefits of PD. What is the negative about PD? The negative issues are it requires a storage place at home for bags. This is really a problem in a lower socioeconomic status where they have only a one room to live. Requires a tap water, running water to hand wash and sterilization. Requires a dedicated person to do and time of the dedicated person. Separate room for doing a procedure. The cost, the insurance coverage, government support, and nephrologist reluctance is something which we can control, and it is not the patient problem. This is an article from 2022, published from India, Peritoneal dialysis as the first initiative in India, a cost-effective analysis. The conclusion of the study was the PD first policy is definitely cost-saving, and if the PD first policy is utilized in Pradhan Mantri National Dialysis Program, the PD consumable will come down at the lower prices. The cost of providing PD is largely being borne by the patient or the patient's relatives, and subsidized treatment under Pradhan Mantri National Dialysis Program will definitely reduce the financial hardship of the patient. The introduction of PD first policy linked to primary healthcare services is likely to improve the access to the treatment for patients in rural and remote areas. So this is the Pradhan Mantri National Dialysis Scheme, which was started in April 2016, and already 36 states and 641 districts, they have opened 1350 dialysis centers. But these are all chemodialysis centers. Under this Pradhan Mantri Dialysis Program, we have also got peritoneal dialysis, which is given free of cost to the below poverty line patients. So dialysis fluid, catheters and other accessories that are required for peritoneal dialysis is provided free of cost from the hospitals for the registered patient by Kerala government. In Andhra and Telangana also, under Arogya scheme, they give 15 days back free. Under Rashtriya Arogya Nidhi, person with annual income less than 1.25 lakh get free bags. In Karnataka also, free CAPD catheter insertion and initiation is done in the government hospital, and free CAPD bags are given to the BPL patient. In between, there was some block, but it is again restarted. In Tamil Nadu and Puducherry also, the bags are given free every 15 days under Makkal Teddy Moruam scheme. They also send health workers if the person is elderly or handicapped. So these are the various state and central health programs. I will not go into the detail. Even the ESI, railways, CGHS, and public sector undertakings are now recognizing PD. So with this, I think the cost of PD will in India come down and penetration of PD to the rural areas may increase. The medical reimbursement by insurance. Till now, since the CAPD was a home-based therapy, the medical insurance company was not recognizing this as a therapy. To address this increasing number of kidney patients in India, the Insurance Regulatory Development Authority of India, that is IRDAI, has released a policy guideline to include peritoneal dialysis in the ambit of private insurance coverage. Now, let me tell you, already 14 insurance companies are now covering CAPD. According to the guideline, patients taking treatment for PD can make a reimbursement claim on a monthly basis through an approved pre-authorization procedure. The provision of new guidelines is already effective from 1st October 2020. So there is a demand of 3.4 crores dialysis with only 4,950 dialysis centers approximately. Despite PD's potential advantage, its penetration in the country is very poor. According to a report of 2019, there are just 8,500 patients of PD in India. So now the most important questions comes to the mind, apart from the finance and the penetration, what is the outcome of CAPD as compared to in-center HD? Because this is one thing which the patient may ask us. Over the past 3 decades, many studies have compared the outcome associated with in-center HD versus PD during all, and this we have found that the patients initiating on dialysis PD had a better earlier survival. Contemporary data suggests there is no significant difference in the overall patient survival between a PD and in-center hemodialysis. These studies were found across the globe, including Canada, Netherlands, Taiwan, Colombia, Australia, and New Zealand, and United States. This is a study from our own country done by Dr. George Abraham, who is considered as a father of CAPD in India. There also, the long-term survival on peritoneal dialysis in South India was found to be very good. The Baxter company, which provides the fluid, CAPD fluid, they started a once per lifetime payment scheme way back, and then they found that the survival of patients on CAPD was much better, and they withdrew this lifetime payment scheme because they were found they were going into the loss. So this was the problem of low utilization of PD, high cost, physician and provider bias, PD peritonitis, and low socioeconomic strata unsuitable. Now, how to increase this? Now we should have an awareness, and we should have the recognition and acceptance from public health. Government should support, and the insurance company should come forward. Then the penetration of PD becomes easier to all categories of socioeconomic status. Now that the next question was, if the PD is come, PD is now utilized all over, then what happens to the infection-free CAPD, which is the next question a patient has got a concern. All centers practicing CAPD as a dedicated CAPD nurses for taking care of the patient both in center and remotely through the phones. Some centers have healthcare workers visiting the patient's home. Under allied health sciences, we have BSc renal dialysis and diploma courses in dialysis going on. These students are also trained in CAPD procedures. So I don't think there will be any scarcity of a good technically trained person to teach CAPD even in the district levels. Now, ISPD peritoneal guidelines also, if you concentrate on the third column, the prevention is more important. That is, if there is a doubt that you have not used the antiseptic precautions properly, you can take an antibiotic prophylaxis. And even before putting a catheter, we use the antibiotic prophylaxis. Topical ointments are given for exit site care, antibiotic prior to any invasive procedure, like if you have to undergo a gynecological procedure, dental procedure, or antibiotic prophylaxis is given. Pets are not allowed in the PD exchange room, and you have to avoid H2 receptor blocker or hypokalemia. If these things are followed and 7 steps of hand hygiene, I don't think PD peritonitis will be a big problem in our country. Now, the second thing I was asked that some patients have got this problem. What is the nephrologist's role in educating the patient about managing AV fistula? I think this is a very important question from patient point of view, because they have to know what AV fistula is there and how we have to manage the AV fistula. So taking care of AV fistula by patients, there are certain important points. First is to look for the redness or swelling around the fistula area. If you experience any pain in the fistula area, contact your doctor immediately. If you get a fever and there is a sign of infection in form of redness, again, please come to the center or contact your nephrologist. Every time before you reach the dialysis unit, wash and pat dry your fistula arm thoroughly before each treatment. Then, what are the other precautions? Do not wear tight-fitting shirts. Do not wear jewelry such as bracelets that may restrict the blood flow on your access arm. When carrying things for grocery bag, luggages, make sure that your straps or handles don't tighten around your fistula. When having your blood pressure taken or blood drawn, use your non-fistula arm. When sitting or sleeping, make certain that your head pillows or cushion does not rest on your fistula hand. And check the blood flow through AV fistula daily. This can be done by touch and sound. I think touch is more important for the patient because each one of them would not have access to further sound. When you place your finger over the fistula, you are able to feel the motion of blood flowing through this. This sensation is called the thrill. This is very important. Each patient should check it every day so that if there is a slight decrease in the thrill or absent thrill, they should immediately report to the center. With this, I thank you for the patient listening and hand over the mic to Mary.
Thank you very much, Dr. Renuka. I think we'll come back a little later if we have time on for a Q&A session. But we have Dr. Urmila, are you in a space where you can speak right now?
Yes,
Okay,
I can
yeah.
speak.
Okay, so we'll call upon Dr. Urmila right now, and Dr. Urmila is going to be talking on a very, very interesting, conflicting topic and a very heated topic within our community, the patient community, the challenges faced for a patient who's getting ready for transplant. And I think Dr. Urmila is going to be specifically speaking on cadaver transplant and the paperwork that goes into the process. Dr. Urmila, can I request you to please take over?
Thank you, Marian. And Marian, I really appreciate you joining with us. And Women in Nephrology India is very keen to partner with you and work on this issue about patient advocacy and their voices. I had the privilege of writing up a paper with Dr. Vasundhara about a few months back on Kidney 360 about patients' journey in chronic kidney disease. I do understand dialysis is important. Government of India is doing its best to make access for hemodialysis much more easier, making it financially much more viable. But at the end of the day, for a chronic kidney disease patient, especially young kidney warriors, actually transplant is the option. And whenever the issue of transplant comes, I am aware the trouble that patients go through. First of all, nowadays getting a donor is a problem because we are now many of us are in nuclear families. There is a very young onset diabetes, hypertension, and other non-communicable diseases very common in our families nowadays. When I was a student in Vellore, it was easy to, identify a donor and get a transplant done within 6 weeks. Nowadays, I think that's a pipe dream because you often reject many family donors because of health issues. Most of them have either impaired fasting glucose or even undiagnosed or subclinical diabetes. So these are issues which we face, and we realize a solution to this is actually a deceased donor program. But then you, Marian, know that the deceased donor program is very much heterogeneous in our country. I have worked in Telangana, which actually got the award this last week for the largest donation. I am from Tamil Nadu. I know they do a good job. Karnataka does a lot of work. Maharashtra does a lot of work on transplant. Their trajectory is moving up. But now I am fortunately or unfortunately in a part of the country where what is deceased donation? I mean, we hardly get any awareness and understanding between the patient and the doctor community about deceased donation. And I think the fault lies with us because we don't educate the patient about this viable option. I know it becomes difficult for them because there are not many centers offering deceased donation, and deceased donations are like, as we use the word Eid Ka Chand, it happens every 1 or 2 months. And then we all get up and make a big noise in Delhi NCR. Today, just now, I got a message for an allocation from one of the Delhi NCR hospitals. Like this happens once a week or twice a week. So deceased donation program has to move forward all over the country. And in this, I think kidney warriors have to take a step. They need to, in North India at least, they need to educate the patients that there is an option of transplantation besides live donation. And please understand, live donation is, as we realize now, is not as safe as we made it out before. So we have to choose very healthy donors, and we have to see that nobody gets into trouble. So that's one area, Marian, I think we need to look forward. We need to work together and advocate for a uniform deceased donor policy. Next is the paperwork that we go through for transplants. It's whether it's deceased donation or live donation, the paperwork is humongous, and you have to meet so many people, get documentations done, and each state has its own rules, and each coordinator, the way he is trained, actually decides what is to be done. Just now today, I came to know that a live donation, a family live donation, that is a father giving to a son in Kerala, actually needs a NOC from the state from which the patient is coming. So if you're somebody who's, let's say, a central government employee working in one of the institutions in Kerala, and you are from Bihar, your son has lost his kidney and you want to give a kidney to him, because you are from Bihar, but you are in Kerala, you have to get a NOC from Bihar. And I know these things are not easy. Getting NOCs are very difficult. Then comes the question of, in Delhi, we do a lot of ABO incompatible transplant. Doesn't matter if you don't have a blood group match, get a non-blood group match donor. And for all its advances or improvement that has happened, the cost of ABO incompatible transplant is high. There is no doubt about that. And secondly, we do a lot of ABO incompatible things. When the things move smoothly, everything is fine. But the day the kidney is lost, it is lost. You have no way to get it out. All of us realize that. So it's easy to say that ABO incompatible transplant is a good solution for all this unhealthy live-related donors and let's say incompetent or inefficient deceased donor program. But that's not the solution. The solution again is we have to again, as I'm talking to you, Marianne, because we want the patient's voice to come forward. And I'm being very honest, maybe a little cynical. Patients are what the government's here to. And unfortunately, we don't take their voices to. And patients are the vote bank for whatever it's worth. So we need the politicians to change their thought process, and we need to take it together. But if you want to take it forward to the government, we need your support of all the non-governmental organizations. And I know you have done a lot of work. This year, one of the non-governmental organizations from Gujarat also got a Noto Award for their work on transplantation. And I'm sure you can take it forward, Marianne. So then next comes paired kidney exchange. Paired kidney exchange is another ball game. If you are exchanging two couples, it's always related. You cannot do unrelated. Like I was supposed to give it to my husband, but I cannot give him because of blood group. So I give it to another gentleman. His son gives to my husband and I give it to the gentleman. So everything is related. But even if it's a related program, God forbid, I am from Kerala, my husband's from Tamil Nadu, and somebody else is from somewhere else, you need permissions from all the states. And when you get those permissions, then you need to go to the government of that state and get it permission. Despite the THOA Act saying paired kidney exchange can be done, many states like Gujarat have got the internal authorization committee sort of approve or disapprove for the paired kidney exchange. But I know in Telangana, we have not been able to get it done there. And Delhi and all, paired kidney exchange is non-existent. We think these are areas to make things a little smoother for the patient. And you know, our patients are so sick. And we have, which is so unfortunate, have lost patients waiting for transplants who have had donors. But all the paperwork, all the legality, and small nitpicking here and there, things become, and the number of forms. I realize there are 21, 22 forms that they have to fill, affidavits, notaries, police verifications, everything. I'm saying don't do it because it may be a very important check and balance for doing all those difficult transplants. But despite all this paperwork, all these legalese, we still go on doing, let's say, quote unquote, illegal transplants. So obviously these paperwork have been there in good faith to prevent wrongdoing, but this has not stopped. So we have to look somewhere else to get this process streamlined. And that is something the patient's end. For me, throwing those 10 forms to the patient and saying, get all the permissions and come. And then it's not my job. So the patients, they want a transplant. They're sick. Their family is harassed. What more harassment we are giving to them? So as a community of nephrologists, I realize we have made a lot of advances in medical management, but we have somehow not realized the patient's end of the in transplant practices. And we can make this shorter, we can make it simpler, and let's say the patients benefit a lot. And this is something I think if anybody who has read this article in Kidney 360 has come out very, very clearly from Madam Vasundhara's comments. And there was one thing which patients take objection to, and which I just want to say before I finish, is that comment, which is loosely used in television, movies, everywhere. Oh, I don't have money, let me sell my kidney base. This is something we should not say. This is a dishonor to patients. This is something which we should not use. Just because, I mean, it is not that poverty-stricken people should sell their kidneys. It gives a very bad connotation to the program, and it also sort of makes transplantation, all stakeholders, patients, donors, relatives, doctors, coordinators, hospital administrators, being very wary of the transplant process in general. We need to really look into it, and we need to simplify the process and see that we can check wrongdoing, but not at the cost of patient harassment and patient inconvenience. Thank you, Marianne. Thank you very much.
Thank you very much, Dr. Urmila. Actually, there's an interesting thing that I realized. So I was at the World Transplant Games with my husband this year in Australia. And I was also interviewing a lot of patients from abroad. And say I interviewed about 30 patients. Over there, only Indian patients had live donors. It was only cadaver transplants like majority,
Yes.
at least 90+ percentage of people who turned up there are only cadaver transplants. And
And that is
it was a
another
very
area I
interesting,
think.
yeah.
That's another area I think we need to understand. In India, it is not just living donors, it's a living related donor. And how
Yeah.
you prove the relation is something which is very doubtful nowadays. There is no rule, no clause of, having living donor champions as we have in Australia, United States, everywhere, where altruistic donation in the real sense of the word does not exist in India. Some parts of Kerala does it, but it puts us into disrepute. I have a patient, if that patient's friend comes and says, I want to donate kidney to my friend of 20 years, I cannot do it. The first thing that comes to mind is there is a commercial transaction happening. Whereas in United States, Australia, and everywhere, it is majority of deceased donor, and they have realized that the deceased donor program is actually not enough to cater for the requirement, which is everywhere. Now, I'm sure you're aware that the government of United States Health Services have now actually passed a law saying overhauling their whole deceased donor transplant program. In the next 6 months, the whole system will get overhauled, and they actually ask for donor champions, living donor champions. This is something we don't have in India, because everything that we look at with suspicion. If it's a wife who gives it to his sister, or a sister, I give it to my sister, nobody looks into the financial transaction that is happening. I'm sure that is happening, but it is sacrosanct because 2 siblings have given it. Nobody looks into it. But if a friend gives to my sister, then it's looked with I'm being a little difficult, but these are areas we have to have a conversation about. How do we make our transplant process smoother, less with the negativity, and help patients? We don't have living donor champions, and the government should be thinking of it. There's so many things we need to discuss. Donor healthcare, donor insurance, donor support system, nothing is there. We just have to think a patient comes, a donor comes. If it is a brother, sister, very happy. Old mother, 65 years, gives to a 35 years, don't even worry what is going to happen to the mother, take the kidney. Unfortunately, we don't have a very strong deceased donor program, and we have to pick it forward. The government is doing a lot now. The ministry is doing a lot, but it's in pockets. We want everywhere. Thank you, ma'am. Thank you.
Thank you, Doc. I'll come back later. Actually, I have some questions on that, but I'll come back. So we've heard on dialysis, and then we heard in the process between dialysis and transplants. This is my most favorite topic, and we have Dr. Muthu J. Raman to talk to us on the generic medicines. Doc, so this has been like a discussion that we have almost every day, where patients share their list of medicines, and we still haven't figured out, even the most educated patients, the well-read patients who kind of know their disease pretty well, we've never understood the mother brand and the generic medicines, and why is it prescribed by some doctors? Why is it good? It is not good. We have no idea on that. So what's your take on this topic, Doc?
Thank you, Marian. That's a very, very interesting question. It's always in our mind to not only with the patient, even the doctors are difficult to understand. Because today generic medicines rules the world. 80% of the medicines in any disease are generic medicines, not only in our country, but also in. Can you share the slides? Okay.
Yes, Doc.
How do I move? How do I move? Not moving.
Madam,
How
you
do
have
I
to
move?
share the screen. Now you can press in your laptop up and down, it'll move.
Disable share. Somebody else is sharing, I think.
Can somebody share Madam's slides, please?
Marian, is somebody sharing?
Madam, you have to share.
It's not moving. Comes as somebody else is sharing them. Marian, can you help me?
Yes, Doc. I think we have this group in the name of SJRI. They are the ones who are
St.
hosting
John's
it and they're
Research
taking care of
Institute.
it.
Okay,
They're taking
please.
care.
So while they are at it, generic names are, generic medicines are commonly used not only in our country, world over. And the difference, we have to know what is the branded drug, what is the generic drug. So branded drugs are the ones, they are discovered by the company and work on it, and it makes gets a patency for the drug for about 20 years, and then it does the basic work, research, development.
Dr. Muthu, sorry to pause you. I think are you trying to say our slides are ready?
Slides are not ready, I'm talking.
Enter button, ma'am. We are sharing
The
this.
slides are not moving.
Ma'am, just press enter, ma'am.
Madam, in your laptop, look down. There is a green thing called share. You have
Yeah.
to share that. Just
I
click on
received
that, share.
I clicked it, but it comes, you cannot start screen share while the other participant is sharing. Somebody else
Yes,
is
yes, the
sharing.
host screen. The doctor, the SGRI host screen is still going on, so it's not sharing madam's screen.
Okay,
You have
then
to
you do
unshare.
that. I'll cut it off.
Yeah, madam, you
Ask
can
them to
continue.
share it. Ask them to share it.
Purnima, Renuka, let them share the screen, no? Let them share the madam slide, because there is a SGRI host screen, so that is not allowing madam to share her screen.
Ma'am, we are already sharing the PPT. You
Just share madam
she-
slides. Just share
Enjoy.
madam slides from your end. Madam cannot share because there is a screen already, SGRI screen is already there. So that's why you just share madam share.
Now,
Yeah.
now you can share, ma'am.
Okay, now you share it.
Now you can share, ma'am.
Madam, you share now?
Can I?
Yes, madam.
Yes,
share.
Doc.
Comes entire screen, share.
Yes, ma'am. Click OK, ma'am. Click share.
I'm not
Okay, ma'am.
visual.
Ma'am,
Okay.
first you click the share screen, ma'am. Then entire screen, ma'am. Then click share.
Can it? Shall I
Madam,
put
at
it
your
in
lower end, there is a green thing share thing, no? Madam, shares
I've
icon has
clicked
come.
it. I clicked it. It's not coming.
Madam is clicked, but it is not coming.
No, ma'am. First you click
Actually,
the share
Marian, Madam does the
green
maximum number of Zoom meetings every month. So
Oh,
she's been
really?
using the click share every time. So
Ma'am, the green color button in the share screen is the bottom of
yeah.
the screen.
Shall I
Click that
cancel
button,
it
ma'am.
and click it on?
Okay, ma'am. Now you select your PPT, ma'am. Then click share, ma'am.
I click the share screen.
Yes, ma'am. Next one window to open, ma'am.
It comes as choose what to share.
Yes, ma'am.
you
Yeah,
see
can you choose your
file, sir. You share your PPT, ma'am. Your
Can I do
PPT will
that?
be in the
Okay.
desktop.
Okay.
Your PPT will be in the
Just have
desktop.
to select the PPT. After that, you can click
Okay,
share.
let's come. Can you see my share screen?
No.
No, Doc.
No? This is my PPT. It's not coming.
Madam, you can just say whatever you want to say. That's enough. I mean, I think there is some.
Dr. Muthu, if it's okay with you, can we move on without the PPT? Because this is such an engaging conversation, actually, the generic and the on generic medicine.
My PPT also. so disappeared.
Okay.
Yeah, it's
Okay, and now. Okay,
Now you inform to them, click the next slide. I can-
next
Ma'am,
one.
we slides from here. ma'am.
Who the next one?
Hmm.
Okay. Do I have to change it or? So the
They will
drug-
change it for you, madam.
The question is on about generic vice branded drugs. When we say branded drugs, it's a new drug researched and discovered by a company. The company would apply for patency to prevent other companies from producing and selling the drug. It may take about 20 years. During this period, the company will produce, the drug undergoes trials, phase 1, phase 2, phase 3 trial, and a brand name is given to that, and the company puts it in market to make a profit. And during this time, nobody can use this drug or the name of that. When the patency gets over, by this time the name becomes synonymous with the drug. For example, take Crocin. Crocin is known only as Crocin. Nobody knows it's a paracetamol. But once the patency is over, expires, other companies are allowed to produce a similar drug, and it is called generic drug. Next one. The difference between the brand name and generic drug is, while brand name drug refers to the name given by the producing company, generic drug refers to the drug produced during the using the active ingredient of the brand name drug. Generic drugs will, however, be sold under different brand names, but will contain the same active ingredients as the brand name drug. But with regards to the effectiveness of the drug, generic drugs have the same quality active ingredient as brand names. All drugs must comply with the strict directive and supervision of the Food and Drug Administration, FDA, in the US. In India, it is monitored by CDSCO, that is Central Drugs Standard Control Organization. Next. For example, Cellcept is a drug. It's a brand name manufactured by Roche and Hoffman companies. It was there for long. Most of us have used it initially in the transplant. But once its patency was over, the molecule was used by other companies or allowed to use by other companies, and they come in the names like Celimune, Mycept, Renodapt, and all those things are the generic names. But before they come into the market, before it comes into the market, it has to undergo the test along with the Cellcept about its absorption, metabolism, activity, and the duration of it. It should be similar to the original drug. Then only these generic drugs are approved. Next. And generic drugs are usually cheaper, and very much cheaper. That is why it's very popular and is not used. And when the drugs are cheaper, you are worried about the quality of the drug, because you do not know whether it is as good as the original drug or the quality is compromised. But the monitoring agency, CDSCO, works on these generic drugs and certifies it safe and effective as brand name drugs. As I said, new drugs, your expenses will include the cost of research, patency, development, marketing, promotion. But none of these costs are involved with generic drugs. It just takes the active drug formula and starts producing that. So that's why the generic drugs are cheaper, and so that it is made available to and affordable to common people. Next. So what's the difference between a generic drug and a brand name? About the active ingredient in the brand name is the same in both generic as well as in the brand name. What does the generic drug contain is something called inactive ingredient in the drug to make it different. And FDA or CDSCO is not particular about this inactive drug ingredient in the drug, but they are very particular about the active ingredient. And so these inactive ingredients are different in different companies. So it is important, this is why it is important to look through the ingredient list on the drug label to see if there is any ingredient not good for you. So it's cheaper, it's approved by the insurance, and the cost can be less than 20 to 80%. Different manufacturers give a different name to these drugs. Next. So when you go to the pharmacy, when your doctor gives a brand name, but your doctor permits to buy a generic substitution, you should buy the drug, generic drug, and look at the label that should indicate the active as well as the inactive ingredients of that. Despite the differences between brand name and generic drugs, active ingredients must be the same dose, and effectivity must be same. And if you are in doubt, you must talk to your doctor before filling your drug list and get a guarantee that it's the same drug. You are not to assume drug as the same just by looking at it. It takes an understanding of active ingredient composition to decide. So it is important. Next. Next slide. So the law requires the drug manufacturers should have the same drug with same active ingredient. But different companies gives it different names. And next, please. And each company, next one, uses different inactive ingredients in the drug. Next slide. But it will look different. The drugs will look different in color, different in size, different in shape. It will not, the trade law permits, doesn't allow the other manufacturers, generic drug manufacturers to produce exactly the same like a branded name. So it will be different and it will have a different color also. These are all done by fillers. Next slide, please. By using colors, fillers, preservatives, and they help in describing the size, shape, and color. So that is why when you buy a new generic drug, it is reliable as per the present law. It is very effective. It contains the same active drug. Nevertheless, in a country like ours, pharma companies are mushrooming like anything. You don't know whether they are licensed or not. So it's better you take your drug when you get the generic drug, discuss with your doctor and see whether you can use it or not. That is the next slide. So that is the thing that you can safely take the generic drugs, but see to that you check it with your doctor. It contains the correct names. And that's about the first question regarding generic drugs and branded names. Then the next question was asked was, how does the doctor decide the immunosuppressant drugs in each patient? I think it's mainly related to the transplant. And in transplant, the most essential drug used is, important drug used is tacrolimus, that is a calcineurin inhibitor. Its original innovator is cyclosporin, which when we started transplant, which we are using. But now, tacrolimus found to be a better version of CNI, can be easily monitored and it can be given adjusted to the blood levels. And also it has to be adjusted according to the duration of the transplant. The only problem with the tacrolimus is post-transplant diabetes mellitus, which is more common and it's around 18 to 30% depending upon the patient's metabolism. When tacro is not tolerated, we still use cyclosporin or everolimus. And these drugs are also used in other immunological diseases like steroid-resistant nephrotic syndrome, rheumatoid arthritis, psoriasis, etc. Next. Mycophenolate is the most important drug commonly used, particularly in kidney transplant, very effective with TACRO. Both these drugs together dramatically improve the transplant outcome and survival with to more than 90%, more than 90% survival in more than 10 years, 10 years of duration. So it's very, very great combination used in transplant, primarily in kidney transplant, and in other transplants are also used. Some side effects are diarrhea, gastritis, etc. It is not to be given when there is a liver disease, pregnancy, or infection like COVID. It is also used in other immunological disorders like SLE, IgNS. If you cannot use MMF, there are alternative drugs to use like azathioprine and cyclophosphamide in its place. They also have a similar effect on transplant. Next. And steroids, they wanted to know about steroid. It's one of the wonder drugs used since 1948. When we say steroids, we mean corticosteroids, but there are other steroids like anabolic steroids, sex hormones, etc. It has multivarious activity like anti-inflammatory, immunosuppressive effect, and anti-allergic drug. It is long-term used in kidney transplant for many, many years till the patient leaves. But now the policy is changing and steroid-free transplant management is trending nowadays to avoid the long-term effect of steroid on the patient. It's also commonly used in glomerulonephritis, rheumatoid arthritis. It's one of the emergency drugs in shock drug reactions and also in rejections in transplant patients. It should be avoided in infections as it delays wound healing. During vaccination, when there is a diabetes or hypertension, its use must be limited. Psychiatric conditions, disease like systemic sclerosis, septic ulcer, viral infection, should be in this, steroids should be avoided or reduced in dose. The side effects are weight gain, sleep problem, muscle weakness, mood changes, diabetes, cataract, acne, fluitis, etc. So in spite of this long side effects, steroids is one of the common drugs used in the nephrology practice. Lastly, a word about indigenous or alternative medicines. It's the most commonly used in chronic kidney disease, not prescribed by nephrologists, but taken by the CKD patients. It's very common for them, and almost all of us will know, almost all the CKD patients at one time or other have taken some of these indigenous medicines. Alternative and indigenous system of medicine are popular in the developing world, particularly in Southeast Asia, and it is coming up in a big way even in developed countries like USA, Ayurveda, Siddha, Homeo, and all Nepalese, Chinese medicines are come under this. The source and composition of these medicines vary in different parts of the world, but the essential drug is the herbs and their botanicals are central to these systems. Besides heavy metals like mercury, arsenic or radon. The problem with this drug is it's largely outside the ambit of regulatory control. There is no controlling agent about the manufacture or use of it. Herbal medicines are prepared by quasi-trained herbalists and not tested for safety. Toxicity can occur when a herb with unknown toxicity is consumed along with our regular medicines. It may worsen the toxic state of the regular medicines. Preparations are contaminated with toxic non-herbal compounds or herb potentiating nephrotoxic effect of conventional therapy. They can produce primarily CKD, chronic kidney diseases, and they can worsen the pre-existing kidney disease. Next.
Vincent now.
One of the drugs which is scientifically tested from this drug is which has produced renal injury, reported in association with alternative medicines. That's the best known induced chronic kidney disease. Aristolochic acid nephropathy. The condition is characterized by progressive interstitial nephritis, with a proportion of patients developing urothelial malignancy. This is scientifically done. This drug is analyzed. The toxic compound is aristolochic acid and have been identified both in the renal and urothelial tissues. Recent evidence suggests, I'll finish it now, that AAA contributes even to the Balkan endemic nephropathy. The role of herbs has been postulated in the development of CKD in other parts of the world, especially among the renal population. So public awareness, education, and regulation of the preparation of alternative medicines and a control over the use is absolutely essential to prevent further the use of this drug and prevent the kidney damage further. Thank you.
Thank you. Thank you very much, Dr. Muthu Jayaraman. So, Doc, just to sum up, since we're running short of time, I don't think we'll go into like a proper Q&A session, but just to sum up, something that I would take away from this discussion is, Dr. Muthu, something that I think we'll educate our patients, especially patients coming from the not so privileged backgrounds, to go back and discuss with their doctors when they've been prescribed a certain brand, and dialogue with the doctors in terms of asking for the generic brand, getting the confidence of the doctors, because what I get to understand is the mother brand and the generic brand are equally good, and that's the reason it's been prescribed by your doctors. But there's a subconscious fear of, okay, because this is not the original brand, will it not work for me? And I mean, we can understand those fears, because my husband also does not take the generic brand, to be honest with you. So that's something we'll definitely educate our doctors, our patients, Dr. Muthu, and that's something I'm taking away. Thank you for the confidence that you've given us through that session. Dr. Urmila, something that I would take away from your session is, while we understand all the complexities that are happening over here, we as a community have already been trying to work on a unified system. And I think the biggest challenge we are facing with cadaver transplant is we do not have a unified system in our country. Everybody's working in their own verticals, and the patient is lost in the power game. And I think as patients and as doctors, I think we need to come together, because at the end of this, the only person who has a say, should have a say, and also is affected is the patient. So I think we should talk about how do we work.
Hello.
Hi, Manisha, can you? Manisha, can you mute your session, please? Thank you. So I think that's something, Dr. Urmila, we'd like to, and if women in nephrology would actually like to work with us, and how do, it's not going to make a change today for sure, but if we can start somewhere, and if this voice has to come out from anyone, it could only come out from the patient fraternity. I don't think even the doctors can do anything alone, neither can anybody do anything alone, because this is definitely concerning to the patient fraternity. And even with regards to the paperwork, wrong paperwork that is asked for live donors is crazy. And I just to mention on a forum that my husband had his friend donating, his business partner donating. So I went through the process, and one of those people who came out successfully.
Congratulations on that, son. But I think you must have gone through a lot of trouble doing that. That's the only thing.
I think I just had the universe supporting me. Thankfully, they had a joint bank statement together because of the previous business that was still not closed down. So that really supported us. But however, still for the hospital to even give a go ahead to meet the DME was a big thing for us, because that step does not happen, right? So I think coming from one of the best hospitals in Chennai, and it was the first non-related transplant in our hospital also. I think thanks to our doctor who supported the case, and we proved the relationship of 45 years. But it was not easy. It was not easy. But, you know, when you have to save a loved one from dying, because my husband had an aortic dissection also. So I had to have this done. And Dr. Renuka, something that I would definitely take away from you is the conference that you've given us on CAPD. Yes, we've been working very closely with understanding the developments of CAPD and understanding how peritoneal dialysis is actually evolving in the country, especially for the south of India. We'd like more work in states like Maharashtra. I think we need to encourage nephrologists over there to talk more about it, like it's happening in Tamil Nadu and Andhra Pradesh. But I think north of India, we don't really have too many patients on peritoneal dialysis. We still have no idea for the reason why. But I think the patient getting educated in these parts of the country would really help with promoting peritoneal dialysis. And I think some other place that we're having challenges is the insurance. We do have case studies of a few patients.
We are just running.
This is my last point and I have to make it, so I'll finish with this. Yeah, I never even did a Q&A session. Yeah, and patients with regards to insurance, we have a few patients, but it does not happen that easily, Dr. Renuka. There is persistent follow-up, only then private insurance, even if you go and show them the law and anything, that they're not getting a coverage on private insurance. But we do have few cases and we are working with those patients of how they actually have managed to get their insurance reimbursed. And we're taking inspiration from them and educating the other patients. So that's still work on progress. So, well, that's the end from us. I'd like to thank all my doctors for joining us on this panel discussion. It was really very inspiring, a lot of information to take back to the community. And we look forward to working closely with the women in nephrology to actually make all these discussions happen in reality. So I'm going to request the doctors to please support us with this. Thank you.
Sure.
Marian, thank you very much. Thank you very much. Anytime I'm in Delhi, you let me know. We will help you. Thank you.
Thank you.
Thank you, Doctor.
Madam, for the nice session.
Thank you,
This is
Doctor.
first time we discuss about the patent doubts. So thanks a lot.
Now, I would
Dr. Muthu, I'll come and meet you.
Sure, please come.
Thank you.
Marian, meet us in Delhi also.
Sure. Dr. Muthu is just 2 kilometers away from me, so.
Oh, please do come.
I'll connect with you offline, Doc. Yeah,
sure.
thank you.
We can do some work.
Yes.
Thank you.
We've come to the end of today's program. So we have the last session now, which is the valedictory function. I request Dr. Anita Madam to please come on the dais.